A mesmerizing morning, everyone. I welcome you all to the AlliedCon International Multidisciplinary Conference on Health Science on 29th and 30th March 2024. Organized by BioLeaks and our academic partners, Beneventia Foundation, Chettinad Academy of Research and Education, and Pearl University. I'm sure you had a great day yesterday with us and hope to see the same enthusiasm from all the presenters and attendees today. I would like to welcome our honorable dignitaries and eminent keynote speakers. Dr. Jijo PM, Department of Audiology, Principal and Professor, JSS Institute of Speech and Hearing, India. Dr. Siti Saira, co-founder, Awaken Academy, Malaysia. Mr. Ahmad Mustafa, Senior Product Specialist, Medtronics Hugo, ENT and TS, Sultan United Medical Company, Kuwait. Dr. Shinshan Das, Director, Homeopathy and Psychiatry, Beneventia Foundation, West Bengal, India. Dr. Ayan Chatterjee, Assistant Professor at Department of Allied Health, School of Health and Medical Sciences, Adamas University, India. And our beloved session chairs of Main Hall, Dr. Sinchan Das, Director, Homeopathy and Psychiatry, Beneventia Foundation, India. Dr. Hina Pravansh Rathod, Assistant Professor, Srimad Rajchandra College of Physiotherapy, Gujarat, India. And our session chairs of Hall 1, Dr. Dharmang Vyas, Assistant Professor, Pearl Institute of Physiotherapy, India. Dr. Ravi Jyotikant Shah, Associate Professor, Veer Narmad South Gujarat University, Surat, India. I thank each and every participant and attendees of today to join this wonderful session. Now I would like to invite our keynote speaker of our day, Dr. Siti Saria, co-founder, Awaken Academy, Malaysia. Ma'am, over to you, please.
Good morning, everyone. Thank you very much for the invitation. Thank you very much for being here in a wonderful day today. How's everyone doing?
I request every participant can reply either in the chat box.
Yes, I would like a more interactive session, so you guys can reply in the chat.
Doing well, ma'am.
Glad to hear that. So having said that, let's move into today's presentation. Is my screen visible?
Yes, ma'am.
Give me a moment. I guess everyone is, even the technicalities are having some issues today. Okay, it's visible now?
Yes, ma'am.
Awesome. So very good morning, everyone. Like I mentioned, my name is Dr. Siti Shahira. I'm the founder of Awaken Academy, co-founding of Awaken Academy. So basically what we do is my interest is towards advocating mental health, and hence the reason why I'm here today. Why stigma is important and why mental health is important. So when we speak about mental health and how it has been blooming, we had a pandemic from the year of 2021 up to 2023-ish, right? But after that, the world realized that we are facing another set of pandemic, which was the mental health pandemic. So during this period, there's a lot of patients that came to me, a lot of them that spoke about mental health and the awareness of how it's expanding into the current era that we are living in. So indirectly, COVID has acted as a precedent towards mental health as well. But why is it important for us? Because according to the WHO, the estimated of 970 million people globally were living in a mental disorder at the year of 2019. And this pandemic that happened from the year 2021 has increased the prevalence of mental health issues, estimating with about 26 to 28% of rise in anxiety and major depressive disorders. Keep in mind that anxiety and MDD are just few of the important mental illness that we are facing. So we have mental health problems, we have mental illness, and we have mental health itself. Most of you guys might be thinking, so what is mental health per se, right? Those who are from a medical background or those who are studying psychiatry, psychology would understand this. But
Now it is connected. I'm in the meeting.
sorry. Can everyone else mute their mic, please? Okay. So, like I was saying, so mental health per se comprises of three important things, which is your physical, your mental, and your emotional state. So, all three combining and reaching an equilibrium indicates a good mental health. Unfortunately, the current state of mental health requires an urgent attention because of the significant increase and the significant sudden, I would say, after the pandemic. There's a lot of people that came out and started talking about mental health itself. So stigma. When we speak about stigma, we believe that it's a negative attitude or belief that we have towards mental health or mental illness. And this often leads to discrimination, social isolation, and whatnot when it comes to the stereotypical mentality that humans have against mental health and mental illness has been a direct effect that caused a patient to seek treatment late or even speaking about it per se. So it could be why, it could be due to the misconceptions that they have about mental health, it could be due to media portrayals, or even very simple, the fear of judgment that we have. I am very sure if I ask you right now, among the 20 participants that we have in the Zoom, how many of you guys would openly come and admit that, yes, I think I might have mental health problem? It's doubtful to have even one or two. You might, each one of us, I would say 98% of us, we all have been to a stage where we are stressed, we have mental problems per se, but we are never brave, or we are never confident enough, or when we are not comfortable enough to say that, yes, this is what I'm facing, this is my problem, this is what I'm going through, and you know what, I need help. We are not in an environment where it's safe for us to say this. So this will lead to social isolation. And of course, it's so reluctant for a patient to take medication. And I myself personally, I advocate a comprehensive solution towards mental illness. So I don't believe in only taking the medication. For you to first come out of that bubble of yours is to break it and to seek help. So why is it important, and how can we as a person help towards the changing of the stigmatized world that we are living in? This is where mental health advocacy comes in. So it's an active process of promoting the importance of mental well-being and basically working towards improving the lives of affected with mental illness. So how do we do this? We speak about it. We raise awareness, we speak about it, and we normalize these conversations. Having said that, normalizing the conversation also means having a good support. So interpersonal support, peer support, and supporting community, I would say, plays a very, very important role. And when to do both of this, of course, you need resources. So financial resources, governmental resources, time, place, venue. But you know what? Sometimes we complicate things too much that we don't realize that the gist of it still lies in an individual, and as an individual making an impact towards the whole world. So as a person, how can you help? Number one is the way we think. So improve our thinking pattern, challenge the existing stigma. When a person comes to you and say, oh, look at that person, I think he's going through some mental illness, stop, take a deep breath, and tell them back. Tell them back. This is normal. Everyone in this world is currently facing mental health problems. If it's a mental illness or not, that's depending on the diagnosis that is being given by the physician or the psychiatrist or the psychologist. But when it comes to normalizing the conversation, you play a very important role. And of course, if you are facing this yourself, then the important part of it is to know when to seek help, and just to seek help on its own. So how can you do that? Here, as you can see, I have mentioned few. These are the organizations or the group of well-known foundations or educational platforms that provide help. So as you can see, mental illness offers educational material, support groups, and advocacy opportunities. We have the JET Foundation. JET Foundation targets mental health resources, specifically for teens and young adults. Anxiety Depression Association of America, ADA, also gives a lot of evidence-based information and resources on anxiety and depression. WHO per se offers a global resources and reports on mental health. Now, as much as it is important or good for us to have someone to confide and talk in, it is also sometimes very difficult to have a person who we completely trust. And to have a person who we completely trust, sometimes we take a step back and think, can I trust this person? Can I speak to this person? Or will I be taken advantage if I speak about it? So if you're facing this, then these are the support groups that you can reach out to. So we have mentalhealth.com that offers communities for various mental health conditions. We have the Mighty, a platform for sharing personal stories about mental health. And we have 7 Cups of Tea. So 7 Cups of Tea are quite interesting as well, because they have this online therapy, peer support through trained listeners. So you can also register as a volunteer, and you can also register as a listener. So it's up to you. You can choose whichever platform that you're comfortable in. I'm from Malaysia, and in Malaysia, what we have is we have many more organizations, NGOs that speak about this. So we have MIASA, Malaysian International Association of Mental Illness and Spectrum Disorders, and we have MMHA. So we have many organizations that targets on creating peer support or community that is supportive to just listen to what you are facing. Next, apart from this, we also have mental health GOV. So this is more of a reliable information. So when it comes to informations about mental health, right? Stigma or stereotypes or even taboo, it arises because of lack of awareness and information when it comes to mental illness and mental health. So what these organizations or these platforms provide you is a space for you to check for a reliable resource. So of course we have WHO. WHO gives us all the right informations and statistics, but at the same time, we also have mentalhealth.gov. We have National Institute of Mental Health, and which gives us a research backed information on mental health conditions and treatment. So there's a paper that was established that speaks about prejudice, stigma when it comes to mental health. So I can give you the link after this. You can just click and look into the researches that they have provided pertaining to mental health. And there are also certain podcasts or documentaries that you can explore. Most of us, right, the target groups that we look into, for example, teenagers, we don't really like to listen to people speak or to read. So we are more towards a visual person. So you like to see it animated or you would like to listen to it more. Then you can tune into The Hilarious World of Depression. It's a podcast, or the documentary, The Biggest Little Farm. Here, they spoke about mental illness, depression, and its connection to nature. Now, mental illness, mental health problems. All this is a bubble that we're living in right now. All these informations or all these terms that we have. For us to understand or to normalize this, we need to make the change. We need to start towards advocating mental health. We need to start towards creating the awareness. So how does it happen? How is all this possible? How can we reduce the prevalence of mental illness? How can we create more awareness? How can we create a safe space for everyone? Again, it starts with you, as in you, me, as an individual. Normalize the conversation. Create a space where it's okay for anyone to come and speak. How do you do this? Reduce the judgment that you have in your mind. Stop judging people or stop creating an image in your head when it comes to mental health or mental illness or mental health problems. Stop that. Clear your mind, judgment free, and just focus on creating a safe space for everyone. Next, provide support. So volunteer in any mental health activities, or we have some awareness campaigns. We have, just like how NHR or NHCR, all these platforms, they have a lot of awareness campaigns that they do on a frequent basis. So I'm very sure back in from wherever country that you are from, there's a lot of NGOs that would be able to bring you in for volunteering works. And even if it's too much for you to physically be present, you can still offer your help through online platforms. So like I mentioned, the 7 cups of tea would be able to help. And then there's many more similar platforms out there that you can volunteer and bring a change. And of course, at the end of the day, we all want betterment, right? So betterment does not come free. So if we are able to raise fund or if we are able to raise resources towards advocating mental health, then there's nothing bigger than achieving the goal that we want. So whatever you see right now, whatever that we are facing, whatever situation that your country is in regards to mental health, the changes can start from you. As a single person, yes, you are capable of starting a movement. I would like to end the presentation with something that Glenn Close, I'm very sure some of you guys might have seen her. 1 in 4 people will be affected by mental illness in their lifetime. So asking for help is not a sign of weakness, it's a sign of strength. With that, I would like to thank you. And you can follow me in social media. You can just scan the link there. And yeah, thank you very much. I will be taking questions now. Do you have any questions that you would like to ask me in regards to mental health, in regards to uh, research on stigmas, or anything that you're interested in? By the way, this is the green ribbon, which advocates mental health awareness. So if you see a green ribbon and you're interested to become a mental health advocate, then you can always opt to wear one. Any questions?
I request every participant, if any of the participant is having any questions, kindly drop their queries in their chat box, or else you can unmute yourself and ask your the questions.
You can put in the chat box as well.
On behalf of all the participants, I have a question, ma'am. Like,
Yes,
is
please
there
do.
any specific course kind of stuff to be a mental health advocate?
Okay, for mental health advocacy, we don't have a specific course just yet. But I believe every single person out there can be an advocate if you are interested in mental health. So you don't have to be a psychiatrist, psychologist, but make sure whatever points that you are putting out there is valid. So in the world, in Australia, it started in Australia. There is something called as a mental health first aider program, which is a 2-day program that you can just join virtually as well, I think, in some of the countries. And you'll be able to get this certificate, like how we have first aid programs for medical first aider, right? Just like that, you have mental health first aider program as well. So check in your countries, specific countries, wherever you're from. In Malaysia, we have MMHA that does this. In anywhere else, you can just look for it. It's a mental health first aider program. So this program will be providing you with a gist of whatever informations that you need, solid, valid informations, not those half-baked information, not the ones that you see in social media, not the ones that unrelated expertise people speaking about. No, this is valid, and always, always, always look for a place where you can validate your informations. Never listen to the social medias and whatnot. So you can try Malaysian mental health first aid program. And otherwise, for public per se, I advocating, no, we don't have any specific course.
Okay, ma'am. Thank you. Thank you, ma'am. Thank you so much for your informative session. Actually, it's an interesting topic to see.
Thank you very much. Thank you very much. I hope it was informative and beneficial for everyone. And thank you for the invitation.
Thank you, ma'am. Now I would like to invite our next keynote speaker of our day, Dr. Jijo PM, Department of Audiology, Principal and Professor, JSS Institute of Speech and Hearing, India. Sir, over to you, please.
Morning. Can you hear me?
Yes, sir. You're audible.
Yeah. I'm going to share my screen. Is it?
Not yet, sir. Yeah, now it's fine.
Yeah. Can you see my screen?
Yes, sir. Yes, sir.
Yeah. Shall I start my presentation?
Yes, sir, please.
Okay. I'm Dr. Jijo Matai. I work as a professor of audiology at JSS Institute of Speech and Hearing, Dharwad, Karnataka. My topic of presentation is audiology, an allied healthcare profession. I thank the organizers of Allied Con, International Multidisciplinary Conference on Health Sciences, for inviting me as a person to deliver keynote address. So in my presentation, I'm going to talk about the profession, which is called audiology, and what work an audiologist do, and what are the current areas of work they perform. So audiology is a relatively young profession. It started during the World War II. So at the time of World War II, there are many servicemen. They came back to US having hearing loss due to exposure to loud noise during the wartime. So US government, they established some program to perform hearing assessment and to provide some form of rehabilitation to these war veterans. So this is how the profession started during 1940s in the United States. I would like some of milestones, a major milestones that have shaped our profession to today's condition. So in the beginning, during 1943, there was a person called C.C. Bunch. He is the first person to write a book on audiology that is called clinical audiometry. And he has worked for more than 20 years and published many research presentations. He was the one who is instrumental in developing first audiometer that was used for performing hearing assessment. The instrument is known as Western Electric 1A audiometer. And during 1946, an army captain, his name is Raymond Carhart, who is later known as father of audiology. He utilized the speech audiometry, that PB words, we call it phonetically balanced words, to perform assessment of candidacy for hearing aids and to perform the patient performance using such words. So another major milestone compared to any other field in the electronics, it was transistors. So earlier, the hearing aid, which were utilized in the field of audiology, they were earlier hearing aids were vacuum tube based hearing aids. They were bigger in size and they were utilizing so much of battery power. Soon after the invention of transistors, the size of hearing aid tremendously reduced and battery consumption also reduced tremendously. So it was a major milestone. During 1963, it was a person called Marian Downs. She started the first infant screening program in the United States. So until then, there was no any program for the early identification of hearing loss in young children. It was Marian Downs who started the program. During 1964, another major milestone that was development of an immittance meter by Metz and his colleagues. The instrument is even used today for the assessment of middle ear status. And another interesting story of Barry Elpern, who is a person who started the first private practice in United States in the year 1968. And by the American Speech and Hearing Association, known as ASHA, they removed him because he has started such a dispensing of hearing aid, which they found to be unethical. And now the private practice is one of the major sector that is giving employment in the United States as well as all over the world. So he was a trendsetter. During 1971, it was by Donald Jewett invented auditory brainstem response. This test is used even today for the early identification of hearing loss in newborns, young children, and difficult to test population like children having mental illness, autism spectrum disorder. Any difficult to test population, we can use it as a objective test for hearing assessment. Another major milestone was discovery of autoacoustic emissions. This was by David Kemp, who is a physicist from the United Kingdom, who invented autoacoustic emission. They were later used it for infant screening, early identification of noise-induced hearing loss, monitoring the status of outer hair cell function in case of ototoxicity. So this is very briefly through the history of our profession. Let us see what do of practice is to provide patient-centered care in prevention, identification, diagnosis, and evidence-based intervention and treatment of hearing, balance, and other related disorders. So let me take you through what work we do. We perform assessment of hearing, balance, and other disorders. For that, we have a battery of tests, which include behavioral tests, such as pure tone audiometry, speech audiometry, and we do have many physiological tests, which does not require any response from the subject. Like subject can be either sleeping or they just need to be very quiet. So we have tests like auditory brainstem response, autoacoustic emission, we have immittance audiometry, and we have many tests for balance disorders. They are objective. We do perform comprehensive rehabilitation services for hearing, balance, and other related disorders. We have, with the advancement of technology, we have many devices like hearing aids, cochlear implant, bone-anchored hearing aids, we call it BAHA, and tinnitus maskers. All of them, they provide rehabilitation services for various hearing-related conditions. We do perform infant screening that help in early identification of hearing loss. Audiologists provide hearing services in school setup, especially when it is an integrated school having children with hearing problem. The role of audiologist is to help that child in terms of his hearing aid, assistive listening devices, and to provide classroom acoustics, preferential seating. All that comes into our work. And we do work in prevention and management of noise-induced hearing loss. Nowadays, due to noise exposure, many young people as well as uh, uh, senior citizens, they develop hearing loss, especially because they are working in a noisy environment, or it can be because of some recreational activity like exposure to loud music. They develop some form of hearing loss. So we come in there, we can perform the identification of hearing loss and to give them management. And telehealth is a promising area for audiologists, where we do provide a diagnosis and a treatment of various hearing related problems through online uh, uh, modes of service delivery. Another role of audiologist is to conduct a need-based, very basic and applied researches. So there are lots of research work that is happening in the field of hearing, balance, disorders, where audiologists are involved in research activities. And audiologist is also play a major role in academic programs in various institutions, in healthcare sector, in private practice. They are involved in training or human resource development. And another major area of work is advocacy, where we provide legal uh, advocacy to institutions or some professionals or in the government sector. So a lot of demand is there in that sector too. So in my presentation, I'm just discussing about three different areas of work. They are in the current trend, like newborn screening, cochlear implants, and vestibular assessment. These three areas, they are seeing tremendous growth in our clinical practice. So let me take you through universal newborn hearing screening program. So many of us, we are aware that in the absence of early recognition, a child who is having hard of hearing can experience delay in speech and language development, academic achievement, social and emotional outcome. So early identification is a very important criteria for the adequate development of speech and language skills. It was during 1980s and 90s in the United States, they started first infant screening program. So there is a committee. So it is a non-profit organization of many professionals such as otolaryngologist, a pediatrician, audiologist. They have a committee called Joint Committee on Infants Hearing, JCIH. So they have a position statement which was recently published in 2019, where they have set a goal of 136. That means hearing screening should be conducted at the first month, and diagnosis should be conducted in third month, and rehabilitation should be started by 6 months. And many of the United States, they have achieved this goal, and now they have a new target of 1, 2, 3 rule. So where hearing screening should be performed in first month, diagnosis should be performed in second month, and treatment like a hearing aid, cochlear implant, it may still take some more time, but hearing aid rehabilitation should be started by 3 months. So there are many high risk factors that can lead to hearing loss. They are prenatal risk factors such as family history of hearing loss, admitted in NICU for more than 5 days, history of hyperbilirubinemia, aminoglycoside administration for more than 5 days, asphyxia, intrauterine infection like herpes, rubella, syphilis, toxoplasmosis, and craniofacial conditions. If any of these risk factors are involved, there is a high chance for the child to develop some form of hearing loss. Another uh, risk factors, they are postnatal risk factors. They can be a bacterial or viral infection during perinatal or postnatal period, and any history of head trauma, especially in the mastoid region, or any concern by the family members or caregivers regarding the hearing, speech, and language development of the child. So if a child is involved with any of these risk criteria, there is a high chance for development of hearing loss. So I would like to say in my presentation, where there is an audiologist is involved and there are hospitals, we need to develop our own infant screening programs. So so what are the requirements for having a newborn screening program in any setup? So we need to have a person who is trained to use the equipment. It need not be an audiologist always. An audiologist can train a nurse or a lab technician to use devices that can be used for hearing screening. So the screening should not be performed very soon after birth. They say it need to be performed after 3 to 6 hours after birth, because there can be a chance of fluid in the ear canal or in the middle ear. So the screening, what we do is we usually perform screening prior to the discharge from the hospital, so that the ear canal is dry. Chance for false positive responses are very less. Now, the environment should be relatively noise-free. We don't have to have a sound-treated room like in an audiometry room. We can perform hearing screening in a quiet environment. And we need to set the pass or refer criteria. So that depends on the equipment. So we have two different equipment. One is automated auditory brainstem response, and another one is autoacoustic fusion. Automated auditory brainstem response is a device that can be used to detect the response from the neural. It is actually assessing the entire auditory major part of auditory system, but it comes from the auditory nervous system, especially from the brainstem part of the auditory nerve. So this test is assessing a larger area of the auditory system, and it is resistant to any kind of middle ear infection. So these are the advantages of auditory brainstem response. There are always limitations, like it is an expensive equipment. It takes more time compared to autoacoustic emission. So another equipment we have is autoacoustic emission. They are actually assessing only the pre-neural functioning, that is about outer hair cells. So we don't know about the nervous system functioning in the auditory system if you do OAs. So it is always recommended to use a combination of auditory brainstem response and autoacoustic emissions in infant screening. So we need to develop our own protocol. And protocol vary depends on well baby nursery or NICU. If the child is in a well baby nursery, we can perform an OA screening. If the child passed the screening, then you look into any risk factor. If there is no any risk factor, which I have mentioned in my earlier slide, they are involved, you can send that baby home. But if there are risk factors involved, the baby need to be sent to an audiologist for counseling or rescreening at a later period. If the baby is refer in the first screening of autoacoustic emission, if it comes refer, then we need to perform a rescreening. Okay, so the rescreening, they say a 2-level screening need to be performed. If the rescreening results are pass, then no risk factor involved, the baby is considered to be pass. Risk factors are involved, then the earlier procedure need to be followed. So if the baby is in NICU, we have a different criteria of screening. If the baby is in NICU, it is always recommended to use an automated ABR screening. And if the baby passed the screening, no risk factors are involved, then you can tell that the baby is finished the screening. But if there is any refer coming, we need to directly send that baby to an audiologist. We don't have to wait for rescreening, because the baby was already in NICU and the results are showing refer. We need to send the baby to an audiologist. So I strongly suggest be any hospital where availability of audiologist is there, we need to develop our own protocol for infant screening, and we need to perform infant screening. Another area where audiologist is in great demand is cochlear implant. So many of us have heard about cochlear implant. It is an electronic device. It is an option for people who have severe to profound hearing loss due to inner ear damage. They are not able to use their hearing aids. So unlike hearing aids, which amplify the sounds, a cochlear implant bypasses the damaged portion of the inner ear and delivers sound to the auditory nerve. As you can see in this picture, there are two major uh, divisions. One is an external device, one is an internal device which is surgically implanted. The external device is having a speech processor and a transmitter coil, which will convert the speech signal into electrical and radio frequency signal, and it will be transmitted to the inner components. In the inner ear, we have array of usually 22 electrodes that will be implanted inside the cochlea, so that the neural stimulation that happens. And cochlear implant is recommended for children above 9 months of age having severe to profound hearing loss. They are getting very limited benefit from amplification. And it is also recommended in adult senior citizens having moderate to profound hearing loss. They are having limited benefit from amplification. So an audiologist is part of this cochlear implant team. So audiologists perform assessment of candidacy, assessment of aided performance in that child, whether the child is getting benefit from the hearing aid or not. And we do be part of intraoperative monitoring. So when the surgeon is performing surgery, when they insert the implant inside the cochlea, so the implant will be connected using an interface to the computer, and the audiologist will perform neural response telemetry to monitor the status of the eighth nerve and to look for the response from the eighth nerve. So once the responses are adequate, then and it comes from almost all the electrodes, then only the surgeon will close the procedure. So it is a major role of the audiologist. And soon after implantation, we do perform switch on and counseling. And we are involved in rehabilitation of children who are implanted. We call it auditory verbal therapy. and we monitor the progress. We are also part of pre and post-operative counseling. So in my presentation, I would like to talk about the cochlear implant program that is happening in our country. In many of the states like Kerala, Karnataka, Tamil Nadu, and Government of India, we have government-sponsored programs running in different part of the country. And as we see that sustaining the program is really a challenge, because the government is giving money for implantation and implantation is happening. But after implantation, it is almost 2 years of time. The parents, they have to literally spend a solid amount of time on rehabilitation, care and maintenance of the hearing aid. All that becomes their responsibility. Though government is giving some financial aid, availability of services in many places, what happens is the village people from the village, they are getting implanted, but to commute to a rehabilitation center is challenging for them. They have to really relocate and stay in a place where the services are available. That is a challenge they face, and there is attrition because of this problem. And parental education and motivation is a very important factor, because there are financial involvement. Parents, they do have to really spend time, money on service of the equipment, device, battery. Though there are rechargeable devices given, sometimes what happens is, if there is any damage in the battery compartment, speech processor, it is a huge amount that first 5 years or 1.5 years, the company will provide uh, uh, some service. But after that, it becomes a responsibility of the parent. For sustaining the program, an audiologist really need to look into some financial assistance from some CSR funding or government organization, so that these poor people, they get some kind of financial assistance, so they can use this device for a longer period of time, or throughout the lifetime of the child. Another area where we do work is assessment and treatment of balance disorders. So nowadays, it is very common that many people, senior citizen as well as younger age group, they suffer from different kind of balance problem. They are either due to central nervous system problem or peripheral balance disorders like vestibular neuritis, labyrinthitis, Meniere's disease, and benign paroxysmal possessional vertigo, vestibulopathy following surgical procedures. All that is leading to balance problem. They are peripheral balance disorders, and there are central dysfunction that leads to balance problem like brainstem stroke, head trauma, migraine related vestibulopathy, multiple sclerosis, cerebellar degeneration. Such conditions can also lead to balance disorders. So we audiologists, working as a team involving ENT professionals, neurologist, audiologist. So we have a battery of tests. They are either behavioral or physiological tests, like Romberg test, Fukuda stepping test, tandem gait test, to differentiate whether the person is having a peripheral vestibular disorder or a central vestibular disorder. Once the condition is differentiated, whether it is peripheral or central, we have effective rehabilitation method like adaptation technique, substitution technique, habituation technique. So in adaptation technique, we encourage them to adaptation of the remaining vestibular system to certain stimuli like head movement or changing the body position. And substitution exercises help them to use other senses like visual system, somatosensory system to compensate for the damage in the peripheral vestibular system. We have habituation technique where we are giving very short-term stimuli. Actually, they are noxious stimuli. That means they can trigger some kind of giddiness, but we are trying to slowly habituate them to any kind of vestibular disorder. So in my presentation, I would like to say that we can, if there is an audiologist and ENT or neurologist available in your center, you can start thinking about a vestibular clinic in your center. Yeah, we can think about setting up a vestibular clinic where we can identify whether the problem is a peripheral vestibular dysfunction or a central dysfunction, and we can give them vestibular rehabilitation So many vestibular conditions like benign paroxysmal positional vertigo, they have very effective intervention method where the subject can be trained, and he will get rid of this giddiness, which is a very disabling condition. So with this very brief keynote address, I would like to conclude my presentation. Just to summarize, audiologist is involved in early identification, prevention, assessment, and rehabilitation of hearing balance disorders across age group. So wherever there is an audiologist available, we can make use of his service for early identification of hearing loss, infant screening program, school screening program. We can identify the hearing loss early, and we can provide us rehabilitation through hearing aids or cochlear implant. And young children, especially if it is identified early and provided rehabilitation, they can develop speech and language skill, and they can go to a normal school. So especially in cochlear implant, success rate is very high, where 80% of the children implanted, they early period, they do go to a normal school and study like a normal child. They don't have to go to a special school. And audiologist, we are involved in assessment and treatment of balance disorders, assessment and treatment of tinnitus and hyperacusis. So it is a very potential area of work, and lots of services can be provided where audiologist is available. And this is a very promising profession which has got scope of practice in the entire globe. So we have a training program in our institute in Dharwad, JSS Institute of Speech and Hearing, where we have students from all over India. They do come and study this bachelor's degree, and they can go for master's also if they are interested, or soon after bachelor's, it is an autonomous profession. They can start their own private practice, or they can work with an ENT specialist, or they can work in a hospital setup, they can work in a school setup. So there are lots of options available. So with this brief keynote, I would like to thank the organizers for giving this opportunity. And I am concluding my presentation. If you have any questions, you can ask.
Thank you, sir. Thank you so much for your informative session. If any of the participants is having any queries regarding the presentation, kindly drop your queries in the chat box, or else you can unmute yourself and ask the queries. I guess there are no questions from the participant side, sir. Thank you.
Yeah, all right. Thank you so much. Thank you.
Thank you, sir. Now I would like to welcome our next keynote speaker of the day, Dr. Ayan Chatterjee, Assistant Professor at Department of Allied Health, School of Health and Medical Sciences, Adamas University, India. Dr. Ayan.
Yes, good morning. Am I audible?
Yes, sir, you're audible.
The voice is little bit. Make it further. Give me a 1 minute. Yeah. Good morning. Shall I start or?
Yes, sir. Please start sharing your screen and your presentation.
Can you make it a little bit louder? Your voice is a little bit slow.
Am I audible now, sir?
Not clearly, but you're audible, but your sound is not.
Okay. Is that good now?
My side. Just give me 1 minute. I'm checking. So shall I start?
Yes, sir, please.
Okay, thank you. Yeah, very good morning to all of you. Thank you so much for giving me the opportunity to deliver as a keynote address on this Allied Conference, International Conference on Allied Health Sciences, organized by the BioLeaks. And thank you so much, the CEO of the organization BioLeaks, Mr. Shatpati sir, and thank you so much his team, Gopika ma'am, and the other her colleagues, those who are directly and indirectly related with that conference, and to make the conference more successfully. So without delay, I'm moving forward to the presentation. This is based on the theme of the conference. Parallelly, I like to deal with a few of the subject where the Allied Health Conference Allied Health is lacking in the global scenario, and as well as in the scenario of the Indian context, and where should we must be improved for the betterment of the health services or the health providing. So the title of that my presentation is Expanding the Medical Horizon with the Allied Health Sciences. Let us start with that health. As we all know, the health is a state of complete physical, mental, social well-being, and not merely the absence of disease or any other particular infirmity. This is the definition of the health as per the WHO, World Health Organization. And as per the report, the World Health Organization, the global economy is expected to generate 40 million new jobs that will be the health industry by 2030. So from that context, we can expect the people will be expecting more job in the health sector, particularly in the hospital industry, as well as in the academia field, as well as in the research field also. The necessary for healthcare services, rising the beneficiary expectation, and people are expecting more from that healthcare sector. And this is a very greater demand, have all contributed to current rapid expansion of this global healthcare system. Before COVID, few are the institutions they are providing the training in the graduation and the post-graduation in healthcare or the allied health. Earlier it was called as a paramedical. Now from the government of the India, Ministry of the Health and Family Welfare, we are offering the course. The name of that or the nomenclature is Allied Health Sciences. So to begin with that, we understand what is the allied health professional and whom should we call the allied health professional. The workforce in the health and human services is incomplete without allied health professionals. That means the people, the doctors and the medical practitioners, they are actually depending on the allied health people, those who are directly related with that particular healthcare sector. And they are very essential for the industry, care for the delivery, and they are providing the positive health and well-being result, and which is very important for physical and the mental health. I would like to share a few of the things when we are going for a regular checkup, like the blood or like the stool sample, urine sample, or any hematological test or any biochemical test. Firstly, during the screening or after the screening, when the result we are getting in a output result or hard copy result, we are asking that people who is giving me the result, what is my value, whether it is elevated or it is the same with that range which is required, that is we call the reference value, or it is less than the requirement. So you are believing on that particular individual who is actually getting the sample from you, who is collecting the sample from you and doing the beneficiary result, and after that giving you the ultimate output. So here I would like to share that even me also, being a medical practitioners and the doctors, we are also firstly expecting and believing the allied health professionals. If it is a physical or is a mental or the chronic disease, disability, rehabilitation, forensic health, public health, everywhere the people, those who are related, we call them allied health professionals. And this is a very essential component in this particular era of the health sector. And During the COVID scenario, 2020, 2021, 2022, lots of report where we find the importance of the allied health people and where the India is lacking, not only the India, the global and the all over Europe, all over America, the people are affecting because the lacking of the manpower in the allied health sector. And if they have the country having the people, they are not so much experienced with that kind of the experiment. So a vital component providing safe and the efficient health services, allied health people are giving that particular thing and care the benefit of the community. So where they know where should giving them more care, and they played a very good role model for the practitioners, leader, and the other career connectors. Few potential numerous diverse allied health job pathways shown by the design of the healthcare pathways. Different allied health courses are right now available: medical lab technologist, and this is also called the medical laboratory sciences. Then we have the optometry. Then we have the cardiovascular technology. We have critical care technology or critical care. We have physiotherapy. We have clinical psychology. We have anesthesia technology. We have operation theater technology. We have cardiopulmonary technologist. We have dialysis technologist. We have emergency medical technologist. We have radiology and imaging technologies. So diverse field is presently available. It is nothing like the people who is collecting the sample or the blood sample, he also doing the ECG. No, people are right presently the blood sample, the people who is collecting, either he is a DMLT diploma or that persons will be a graduate BSc MLT, and the person who is doing the ECG, he might be from cardiac care or might be from the your cardiovascular technology. So it is nothing like earlier the people having same field and they are doing the same kind of the test. Presently different kind of diverse field is there, so people are doing that particular course and they are doing the internship, and after that they are getting placed in different hospital as well as in the healthcare sector and industry. And this is also part of the career development. People are doing masters in that particular field also. Those who are target in the academia field, or they have a target in the research and developments or the R&D sector, and people can expecting in the R&D sector and the research field or in the academic field, there might be a better career option than the hospital or the healthcare sector. As already I have mentioned, it is a vital component in the healthcare team. Allied health professionals offer wide range of therapeutic, diagnostic, technical, rehabilitative, and direct patient care services, which already I have mentioned. They contribute the seamless operation of the healthcare system. Without that, the healthcare sector is delayed and they will not do their regular screening or the ultimate final their target goal to remove that particular disease from the body. So without the allied health, without the doubt we can say the allied health professionals, the healthcare and the other support enable to the medical team to collaborate with the patients more effectively. They receive the training from specialized and supplementary services in each course. The last semester, there is an internship for 6 months, and particularly some of the institutions, they are offering 1 year internship and during the course also. So it is nothing like it is only the particularly academic related, academic as well as it is also skill based. So they have a chances of the internship, patient dealing, how to treat that particular disease, and each and everything, the close relationship with the particular hospital and industry and academia field. So this is nothing, they do not have the hands-on experiment techniques, they also have the hands-on experiment technique as well as they are doing the other support also. So we can say they are the cornerstone of the healthcare team and support the allied health professionals, and they are essential in provision of the healthcare in the related service. They collaborate with the medical expert, specialists in the interdisciplinary field also, and allied health professionals needed to be primary areas in the therapeutic, the preventive, promotive, diagnostic, and the relative other field. They treat and attending the patient physical, mental, psychological, and particularly the overall well-being. So in a context, we should understand the what is they are dealing. They basically do the patient care. They collaborate in order to prevent, assess, and treat the disease, as well as to prevent and manage the patient disorder and the disability. They support the patient in a higher quality of the life. They provide who are the not medical specialists, and they are identify, they are dealing their problems, their knowledge, accountability, hands-on patient care, enhance the particularly healthcare sector. Obviously, already I have mentioned they provide the clinical support. This clinical support including the critical care support, intensive care unit support, the other support which is needed. Parallelly, they are the busy in the medical support providing for smooth patient care, and the allied health people they are assisting the medical professionals, which is enhance the general result of the public health. Last but not the least, the social and the psychological and environmental well-being. This is actually extended beyond the practicing medicines. They cannot write, allied health people, they cannot write the prescription, they cannot provide the medicines, but they are providing the initial screening. They are actually important for the social context, and parallelly they are providing the particularly the children, the elderly, geriatric people to a better quality of the life, as well as they are helping in the doctors. So this is what I am trying to say, to promote that. Don't think they are the allied health people, they are beyond that. They are also helping each and another in different sector. They are helping in the interdisciplinary sector. Their basic job is to promote and how to create how to prevent that particular disease and how to eliminate that disease from that particular, which is actually creating the problem. The screening as well as their main identification is to promote the good health socially, psychologically, and from the mentally, definitely. So thank you. That is from my side.
Thank you, sir. Thank you so much for your informative session. If any of the participant is having any queries regarding the presentation, kindly drop your queries in the chat box, or else you can unmute yourself and ask the queries. I guess there are no queries from the participant side, sir. We'll move on to our next speaker. Thank you, sir. Thank you so much. So our next presentation of our day is by Dr. Sinchan Das, Director, Homeopathy and Psychiatry, Benevolentia Foundation, West Bengal, India. Sir, over to you, please.
Good morning, everybody. At
Very good
first, I
morning, sir.
felt, thank you so much. At first, I want to show my heartfelt gratitude to all of the participants and the keynote speakers and my colleagues all are presented here. Before going to discuss, I will share my screen. Is it visible?
Yes, sir, it's visible.
today we are facing so much problems, so much and newer problems in the health sectors and healthcare fields. And
Sorry
this,
to interrupt you, sir.
yeah,
Your slides are not on a full screen mode.
okay. Is it in the full screen?
Not yet, sir.
Now is it in the full screen?
Not yet, sir. Now I could see only half of the screen. Kindly reshare, sir.
Is it full screen?
Not yet, sir. So at the down corner, you could see the 77 number beside there is icon, right? Kindly tap on it, sir.
Yeah. The list of participants, right?
Yes, sir.
Yeah. Then
Okay, so we'll continue in this mode itself.
fine. So in this time, we are facing so much problems and newer problems, whatever we are encountering in our daily practices, where the emerging threats are the cardiovascular disorders. It is not about the emerging threat only, rather, it is the threat of the modern society where major mortality rate is concerned. But whenever we are inquiring the multiple etiological factors for the pathological conditions, we usually find there is a missing gap, there is a missing link actually. And that gap is very much pronounced, and that gap is alarming also. Because our health parameters containing the psychological health, physical health, and social health, as you all know that. But whenever we are practicing in the daily life, in our daily practices, we actually forgot the psychological health and collective social health, because we are too much considering, too much concerning about the individual physical health only. And this individual physical health consideration, the consideration of this individual physical health is half truth, where the major concerning factors which are controlling ourselves, that is our psychological health, is going to be overlooked. And whenever individual psychological health is not concerned, because it is a cycle, it is an interlinked cycle, the physical health is not going to be optimum. And when the physical health is not going to be optimum, we can say that the productivity, that means the collective health of the society, will not be optimum. So before considering the physical health only, we have to consider the individual psychological health, even the thought pattern of the individual, how to think, what are the patternistic errors in the thought, what are the models he is thinking or she is thinking of, and how he or she is going to process their emotions, how they are going to express their emotions, etc. So these are very important factors in diagnosis and managing the physical health or physical pathological conditions. Today I am going to emphasis on the cardiovascular disorder, and where I will include all the related pathologies also. So the occurrence of these psychological alterations in this and cardiac diseases in the many patients exemplifies the complexity of the psychosomatic and somatopsychic effects. The psychosomatic means where the pathological conditions originated from the psychological background and afterwards it affects our physical health. In somatopsychic, where our physical health is concerned in the primary manner, as a result of that, our psychological health going to be impaired. Although this understanding of psychology of a person is very tough job because it doesn't have any clear parameters, it doesn't have any clear biochemical scales, the biochemical range where you can say that yes, the person is suffering from this or the person is thinking like this. For that reason, you have to consider their body language, their ideological findings, their way of thinking, their postures, their gestures, their choices. It is very important factor, their choice. How a person is choosing themselves, what color he or she is choosing, in what manner they are talking of, how they are sitting, what is their choice about dresses, their hobbies. Everything is of very utmost importance whenever we have to consider their psychological health. Whenever this health scenario is concerned, how the psychological parameters or psychological phenomena is operating our physical health. When the psychiatric mechanisms are there, that psychiatric mechanisms means the unconscious and subconscious electromagnetic waves, they are going to transduced, and after the transduction of that, they will encoded in some altered manner after the bottleneck processing. After that, the neuropsychoendocrinal axis will be activated. That means the nervous mechanisms, the way our psychiatric mechanisms occurs, the way our psychiatric mechanisms operates, our neuronal firings will be designed accordingly. And when that neuronal firings are designed, it will modulate our neuropsychiatric mechanisms. As we all know, there is hypothalamo, pituitary, adrenal, thyroid, testicular, and ovarian, and numerous axes. So those axes are governed by the hypothalamus, and the hypothalamus is closely related with the processing units wherever the visual cortex is concerned, and the information is carried and stored in the thalamus, and frontal cortex, prefrontal gyrus is playing an important role, pineal gland is playing an important role. So these phenomena are collectively working in the modulation of the physical mechanisms or the endocrinal mechanisms. And when this endocrinal mechanisms is concerned, multiple physiological and pathological phenomenologies are operating, like the inflammation, like the cell defense mechanisms, like our homeostatic mechanisms, our hormonal firings, our different hormonal feedback systems, and etc. much more. And as a result of that, these excessively multitasking capability of the body, huge amount of turmoils are going to be occurred. And when this initiation is there of the innumerable psychological and psychosomatic phenomenological errors, it will create a series of disharmonious conditions. And for the correction of these disharmonious conditions, we have to consider all the steps, I must say, all the steps with equal importance. If we are encountering a person is suffering from frontal headache, then we have to consider the ophthalmological consideration, the sinusitis, their migraine, the history of any others, their gastroenterological turmoils, their depressive phases, their mental conditions, their stress levels, and etc. So that we can differentiate between the pathological conditions so that we can get the appropriate results and the basic factors, whatever we can see, whatever we have to investigate it, and whatever we have to diagnose. So the importance of the parameters are of equal importance whenever we have to investigate and diagnose any of the pathological conditions. Now, rather than other factors, as our topic of discussion is the cardiovascular diseases, so we have to take a short snap about the nerve supply of the heart. All you know that the main control of the heart resides with the medulla oblongata. And this area is called the cardio accelerated center or pressure center. In the upper part of the medulla oblongata and an area called the cardio inhibitory center or the depressor center in the lower part. Together they are called the cardio regulatory center, since they interact to control the heart rate and etc. The nerve supply to the heart is autonomic, consisting of both sympathetic and parasympathetic parts. The sympathetic fibers arise from the pressure center, while the parasympathetic fibers arise in the depressor center. So you can understand that the depressor center is basically constituted by the parasympathetic fibers. So cardio inhibitory actions are basically mediated by the parasympathetic fibers, and the cardio excitatory findings operations are basically mediated by the sympathetic fibers. The sympathetic nervous system acts on the sinoatrial node, which is rich in the pacemaker cells. The pacemaker cells are readily firing the readily generating and modulating the electrical currents. The ionic exchanges are taking place in a very speedy manner, and that's speeding up the depolarization rate and therefore increasing the heart rate. The parasympathetic system works in the reverse in order to slow the heart rate down. The heart itself has a natural pacemaker. The sinoatrial node, which doesn't need a nerve supply for function, but they have that capability to depolarize and repolarize by the means of generating resting membrane potential and action potential. If you serve all the nerves to the heart, then it will continue to beat. In fact, it will beat faster than normal, since there is normally a parasympathetic supply slowing the heart down. The sympathetic fibers arising from the superior, middle, or inferior cervical ganglia and the parasympathetic fibers which originate in the medulla oblongata and pass down by way of the vagus nerve join the cardiac plexus. From here, they enter the heart. T2, T3, and T4 are the intercostal nerves whenever it comes to the splanchnic nervous plexus. The sensory component of the sympathetic supply to the heart passes to the same sensory route as these, hence feeling a band of pain across the chest when having a heart attack. T1 is dragged into the upper limb, hence the referred pain in the arm during the heart attack. The pain is more usually felt in the left arm, since the heart is more to the left than the right, but it is not impossible to get pain in the right arm during a heart attack. Not only the right arm, even we can see the pain is felt at the middle portion of the back, that is along with the medial border of the scapula. Now, what are the chemical controls of the heartbeat? In the regular practices, whenever a person is working in the OT or working in the critical care setup, you all can experience the role of adrenaline, noradrenaline, because this adrenaline and noradrenaline is very much important in the emergency management. And not only the adrenaline and noradrenaline, the thyroid hormone also playing an important role in the modulation of sympathetic nervous system. That means in the modulation of the cardio excitatory nervous actions. And whenever the inhibitory actions is concerned, that means activation of the parasympathetic system, it is controlled and mediated by the acetylcholine. Now, what about the anatomical connection between the psychological as well as the organic system of the heart? We all are considering the nervous system only, but whenever the psychological system is concerned, there is a direct connection established between the basal forebrain, hypothalamus, and medulla oblongata. And I have already mentioned the psychological transduction mechanisms is affecting the thalamus and hypothalamus with the initiation of the pineal gland. So the pineal gland is also playing an important role, not only the pineal gland and our substantia innominata. The substantia innominata, pineal gland, and these are going to mediate the actions on the hypothalamus and medulla oblongata to modulate its functions. From the hypothalamus, it will activate the psychoneuroendocrinal axis, and the medulla, from the medulla oblongata, it will excite and inhibit the cardiac actions through the cardiac nervous system. This connection anatomically signifies the emotional and psychological stimulations come effects on the cardiovascular system as well as in our physical body. Now, what are the basic physiological events we are facing, we are experiencing in our daily life? First and foremost is our thought. How we are thinking of. If we are facing a problem, how we are going to analyze that, how we are going to trace that, how we are going to react against that, how we are going to adapt the defensive mechanism, that is our denial, that is our projection, rejection, rationalization, and etc., regression. And by the choice you are operating, your thought pattern, your choice of your psychological defense mechanisms, one can easily understand how you are processing your problems, and accordingly your endocrinal axis, your neuronal axis will operate. Your emotions, it is very important. Whenever we are operating, or we are looking forward for the models of the learning, models of the memory, we have seen that if emotion-based directions are there, emotion-based learning are there, then it will create the long-term memory, where emotion-less learning is not creating the long-term memory in a faster manner. So not only the emotion-based learning, emotion-based experience is also important. Even how your emotion is going to be expressed, the way you are expressing your emotion, it is of utmost importance. If you can modulate your emotion, that means you are suppressing your emotion. But you have to modulate the expression of emotion so that the social parameters must not be violated. So whenever you are creating that analytical setup to control and modulate your emotional expression, it will take some time. And as a result of that, the long-term processing, the system 2, we can say this is system 2, wherever the long-term memory is concerned, wherever analytical skills are concerned, cognitive skills are concerned, genetic factors are concerned, your teachings are concerned, learnings are concerned, you have to take some time. And whenever you are taking some time, you are analyzing, after that you have to face some queries in your mind, and you are trying to resolve that, and afterwards you could get the finest and productive result. But whenever you are seeing that you are facing a problem and accordingly spontaneous reaction is there, it is known as inclination-based reaction. And your inclination-based reaction is never ever going to be correct. It is always comfortability-directed reaction. And this comfortability-directed relations is devoid of any conscious teachings, any conscious analytical skills. And it is known as the animalistic behavior. Whenever a person is hearing something and react spontaneously according to that, and that spontaneous reaction is harming a person, it is very important. And whenever a person is harming, the person has harmed. Whenever a person is injured emotionally, that emotional injury is also affecting the others. Even the person is getting the injury, that person is less affected than the person is giving the injury. It is very important. Number 3 is your ignorance. When this ignorance is concerned, this world is now governed by the monster known as ignorance, because we are ignorant about the facts, we are ignorant about the truths, we are ignorant about the phenomenologies, and we are ignorant about multi-system affections. Whenever we are basically trying to establish our way of thinking, our one-sided manner, our way of thinking of our one-sided way of thinking in a very, very, very arbitrary manner. And this ignorance will create a huge of neuroendocrinal turmoil, because this ignorance can create your body to be ignored. Your body doesn't have the capability to give the concentration properly whenever you are consciously directed continuously that this could be ignored. Whenever a common example is that whenever a person is facing any injury, any emotional upset, the person is never going to express, because that emotional suppression, they think that emotional suppression suits them. But that emotional suppression is basically harming them because they are unaware about the phenomena, about the scientific steps or scientific models of the ignorance and the emotional processing. Next is your belief. What is your belief? How you are thinking of? What is you are thinking of? When to think and how you are going to accept, what you are going to accept and reject, whatever your attraction or your repulsion towards what you are going to attract it. These are the important factors. These are the important factors in order to design, in order to design your thought pattern, your psychological setup, rather you can say your neuroplasticity. The way you are thinking of the basic information processing skill is very important about the designing of your belief, because we are believing something, whatever, what have some preliminary knowledge in our mind. The belief is directed by the preliminary knowledge. If the basic knowledge is there and accordingly the impulse is matching with our basic knowledge, then it will create a sense of belief. If they are not matching, they are antagonistic to each other, they will create the sense of disbelief. So this belief is very important, which what can guide us, that whatever the genetic pattern of the person, whatever the family background of the person, whatever the teachings, how the person is thinking of. Whenever we are working in the field of psychological education, the gender education, the sexual education, we can see there is problems in each and every steps of the society where this false belief and misbeliefs are playing the important role. And finally, the expectation. We can say don't expect anything, but it is impossible for the human being, for a living human being to not expect. Yes, you can't. Maybe you can modulate your expectation, you can suppress your expectation, but your spontaneous expectation will be generated. If it is not generated, it is impossible, first of all. Secondly, you can say that no, it is not generated basically because you have the sense of ignorance, but its subconscious creation is there and it will create that same devastating results on your physical health. Next is the basic neuropsychiatric deviations. Whenever these psychological mechanisms are concerning, the arrogance is there, anger is there, tension, anxiety, fright, irritability, dependency on abusive substances like smoking, alcoholism, right? These all-gone sensation. I have losing my purpose of life. Maybe the person is frustrating. Maybe the person is depressed. Maybe the person is unable to cope up with the situations. Maybe the person is adapting the flighting tendency rather to fight with the situation, because we are not going to cross our level of comfortability. But when this level or the area of comfortability is crossed, we can't achieve the results whatever we are designed for us. And finally, the deficient memory. Whenever we are not seeing something, whenever our more than two senses are not active in watching something, if not proper time has given, then our memory should not be properly optimized, properly operated, because this memory system is a very complex. Whenever the sensory memory is only of few seconds, the short-term memory is about 1 to 8 seconds, and after that the long-term memory, after the analysis, repetition, rehearsal, and repeated manner, the the long-term memory will be operated. So these are the problems, these are the psychological errors one can facing off. Now, whatever the background start of this study, how we are basically designed our study. The study is designed under the guidance of Hahnemann Medical College London in the year of 2014. The patients of different parts of the world and different states of India also. The controls are selected from different age groups, sex groups, religion, occupation, and socio-economic condition. The level of anxiety is measured by the Hamilton Anxiety Rating Scale, level of anger by the Clinical Anger Scale, level of patience is measured by the Julian method. And the categorization of the controls: type A, 0 to 100, type B, 100 to 500, type C, 0 to 100, who are impatient, aggressive, competitive, workaholic, easily angered, introvert, egoistic. Characters type B, characters of the type Bs are lively, calm, cheerful, sporting, and practical. And type C are the chronic addictive. This is the pie chart about the cardiovascular irregularities, where you can say that group A is of huge number of irregularities, group B is very minimal, and group C is also taking a huge number of participants who are suffering from cardiovascular irregularities. So the previous chart, according to the previous chart, group A and group C poses nearly equal virulence of cardiac disorders, whereas group B having less virulence. So characters of group A personality poses similar kind of damage as group C, that means the addicted personality type and the arrogant personality type. So persons with the characters as group A are more prone to the cardiological disorders. That is why those characters need to correct from the very beginning. And how the development of characters of group A is developed: the faulty education, diseased social culture, and pathological trends. These will create tendency of coping social trends, half-hearted understanding and faulty perception, and compromisation with the dream. Whenever half-hearted understanding and faulty perception is concerned, it will create lack of productivity, which will create mismatched expectation level, that will create compromisation in the social performance, that will create expectation performance mismatch, and then it will create stress. And that stress will result into the anxiety. And that stress further is resulting with the dependency on the abusive materials and depression. And it is a by way, it is depression will create the dependency of the abusive substances also. And the second part of this faulty education, diseased social culture, and pathological trends, it will create tendency to coping with the copying the social trends. Whatever in the trends, whatever trending, those are the shortcuts. And those shortcuts are very much acceptable by the society, by the modern youths, by the modern students in a very dangerous manner. And that will create mal-designed goal to match social trends. And they will create their logics for that particular coping tendencies. And that tendency will create aggression. And that aggression is again another sign of our investigation when a person is going to be when to adapt the behavior of aggression. If the person is not having the capability to process the information, when the person is facing some problems, when the person is not not having the proper coping strategies, then the will take the mask of aggression to adopt the denial strategies. And that aggression is again creating the stress, and the stress hormones are going to release. That means the activation of the neuroendocrine axis, what I have already discussed. And third portion is this faulty education, disease, social structure, and pathological trends is our compromisation with dream. There are lots of fallacies. Whenever a person is choosing their paths, we can say, no, it is not your path. But we are not considering their capabilities, whether the person is capable or not. When the person is capable, we should promote him, we should promote her, because that particular dream is the proper path for them. Because this employment status, this educational status, whatever we are talking of, all are designed in one-sided manner. Whenever rushing in any of the field is there, that will create unemployability, because the equal distribution is very much needed. So each and every sectors has their own scopes and limitations, and we have to consider each and every sectors with the equal importance. And this compromisation with the dream will create compromisation of social performance, because a player which is designed to be a player, the player must not be a good doctor. If that particular person is not assigned for the profession of doctor, the person is not suiting for the medical profession. Maybe the person is suiting for both of the professions, but if they are not suiting for that any of the professions, that will create some compromisation of their performance, and it will create anger, and stress will create anxiety, and that anxiety will create again the anger, and this anger cycle is something different. When the anger is there, again the parameters of the neuroendocrinal disturbance are there, that will create dependency on the abusive substances. They will create isolated, they can make the person isolated. They have much more cognitive difficulties in their life. So this is the development of this characters A. So whenever this character A is concerned, you can see here, there is also the stress factors. Whenever the stress factors is there, oxidative stress factors are also concerned. When the oxidative stress factors are there, if there is cell injuries are concerned. Whenever the cell injuries are concerned, multiple steps can be seen. Whenever lipid peroxidation is there, glycation damage is there, protein degradation is there, and whenever these are there, multiple metabolic errors can be occurred. And whenever multiple errors can be occurred, it will create thrombus, it will create embolus, it will create atherosclerosis, it will create diabetes, hypertension, gout, and multiple pathological conditions. Next, whenever the systemic effects of stress is concerned, acute psychological stress will create the physiological changes, that is hemodynamic response, including blood pressure peak, vagal withdrawal, sympathetic activation, including catecholamine surge, inflammatory response, including cytokine storm, prothrombotic response, including hemoconcentration. Then pathophysiological consequences, myocardial ischemia, cardiac arrhythmia, plaque rupture, thrombus formation, and vasoconstriction. And what are the clinical manifestations are there? Ventricular tachyarrhythmia, acute coronary syndrome, and sudden cardiac death. Now, the psychological alterations, the phases of cardiological pathology. When the onset is there is negative thoughts, anger, aggression, etc. as a result of stress. And maybe it is fixed by the removing cause etiological factors, that may be the exciting factors or the fundamental factors or the maintaining the factors. And when it is not fixed, it will turn into the first stage, where denial of suffering, ignorant about sufferings, because conscious mind is incapable to identify the disharmonies, because our conscious mind is basically creating something whatever matching with our comfortability. And when it is not fixed, when this conscious mind is not able to cope up with the condition, it will firing in an adverse manner, because our subconscious mind have some truth, our subconscious mind have some impulses, have some processing capabilities. If the conscious teachings are not matching with that, it will create conflict. And that's as the subconscious mind is already in action to fix up the pathology, naturally, subconscious mind is trying to remove those negative psychological factors by removing pathological thoughts. But when the conscious mind is not able to remove that, it will create a conflict. And that conflict is creating further complications in our thinking pattern. And till the structural alteration is not taking place, the subconscious mind is able to control, and the conscious teachings are able to control whenever the teachings are not matching with your consciousness. For example, you are choosing something, but your teachers are saying that no, it is not correct because of this. They have given the logical understanding behind that. And whenever the logical understandings, their analytical points you have in your hand, you have to analyze that, because your analysis skill will develop from this. And whenever the structural alteration is not taking place, the body is able to fix it naturally. It may be fixed spontaneously as insulting stimulus passes off. Whenever the stimulus is coming in a continuous manner, it is passes off. It will create some soothness, it will create some peace, and it will remove it from your system accordingly. But when it is not fixed, it will turn into the second stage. That is, depending on the family, urge to become healthy, cooperating and calm, because the body is seeking for help, as subconscious mind is failing to fix the disharmony spontaneously, and conscious mind is now in action, and that conscious mind is creating either the defensive mechanisms. You will be angered, it will be irritable, you will be arrogant, you will be insulting, you will take some violent steps, you will create some violent actions on your family, friends, institutions, and etc. Or you will be much more calm, much more peaceful, much more subordinate, much more calm, quiet, because you doesn't have that capability to react. And when the second stage is passes off, the third stage, it is anxious about diseases. If it is not, what to do? If it is not cured, what to do? What will be the fate? That is overthinking. Aggressive natures. Whenever a person is knowing that, yes, it is the problem, and when the problem has identified, when the person is there, a person is seeing that I am tracked, the people is reading me, the people can understand me, they will create aggression, they will be hostile, they will be restless, they will be non-cooperating due to the worsened pathological condition, both in the mind and physics. Depressed psychosomatic state and grossly deteriorating the pathological status. Now, I have already mentioned the thought, although the thought is declared mystery, which actually not so, because thoughts are basically the synchronization of fine electromagnetic waves, generally of moderate to low wavelengths. There are several studies which claims there is a strong evidence about the presence of quarks in the mechanism of thought generation. Thought can be influenced by several psychosocial factors which affect the conscious and subconscious mind in greater extent. This is an important cause of deviating thoughts. How to treat these kinds of pathological conditions? Yes, we can take some cardiovascular drugs also, because cardiovascular irregularities are there, but that is just the cutting the edge of the icebergs as iceberg phenomena is concerned. We have to correct the lifestyle, we have to correct the behavioral pathologies, we have to administer the psychotherapeutic techniques, and as well as we have to adapt the medical management, because correction of these, after whenever we have to correct until and unless we are correcting the behavioral pathologies, correcting the lifestyles, never ever going to, or never any implementation of the therapeutic techniques will take place in a positive manner. And in the conclusion, I must say prevention is better than cure. Not be arrogant, not be ignorant, not be half-hearted genius. Rather, we have to be cool and calm. We have to be analytical. We have to be cognitively much more capable to understand and analyze the problems, so that we can remodulate, restructurize our way of thinking, our lifestyle. It is important to correct our psychological status from the very beginning, along with the correction of the psychosocial status, to avoid this ever-increasing disease scenario. To establish a disease-free era, it is very much important to observe all minute to minutest deviations and correct them accordingly in association with the nature. And what is this nature? Nature is that plane where all the substances, all the subjects, all the elements of this nature will playing in a harmonious manner. They can live in a harmonious manner. They can operate in a harmonious manner, because this we have to obey the natural rule for the existence, for our survival, because otherwise the nature will identify us as the diseased product, as the nature is already identifying us. For that reason, the nature is giving some opposite, the phagocytic responses. That phagocytosis is mediated by your neutrophils, but that resembles the phagocytotic responses or impulses against us. So we are getting much more diseased, we are getting much more irreversibly injured, and afterwards, one after another, the species are going to be extincted, because we are not obeying the natural rule. We are running against the nature, and that anti-natural activities will create much more pathological condition. These are my references for this work. Thank you so much.
Thank you, sir. Thank you so much for your informative session. If any of the participant is having any queries regarding the presentation, kindly drop your queries in the chat box. Either turn on the mic and ask the queries. I guess there are no queries from the participants, sir. Thank you.
Thank you so much.
I request all the participants to join their respective halls as per the agenda. The main hall participants kindly stay in the same room, and the hall A participant kindly join the breakout room, which was mentioned as hall A. For joining the hall A, kindly tap on breakout rooms and join the hall A. I repeat myself, if any of the participant is having any queries regarding joining the breakout room, kindly let us know either in the chat box or else turn on your mic and speak. Thank you. We will start our technical sessions by 11:10. Before we start our technical sessions, I request all the participants to turn on the camera for the gallery image. I repeat myself, I request all the participants kindly turn on the cameras for the gallery image. I request all the participants kindly turn on the cameras for the gallery image. All the participants belonging to Holly kindly join the Holly while tapping on the breakout rooms. If any of the participant is having any queries regarding the joining the breakout room, kindly let us know either in the chat box or else turn on your mic and speak. Thank you. We'll start our technical sessions shortly. I now introduce Ms. Kushi Shah. She will be moderating the rest of the session. Ms.
Yeah.
Kushi,
Yes.
please kindly take over. Thank you.
May I start now?
Yeah, you can start in a few minutes. I request all the participants be ready with your presentations. The guidelines of presentations are presenters are requested to kindly stick on to the time. 7 minutes for the presentation and 3 minutes for questionnaire.
वो फॉर्म जैसे थे कुछ।
Okay, she
The first five participants of main hall are Priyankesh Mishra, Shani T. John, D. Chandana, Mary Kimberly Kim, Swastika Subha. I request all the participants kindly be ready with your presentations. Session chairs. All the respected session chairs, can we start our session now?
Yes, you can start.
So, hello, good morning everyone. Am I audible? Hello.
Yes, you are audible.
Okay, so I am Khushi Shah, doing Masters of Physiotherapy in Musculoskeletal and Sports at Parul University, and I am moderator for today. So our honorable session chairs are Dr. Sinchan Das, Director Homeopathy and Psychiatry, Benevolencia Foundation, and Dr. Hina Pranav Singh Rathod, Assistant Professor, Srimad Rajan College of Physiotherapy, Gujarat, India. We welcome you, sir and ma'am. So our first participant is Priyankesh Mishra. The title is The Efficiency of Cardiac Marinus on the Treatment of Edema. Are you present? Priyankesh, sir? Hello? You may share your screen, sir. You are not audible, sir.
No, Priyankesh, you are not audible.
Hello.
Yes, you are audible.
Okay, sir.
Your time starts now. You may start your presentation.
Good morning to one and all. I, Priyankesh Mishra, Research Scholar, Benevolencia Foundation, is here to deliver a research on the efficacy of Cardas manus on the treatment of edema. So, edema has been one of the major problem in current health scenario, where various types of edema has been encountered in various patients at various levels. So what is edema? Edema is actually the accumulation of fluid in the interstitial spaces of cells in any region. It could be either at the peripheral region or could be in the organs or any other specific places. What actually happens is when the osmolar shift, that is the ICV, But there are other factors. Hello, am I audible?
Yes, sir, you are audible now. Hello, Priyankesh sir. Are you there?
Hello.
Priyankesh sir?
Yeah,
Yes, sir.
yeah. I'm not connected. Okay.
Sir,
So
please share your screen.
wait a second. Yeah. So whenever the osmolar shift changes from ICV to ECV, that occurs, then edema occurs. There are various other cofactors that affects this for the generation of edema. In general terms, in laboratory findings, when we focus on the ECV to ICV ratio, we find that the ratio from 0.59 to 0.75 is increases, and this leads to the formation of edema. Since various fluids are continuously transferring from the cells to the interstitial spaces, and that is not being further carried to the different cells or the vessels of the body, that leads to the generation of edema. So however, edema has been one of the major neglected part. What maximum times has been done, that correlated factors such as renal issues or the hepatic issues that have been correlated, and edema has been not generally focused in these factors. Hence, that interstitial fluid, interstitial spaces, the fluid has been increasing. Hence, there was an important need for the effective management in healthcare. Thus, this study aims to clinically elucidate the management of edema through the help of Cardus marinus. Cardus marinus, the common name is milk thistle, and that gives the alkaloids as silymarin that further breaks down into silibin A and silibin B. What we will focus in the next slide are my objectives, and considering the aim and objective, the research was conducted on the factors. Here, a mixed research approach has been applied where qualitative and quantitative, that is, a clinical study was done on various patients. There were selective parameters such as edema, the sodium potassium level to focus and analyze the pump system, calcium level, and as well as albumin. These were the tests performed clinically as well as in laboratories, based on which the data were collected from the patients. However, the total population of 1,000 was subdivided into three basic factors, where some patients were given with Cardus marinus, some were given the placebos, and some were given only pathological treatments based on what laboratory findings we have encountered. Hence, the methods and materials, based on that methods and materials and the patient studies, the first pathological prescription that we received here was calculated and estimated, and hence this graph could be found here, that how there has been a decrease in vitamin D, the imbalances of sodium potassium channel, and hypoalbuminemia that was encountered in the patient of edema. Levels of edema in different cases, different patients, can be estimated from here, and these are the grades, where grade 1, where peripheral, both feet and ankles swollen could be found. Grade 2, that was both feet plus lower limbs, hands and lower arms were found. And grade 3 was a generalized bilateral pitting edema, including both feet, legs, arms, and face. Hence, when we gave the medicines to the patients for more than a month, we then told the patient to go for again some pathological testings, and hence we found different types of ratios among them and edema level that could be found from this here, where when the patients were given the cardasparan, the rise of serum albumin was noticed. Along with this, the condition of edema that was at a much higher scale was found to reduce. However, the sodium potassium that was first calculated in milliequivalent per liter, here it is calculated in equivalent per liter, and hence we can't find that there has been a deficit changes, and the patient started the normalizing in their edematic condition. However, when the patient was given only placebo, the same varied differences were found, where that could be estimated from this chart, where the serum albumin level, hypoalbuminemia was still encountered, the level of edema started to gradually increase in different group of patients, sodium potassium imbalances was still encountered. These were the some patients and their pictures that were collected from different peripheral camps. And when we go with the patients for specific pathological treatments, such as giving vitamin D tablets to vitamin D insufficiencies, giving sodium and potassium in extra manner, so it was encountered that although there has been a balance in the sodium and potassium level, the level of edema was not at such encountered position, because what happens was that the actual factors that were correlating with this was not actually completely removed or not balanced in this condition. As considering all these factors, what we focus and develop the actual pathogenesis of the edema, as well as the how the actions of cardiac maintenance has been occurring in this. So we will first focus on how is occurring. What is done that we have prescribed the cardiac maintenance in a mother tincture, cardiac maintenance on milk thistle, that is it is a kingdom plantae, and it belongs to the class of tracheophytes. This milk thistle was first crushed, the flowers of the milk thistle was first crushed, and an aqueous solution with alcohol was made that presented with flavonolignin, silibin A and silibin B. That these silibin A and silibin B, these are the chemical structures of silibin A and silibin B. One of the major factors is that silibin A and silibin B, or that combinedly makes the silymarin. These, whenever oral absorption is focused, these gets absorbed to 23 to 47%, where the efflux transporters of the apical sites of the intestinal epithelium are majorly factor important for the absorption of this silibin. Hence, when the silibin is absorbed, it then with the hematological pathways, it aids enterohepatic recycling as well as renal clearance, and it is finally excreted via the routes of feces or urine. The further breakdown of silibin could be here found with the phase of biotransformation that leads to differentiation of different metabolites. Hence, so there has been a correlation of hypoalbuminemia, there has been a correlation of sodium potassium pump, there has been a correlation of different other factors that leads to the generation of edema. And whenever we are applying cardiac maintenance to these patients, different sets of treatment prescriptions could be found in these cases. Hence, what happens and how an edema occurred, we needed to focus in these conditions. So we excluded the various causes and various factors
Sorry
that
for
has been
interruption,
affecting
sir.
the.
So your 2 minutes are only left. You may conclude your study.
Okay, so here we can see in this structure here that there is malnutrition. The pre-proalbumin, proalbumin leads to the generation of albumin. However, thyroid gland, whenever thyroid gland is affected, the albumin deficiency occurs. Hypoalbuminemia reduces the efficacy of cellular protein. This leads to the altered membranous transporter protein, that is sodium potassium pump. These sodium potassium deficiencies alterations have been even evident in the patients, and whenever we focus on treatment with the cardiac maintenance, these were Yes. And easily applied for management of edema and can apply in the European countries from yes. So these were different.
Thank you, sir. I request the session chair to ask any questions.
Priyankesh, you have mentioned here about the milk thistle,
Yes, sir.
where about the milk thistle or Cardias marianus.
Yes, sir.
But what is the basic role of uridine glucuronide transferase in the metabolism of Cardas?
Sir, can you repeat the question?
What is the role of uridine glucuronide transferase in the metabolism of Cardas?
Sir, urine, sir, whenever we focus, silibine is one of the major alkaloid, and whenever we need to transform, that is a focus of biotransformation, that UGTs aids in that transformation of its that could be acted on the sodium potassium pump, because silibine is itself
No, my question is specifically what is the role of UGT? Just what is the role of UGT? Is it forming some? Whether it has some actions with the bile conjugates or not? Whether they are forming some compounds or not?
So it first it forms one of the compound that aids in the bile conjugation.
Okay, it is missing in your presentation, right? It should be there.
Okay. Okay,
and you have mentioned all the areas of your body forming edema. Is it possible all the area where the edema is formed?
Not, sir, all the areas. There's various specific areas such as peripheral areas could be evident, as well as various other areas such as cerebral edema has been evident.
Fine, but it is not in the everywhere, right?
No, sir, and not it is not everywhere.
And this pathogenetic pathway, is it applicable for the lymphadenitis also?
No, sir, that has yes, sir, it has been applied for the lymphadenitis also, because, sir, a major factor here is the sodium potassium pump as well as the albumin protein. When the lymphedema is acting in this condition, the sodium potassium pump alteration, because the ICV transformations to the ECV is essential here.
Okay.
For the generation of edema.
Thank you.
Thank you, sir. Next we have Sanity John. Screening of antibacterial activity of crude extracts and epibiotic organism isolated from seagrass, Thalassacia hemipreci, Halodula pinifolia, Halodula universalis against human and fish pathogens.
Good morning. My screen is visible?
Yes, ma'am, it's visible. You may start your presentation. Your time starts now.
Thank you for this opportunity. And my name is Shani Tejan. I am going to present my topic on screening of antibacterial activity of different sea grasses, which is collected from southern state. And we know that we are particularly been going on with multi-drug resistant bacteria, both in the case of marine as well as in the marine as well as among human populations. Therefore, in an aim to isolate an antibiotic compound from seagrasses, we have selected 3 seagrasses from the regions, from Kanyakumari district regions. We know that seagrasses are submerged marine angiosperms growing in the tidal as well as the subtidal areas of seas, except the polar regions. And these seagrasses have been found to have numerous effects. It is being used in the erstwhile period in the treatment of burns, boils, and also in the treatment in order to give treatment during the bite of different sting bite by different insects. Therefore, in this study, I have selected this particular seagrasses to assess whether this seagrasses is having any potential activity against human pathogens as well as fish pathogens. Therefore, my materials is that I have collected the seagrass using sterile methods brought into the laboratory. I have washed the seagrasses thoroughly to remove the adherent particles, and also I have extracted the extracts using different solvents, and also gone for analysis of antagonistic antagonistic activity of associated bacteria by following the method of Lemus et al. So antibacterial assay of epibiotic bacteria was actually an important assay, because on assaying the crude extract, efficacy of the crude extract, sometimes the associated bacteria may also play a vital role in producing efficacy against the disease treatment. And crude extract was extracted using different solvents in the increasing order of polarity, with like I have started from hexane, chloroform, ethyl acetate, diethyl ether, acetone, and methanol by soaking the material in the respective solvents overnight at 18 degree centigrade. And after going for crude extract analysis, I have also gone with minimal inhibitory concentration of the purified extracts, where the minimal inhibitory concentration of the isolates, like those isolates which I have isolated from the surface of the seagrasses, like they were named as S1 to S356, and the strains like S1, S3, and S6 were determined for the presence of minimal inhibitory concentrations, as well as the crude extract, which showed very effective antibacterial activity, was also partially purified using the method which has been said by Wright. Results. Out of the 6 solvents used for the extraction of the seagrasses, I have used 3 seagrasses like Thalassia hemprichi, Halodula finifolia, Halodula uninovus. Among the 3 seagrasses, Thalassia hemprichi was excellent in inhibiting the growth of both the fish pathogens as well as the human pathogens. I have procured this fish as well as human pathogens from UAT, and fish pathogens from Tuticorin Fisheries College. And on screening the antibacterial activity of these pathogens, Thalassia hemprichi showed excellent activity. That too, diethyl ether extract was able to produce a zone of around 5 mm against Pseudomonas mirabilis, Pseudomonas aeruginosa, and E. coli and Staphylococcus epidermidis. Also, it is able to inhibit fish pathogens like Vibrio hemprichi and Vibrio fisheries. And this is the table which shows the antibacterial activity of 3 different sea grasses against human pathogens, where you can see some of the extracts like methyl, diethyl ether, chloroform extracts were good enough to inhibit the growth of most of the human pathogens. As well as the antibacterial activity of isolated epibiotic bacteria against human and fish pathogens were also identified. And for the isolation of epibiotic bacteria, the seagrasses were thoroughly washed 2 to 3 times with the sterile seawater. After that, the swabbing was done on the surface of the seagrasses to elect the adherent epibiotic bacteria, were swabbed onto Sobel marine agar bacteria. Then pure culture was isolated and maintained to assess the antibacterial activity. Here, for assessing the antagonistic activity against human as well as fish pathogens, we have gone with the cross-trick method, where it showed very good activity against some of the tested pathogens, both against humans as well as the fish pathogens. So this graph shows the total amount of epibiotic bacteria which has been isolated from the 3 seagrasses, where you can see about 15% as well as 25 and 15% of the total strains which has been isolated from 3 grasses were potent active in inhibiting the growth of pathogens. And after that, after the identification of antagonistic activity, the crude extract which showed best activity was partially purified, and the partially purified extract was gone for minimal inhibitory concentration analysis. Minimal inhibitory concentration were found to be lower for 100% methanol fraction for the pathogens E. coli, Salmonella typhi and Pseudomonas aeruginosa. In case of fish pathogens, the MIC was found to be lower for Vibrio fischeri and Vibrio harvey. That is 0.1 mg of the extract was good enough to inhibit the growth of these pathogens. Therefore, the fraction AS10, which showed good minimal inhibitory concentration, was further analyzed using UV and FTIR spectral analysis for the presence of particular compounds, which is necessary, which is very good in carrying out the inhibition of the particular pathogens. And the conclusion is that from the study, it is noted that that adequate data as well as comparison of my results, it is said that seagrass extract has different novel antibiotics on different species like bacterial, human bacterial pathogens as well as fish pathogens. Therefore, further research is also essential to study the principal compound present in the seagrasses, which is responsible for antimicrobial activity. It can be achieved by using advanced separation techniques. Thank you.
So thank you, ma'am, for your presentation. I request session chair to ask questions if any.
Have you implemented your study on any clinical setup or any clinical study has organized?
Sir, actually, we did our study in a laboratory, sir, because this is with the microbes, no, sir. We just done with antimicrobial activity.
Okay, you have said that in the human and fish pathogens. And what sort of pathogens you have already studied?
Actually, we have studied with the Salmonella typhi, Vibrio cholerae, Klebsiella pneumonia. All these pathogens were procured from VIT Vellore.
Yeah. So, in case of Vibrio cholerae or Salmonella typhi, we have do you have any culture on the antibiotic resistant organism or freshly prepared and freshly colonized microorganism?
This is actually freshly prepared.
Okay, so without having the
and also have analyzed against antibiotic resistant bacteria from fish pathogens.
Okay, not in case of human pathogen, right?
Human pathogens.
Do you have any study on the human pathogen also in case of antibacterial resistant human pathogen?
Yes, we are going on with that study, sir. We are continuing with that study right now.
Okay. Thank you.
Thank you.
Thank you. So next we have Deep Chanda, decoding obesity signatures and perturbated host pathway, shifting from cataloging to mechanistic insight at the host microbiome interference. Are you there, Dr. Deep, sir? Okay,
Yes.
you may start
Am
with
I
your
audible?
presentation. Yes, sir, you are audible.
Okay,
Your
so
time
I'm
starts
going in.
now.
Okay. Hi, I am Deep Chandra from Department of Biotechnology, NIT Durgapur. I am a CSIR Senior Research Fellow here and in the final year of my PhD and working under Dr. Debojyoti De, who is an assistant professor in this department. So my work is basically on decoding the obesity signatures, that is signature species and pathways, and how these altered microbiome actually perturb or influence the host pathways to maintain the obese state. So my work has been published recently on gut microbes. You can see here in this here. So you all know that in recent decade, gut microbial dysbiosis has been linked to a number of diseases. So one of them is obesity, which is characterized by a BMI of greater than 30 kg per meter square, and which is actually can be evident from higher energy intake than which can be explained by higher energy intake than higher energy expenditure due to less exercise, sedentary lifestyles, and higher input of energy through diet. So the main objective is to find out signature species and pathways of gut microbiome associated to obesity. What happens is classically smaller cohorts finds this out, but they are inconsistent due to a number of different covariates like age, sex, ethnicities, and all. So there is no such studies that have come to a conclusion which which are actually the signatures pathways or the signature species of obesity. So in our study, we have tried to assess the reproducible alteration in community structure. We have tried to identify which are the species and pathways responsible for the disruption of the community structure, and what are the signature species or pathways associated to obesity. Further, we also have find out what are the host pathways that are actually perturbed by the altered gut microbial composition. So we have included 11 diverse data set from different ethnicities. You can see here in this list, and a total of 903 control and 836 obese subjects have been included in our study, comprising a total of 1739 samples. So we have divided into two parts. This is the methods, materials and methods section. In first part, we have tried to find out the signatures of obesity, where we have downloaded the data, already published data sets. We have analyzed through classical meta-analysis, classical random effect meta-analysis. Then we have used machine learning meta-analysis through random forest, using random forest algorithm, and then we performed network meta-analysis using NetMos package, and we further validated the signatures on independent datasets. In the second part, where we have tried to find out which are the host pathways that are perturbed, for that what we have done is we have find out what are the human proteins that interact with the bacterial protein, and with those human gene families or proteins, we have performed a meta-analysis using a random forest machine learning algorithm to find out differentially abundant human gene families. And with those differentially abundant human gene families, we have performed enrichment analysis using KEGG and Reactome database to find out the host pathways, to find out if the host pathways are somewhere related to obesity or inflammation or whatever. So this is the result section. We have find out there is a consistent decrease in the alpha diversity, although it was not evident in the beta diversity case. You can see that in Shannon Simpson, these two diversity indices are reduced in obese condition. However, F by B ratio, firmicutes by bacteria ratio, which is thought to be a hallmark of obesity, we did not find any pattern here. So this is still controversial and questionable. Now, when we performed integrated, network meta-analysis, we have seen that the network meta-analysis shows there is a destruction of the network. Like in control section, in control individuals, the network is, the gut microbial network is very much compact and complex. And according to ecological concept, a compact and complex network is a healthy network, which is seen in the control section, but in control individuals, which is not seen in obese samples. So there is a destruction of the network. And when we analyzed, we have found that this is a list of species on the basis of their importance, which are responsible for the destruction of this network. Next, we have used machine learning algorithm to find out signature species and signature pathways. Machine learning meta-analysis find 25 species, of which many are used as probiotic, like Alistips shahi, Anaerostips hedros, Alistips indistinctus, Bifidobacterium longum, Odorivector. These are all used as a probiotics nowadays. So we have found the depletion of these species. Hello. Hello.
I request all others to mute their mic, please. You may continue.
Okay. So there is a depletion of a number of species which are actually used as a probiotics nowadays, and we have found that the decrease in this panel of 25 species actually leads to the destroyed network. And when we compile this species, species that we find out from network meta-analysis and from machine learning meta-analysis, we integrated this two to find out this panel of 46 species, and we have used this 46 species to see if they are actually able to efficiently classify obese and lean samples. We have find out that there is an accuracy of 85 with an AUC value of 0.85. They can classify obese and control samples, which is thought to be very high accuracy rate. As
Sorry,
far
sir,
as the
for
pathways,
interruption. You are only left with 2 minutes. You can conclude
okay,
your study.
I'm wrapping. Okay. So as far as the pathways are concerned, we have found that a number of short chain fatty acid pathways and short chain fatty acids biosynthesis pathways and purine and pyrimidine nucleotide biosynthesis pathways and some carbohydrate metabolism pathways are associated to obesity. We have also found this out, and our enrichment analysis also found that some host pathways which are involved in inflammatory reactions like JAK-STAT signaling pathways, TCR receptor signaling pathways, cytokine signaling, which are given in this blue color, TCR signaling, cytokine signaling, interferon gamma signaling. We found them to be enriched in obese conditions. So we have summarized this, that there was a reproducible loss of diversity, and we found 29 key species responsible for the disruption of the healthy gut microbial network. We have found out 25 bacteria reproducibly altered in obese condition, and signatures were validated with very high accuracy of 0.85 AUC on independent validation datasets, and enrichment of different immune regulatory pathways, as I said, JAK-STAT, interferon, cytokine signaling pathways are found enriched in host body in altered gut microbial conditions. So these are my references. Thank you.
Thank you, sir, for your presentation. I request the session chair to ask questions, if any.
You have already mentioned that obesity signatures.
Yes.
And do you have any work on the gut-brain axis?
Well, actually, not. We have not done that explicitly, but we have find out that I have not actually included this in this presentation, but we have find out some metabolites, like you can say some tryptophan derivatives that actually works through the gut-brain axis, that actually responsible for the secretion of some anorexic hormone like GLP or PYY hormone, and that works through the gut-brain axis to signal the brain and regulate appetite. So we have found that out theoretically, but not experimentally.
Is there any relation with the leptins of the microbes?
Actually, yes. I cannot actually remember the compound or the metabolite specifically, but there was some metabolites that found to be signal through this leptin. That actually causes the secretion of leptin.
But
and
the
thereby
intestinal microscopical substances must have some neurological correlations, right?
I didn't get you.
All the microbial substances which have whatever needed for the digestion or anything that are residing in the GI tract, right?
Yes.
So those must have some interrelationship with the neurological substances also, the mediators, the hormones, or other things.
Yeah, that should be, but I have not actually looked up to that.
Okay, okay, thank you.
Thank you.
Thank you, sir. I request the next five: Meera Sarvanan, Devadatta Das, Yasef Sahib Yusufdar, Mukesh Methi, and Dr. Sonia Sharma to be ready with your presentation. So next we have Mary Kimberly Lim, tennis-related injuries, NEISS database study. Are you there, ma'am? Please respond. Okay, you may share your screen now and start with your presentation. You are not audible, ma'am.
Hi, should I go ahead with my presentation?
Yes, ma'am, you can.
Got it.
Please share your screen, ma'am.
Hi, can you see my screen now?
Yes, ma'am, it's audible. Your time starts now.
Okay. Hi, everyone. Good morning. It's a pleasure to be here to speak in front of all of you today. My name is Marie Kimberly Lim, and I'm currently a medical student at the University of Vermont here in the United States. But today I am presenting you research from the University of Pennsylvania. And so today I will be speaking about tennis-related injuries, specifically from the knees or National Electronic Injury Surveillance System database study. So you might ask, what is the reason why we conducted this study to begin with? And the reason we were really interested in carrying out this study was because we wanted to understand and see the trends that are occurring in terms of injuries in the sport. And we really wanted to find out the most common tennis injuries happening in the United States, again, based on this NICE database study. And so in 2022, in the United States alone, we found that there was over 23 million tennis players, and the sport is only gathering even more popularity across the globe. And so this really necessitates the need to better understand what are the most common injuries occurring, how frequently these injuries are happening, and very importantly, also the demographics that are most commonly associated, or who are the individuals that are most commonly impacted by the injuries in this sport. And so moving on to our methodology, how did we collect our data? So again, we derived all of our data from the National Electronic Injury Surveillance System, or NEISS. It's basically a collection of injury reports from 100 emergency departments across the United States. But this database is not limited to just tennis. It involves many other sports, including leisurely activities and even things like mowing the lawn, as simple as that. And it's an open source for individuals who want to carry out studies based on these publicly available and recorded data. And so our group specifically was interested in tennis because I do work in a musculoskeletal lab that has a lot to do with sports medicine. And so the way we did this was we used what we call a NICE query, which requires us to enter a product code. And for this study, it would be tennis. So like typing in tennis into the query. And as a result, this gave us 19 reports coming from over 11,000 different patients from the years 2003 to 2022. These are individuals, or 11,000 patients who had tennis-related injuries, who happened to report to an emergency department in their area when the injury happened. In terms of analyzing the data, we first categorized our data into diagnosis, body part, sex, age, and race. After this, we basically, in order to get the national estimate for each type of tennis-related injury, we added individual national weights for each patient with a specific type of injury. And at the same time, we also used narrative data.
ലിങ്കിലേക്ക് കയറുമ്പോൾ ഡയറക്റ്റ് ആവേ ഓപ്പൺ ആയി വരുന്നത് എനിക്ക് ഇതൊന്നും എനിക്ക് വരുന്നില്ല അതാണോ സെക്ഷൻ ബി ആംഗ്ലോ
I request all others to please mute their mics.
ഇത് ഓപ്പൺ பண்ணி வருது
இதுல எனக்கு ரெஜிஸ்டர்லாம் வருது நீங்க இங்க பாஸ்வேர்ட் மீட்டிங்லாம் இருக்குல்ல இத போட்டீங்கன்னா நீங்க
Ramya
login
Krishnan,
பண்ணலாம்.
and please mute your mic.
எனக்கு தெரியல.
Okay, so as I was saying, aside from that, we also looked into narrative data, which allowed us to better study wrist fractures. It allowed us to see maybe which one was more common, right or left wrist fractures, which bones in the wrist were commonly fractured, and if there was an interesting trend that we could see between males and females. And finally, we also organized our data based on 5 we categorize it into 5 body parts, and you can see that in figure 1 to your left and on figure 3. You have head, face, neck, upper extremity, trunk, lower extremity, and the last one being unreported body part. And we also categorized our data into 8 different diagnoses, which you can see over here at figure 2. So what did we find out from this study? As many of you might guess, especially those who play tennis or have ever engaged in the sport, because of the complexity of the footwork involved in the sport, a lot of running, a lot of side to side and different motions going in different directions, you might guess that the most common injury are sprains or strains. And we learned that you can actually see this on figure 1, where you see the highest bar for sprains and strains. And we found this to be most commonly occurring in the lower extremity. But more specifically, if you look at figure 5, you can see that sprains and strains most often affected the ankles. But second in line to ankles, we saw that lower legs were next impacted, followed by knees, and lastly by wrist, in terms of the diagnoses of sprains and strains. Aside from sprains and strains, if you go back to figure 2, you'll see that the second highest bar there is fracture. So we're not looking into others because that's an uncategorized, basically not identified diagnoses. So for fractures, we found that this was the second most common type of tennis-related injury and was most commonly seen in the upper extremities. So if you look here on the bottom at figure 4, fractures most commonly occurred in the wrist. And when we looked into narrative data, it was very interesting because on figure 6, you'll see that left wrist fractures are actually more common than right wrist fractures. But even more interesting, we saw that females were more affected by left wrist fractures compared to males, while for right wrist fractures, both the occurrence for males and females were around the same. And finally, you'll see on figure 3 just shows you that the lower extremity is the most affected body part. And on figure 7, a little larger, this just shows you that the distal radius was the most commonly affected bone for our wrist fractures. And the tallest bars on the right would just be unspecified bone for wrist fractures. So we can ignore that. And finally, placing our attention back to conclusion, the last bullet shows you that we also looked into dislocations with specified mechanisms of injury, and we found that 64% of dislocations were caused by a fall, and that more than half of these occurred in the upper extremity. And that basically concludes everything I have for you from our study. And our hope really in conducting this is that we can bring more awareness towards the common injuries that happen and help tennis players, tailor their warm up and their exercises to prevent these injuries, and overall just to create safer practices for the sport. And so that's it for me. Thank you so much.
Thank you, ma'am, for your presentation. I request session chair to ask questions if any.
Yes, Mary. Is that your players or the that you have selected for your study, that is a recreational player or the sports person or the athletes?
Thank you so much. That's a very good question. So these individuals who we included in the study are individuals who range from amateur players to professional players. It's just a mix. Because these are just individuals who happen to go to these 100 different emergency departments that have the NICE database system in their hospital. So really, they range from all levels of tennis. Yeah, the players come from all levels.
Okay, fine.
It happens.
Any more questions? Okay, thank you. I assume that there are no questions. So next we have Swastika Subha. Impact of modern psychology in infertility. Are you there, Swastika? Can you hear me, Swastika? Hello. Okay, so till the time we'll move to next presenter. Meera Sarvanan. Hand washing, the facet of microbiology, hand washing, the best hospital practice. Are you there, Meera?
Good afternoon, ma'am. Can you hear me, ma'am?
Yes, ma'am, you are audible. You may
Yes,
start
ma'am.
your share screen.
Yes, ma'am. Yes, ma'am. Shall I start this? Ma'am, shall I
Yes,
start?
ma'am, you may do a
Yes,
yes,
ma'am.
yes, ma'am. You
Good
may do a
afternoon.
slideshow. Your
Yes,
time
ma'am.
starts now.
Yes, ma'am. A descriptive study on hand washing practices among staff nurses was the study taken. 1.4 million people across the globe are affected due to hospital-acquired infections. WHO says prevalence of hospital-acquired infections to be 5 to 10% in the developed countries and 40% in the developing countries. And we found hand washing a cost-effective intervention in the hospital setting. It has become a vital role in infection control, and it adds safety of patients in the healthcare organizations. Kalata et al. Found low adherence to hand washing practices, that is, only 23% of the healthcare professionals adhere to hand hygiene practices. The objective of the study was to assess the practices of hand washing among the staff nurses. The supportive literatures screened were compliance with hand hygiene practices amongst nursing staff in secondary healthcare hospitals in Kuwait, Sarah Al-Anazi et al., BMC Health Services Research 2022. It was a cross-sectional study with 524 participants found compliance with hand hygiene, that was 25% by direct observation, while self-reported compliance was 69.5%. Each varied significantly between different hospitals. Female nurses compared to male nurses were more likely to report compliance with hand hygiene in multivariable analysis. Assessing hand hygiene practices among nurses in the Kingdom of Saudi Arabia, Mohammed Al-Muaitef, the Open Public Health Journal 2020, a cross-sectional survey designed with 243 participants found that 65.4% followed good hand hygiene practice, while 10.3% showed inadequate hand hygiene practice. Good hand hygiene practice was found to be significantly higher among the female participants, that is 88%, than male 44%. Regarding the methodology of the study, the descriptive design, 36 staff nurses working in 4 areas in the hospital, such as medical ward, surgical ward, gastro ward, and ortho wards, who were on duty were selected with the purposive sampling technique. We had
Agenda
collected the socio-demographic data, and the second section was observation checklist for hand washing, which was based on prerequisite and steps of hand washing with 12 statements. Duration of period was 1 week. This was the checklist used. Prerequisite were 2 items, and steps of hand washing included to wet the hand under running water, applying enough soap, palm to palm, right palm over left dorsum, and vice versa. Fingers interlace, fingers interlock, rotational rubbing of thumbs, rotational rubbing backward and forward with clasped fingers. Rub each fingers with opposite hands and rinse hand and dry thoroughly and close the tap with the elbow. So on observation, we found more participants were female, that
Everybody
is
else, I request you to
88%.
please mute their mics.
And the work experience of the staff nurses who worked more than 2 years were 90%, and who had an experience of up to 5 years was just 10%. The work area distribution 31.4% from medical ward, 25.7% from surgical ward, and 22.8% from gastro ward, and ortho ward 20%. So the result of the study was through observation checklist, it was found only 14.3% of staff nurses followed the right steps of hand hygiene practice, and inadequate practice of hand washing was found among 85.7% among the staff nurses in the selected setting. So it is concluded that strict emphasis on hand hygiene to the healthcare professional and its regular monitoring in the hospital can prevent the risk of occurrence of infection. And we can also, the other literatures have specified, like we can have posters and other video form of displays in the area where staff nurses can go for their hand washing. So thank you for the opportunity given to present the study.
Thank you, ma'am, for your presentation. I request session chair to ask questions, if any.
No question from my side.
Okay. So I assume there are no questions. So we'll do for the next participant.
Yes, ma'am. Thank you, ma'am.
Thank you. Swastika Suba, are you there? Can you please respond? Swastika Suba. Swastika, are you there? Okay, so next up we have Devadatta Das. Are you there? Please respond if you are.
I'm here.
Okay, so varicose vein to cardiovascular compromisation. Your time starts now. You may share your screen.
All right, ma'am. Thank you. Is my slide visible, ma'am? Hello?
Yes, sir, it's visible. You may start.
So, varicose vein to cardiovascular compromisation. Hello, good afternoon, everyone. I am Devadatta Das, and I am a junior student scholar from Benevolencia Foundation, the Humanitarian Institute for Advanced Medicine and Cultural Research, West Bengal. Varicose vein what is a varicose vein? A varicose vein is a twisted dilated venous segment linked to valvular incompetence. They arise from the fall of the valves and the blood flow from the superficial. So there are 3 common forms of varicocytes or varicose veins that are saphenous varix, esophageal varix, and copet reducive. Now, what is the need to study? Why do we need to study varicose vein? Varicose vein has been occurring in Indian subcontinent, an Indian population due to various underlying factors, a majority of them being stress, nutritional deficiency, and lifestyle. It is a potential to lead to cardiovascular compromisations or cardiovascular health disease. Aims: to execute the complications of cardiovascular compromisation via saphenous varix or varicocele, and to prove a relationship between saphenous varix and cardiovascular health compromise. Over here, as you can see, I have a disease prevalence of varicose vein throughout the globe. And as you can see that majority of the blue portion, that is the 15 to 30% of the population in this region, which is the entirety of the South Asia, including Middle East, are being affected by varicose vein. Now, a observational research study has been done from various camps throughout West Bengal by Benevolencia Foundation. These camps has been taking place in Harwa, Chouberia, Bashirhat, Darjeeling, and Kolnani. And from there, I have gathered some data of various patients. As you can see, the number of patients are not huge, but still they are significant. As you can see, the male to female ratio of occurrence of varicose vein in the common people of India are here given here. In Chouberia, there are 25 patients, out of whom 15 of the males are suffering from varicose vein and 10 of the females. And let me point it out that they are from the age of 30 to 50 only. So they have a higher chance of cardiovascular health, although I have mentioned the age limit from 30 to 75, but majority of these patients are from the age of 30 to 50, and majority of them are daily wage workers. Underlying factors for varicose vein: anti-gravity movement restrictions, malnutrition, and oxidative stress. In this flow chart, we have a schematic diagrammatic representations of how different factors are influencing and causing the occurrence of saphenous varix or varicose vein. From the left, if we start, we can see that cholesterol and catecholamine stimulates the liver, release the glucose in the bloodstream. Elevated blood glucose occurs in insulin resistance. And environmental stress release cortisol and catecholamine, which also is a factor which makes insulin resistance. And insulin resistance results in metabolic disorder. And this metabolic disorder leads to vascular lumen narrowing. And this vascular lumen narrowing leads to ischemia. Ischemia leads to cellular hypoxia. And the cellular hypoxia, through various factors such as triggering inflammatory pathway, inflammatory cells, ROS, RNS depositions, and producing oxidative stress. Whereas ROS stands as reactive oxygen species and RNS stands as reactive nitrogen species. And this oxidative stress plays a key role as it leads to superficial veins elongation. The superficial veins are elongated by muscles are overloaded with toxins and pollution. When the muscles are being overloaded with toxins and pollutants,
Yes, hello.
Hello, yes.
I have sent some photos in your WhatsApp. So you need to select out, break out. So through that you need to reach Hawley. Can you do that, sir?
Can I join? I have linked now.
Please mute all the participants are requested to mute themselves.
Not made on, sir. Your presentation called Hawley. So you need to click a breakout.
Doctor, you can continue.
Thank you, sir. Thank you very much. Muscles are overloaded with the toxins and
So after one presentation, is
defense
my
mechanisms
cube?
are
How
not
is?
working properly, and intramuscular channels are not working properly. This leads to muscles become loosened and superficial veins elongated. As muscles are becoming loose, the calf muscles is made up of 3 muscles, and the main function of the calf muscles in the leg is to pump the blood to the heart, which is deoxygenated blood. It is actually taking the blood from the superficial veins and pumping it through the saphenous vein to the femoral vein, and this femoral vein is leading upway to the heart. I hope I made myself clear. And thus, the calf muscle is acting like a second heart. And over on the right side is the hypothalamus or the HP axis, leading to liver damage and stress and behavioral patterns. Alcohol consumption, which is a lifestyle modifications and a choice also. Poor diet and leading to various infections. Next slide. Results and discussions. Over here, I have given is my slide visible, sir?
Yes, it is visible.
Yes. Over here, I have given a relationship of nutritional insufficiency and obesity. Two CVC or cardiovascular compromisation, psychological factors are also involved. Now, nutritional deficiency causes imbalancement markers. And how is this imbalancement of inflammatory markers? Sorry, imbalance, and this imbalancement of inflammatory markers is in magnesium deficiency. We know calcium and magnesium are important transport chains. These ions help in various mechanisms of the biochemical pathways. And in deficiency of calcium magnesium in the body can lead to imbalancement of these pathways, and which results in an inflammatory reactions and imbalancement of inflammatory markers. All right. Now, activations of inflammasomes release pro-inflammatory cytokines, which results directly to oxidative stress. And I have mentioned before that how oxidative stress results in saphenous varix. Obesity, deposition of cholesterol, we all know, and plaque results in venous reflux. The cholesterol can deposit in the veins of the peripheral veins, and this deposition results in venous reflux. That is, the blood is reflooded back, and this venous reflux results in twisting of the vein, which in turn results in chronic venous insufficiency, or there is insufficiency of venous flow in the veins, venous blood to the veins, which is also against reacts and results in more plaque formation and venous reflux. The main part over here is the deep vein thrombosis. Improper drainage from the femoral vein to the inferior vena cava results in deep vein thrombosis. These deep vein thrombosis give rise to minute internal plaques or clots which travels via the vein to the heart. And plaque reaches the heart and results in deposition or formation of blockage. I have mentioned also earlier that anti-gravity movement restriction results in a greater stress on the heart. These all results in the CVC or cardiovascular health compromisation, which in turn can lead to cardiovascular health disease. Management and a detailed understanding of deep vein thrombosis. On the right over here, we have various pictures of saphenous varix, which are occurred due to deep vein thrombosis. Now, what is deep vein thrombosis? As over here in this diagrammatic picture, we can see that healthy veins have
Sorry,
normal.
sir, for interruption. You are just left with 2 minutes. You may now conclude your study.
All right. Thank you, ma'am. There are some as I was saying, that pooling of blood results in embolism, and this is the embolism that travels via the vein towards the heart and results in the clot formation and results in the heart. And we know that if there is cholesterol present in the blood, present in the body, then atherosclerosis may occurs. And these clots or embolus results in more clot formation and results in the blockage of the heart, which results to cardiovascular health problems. Now, management. There are some nutrients that are very beneficial for varicose vein management: vitamin C, vitamin E, bioflavin, zinc. We should include them in diet and reduce sodium, refined carbohydrates, sugars, and trans fat, which we consume in huge amount in modern lifestyle, in so-called modern lifestyle. And trans fat and alcohol. Caffeine, it's like our go-to drug now. Summary and conclusions. All that I have mentioned above about embolus have been summarized and concluded over here, which results in cardiovascular compromisation. Acknowledgement. I would like to thank BioLeaks and my mentors and my elders for giving me this opportunity to present my topic here. And these are my references from where I have conducted and concluded my thesis. The links are given here. Thank you. Any questions?
Thank you, sir, for your presentation. I request session chair to ask questions if any.
Hidotto,
Yes, sir.
Go to the previous slide. Previous one. Previous one. Yes. You have to you have to be more careful about the spelling whenever you are presenting something. Twisting of vein, deep vein thrombosis, the spellings are there. It is wrong.
Yes, sir.
You should be more careful for that. Nextly, you are mentioning here that alcohol plays an important role in the formation of varicose vein. But can you specify how the process is going to be occurred?
Sir, I have is my slide visible? Yes, sir. Sir, here I have mentioned that stress, behavioral patterns, and alcohol consumptions leads to liver damage. How the liver damage is occurring? Alteration in the function of liver. That is the function. The liver has plays various crucial functions in the biochemical pathway, and the alteration in these functions leads to liver damage. And this alteration of function leading to liver damage
Alteration
results.
of the function is not causing the liver damage. The result of the liver damage should be the alteration of the function.
Yes, sir.
Is there any enzymatic interconnection between the alcohol and oxidative reactions?
Sir, the antioxidant deficiency mechanisms are not working properly. So if the liver is not working properly,
Have you,
then
have you
liver.
measured in your work the oxidative radicals?
No, sir, I have not mentioned, but we all know that liver plays a crucial function as it's a it acts as a detoxifying organ. So it detoxifies every unnecessary waste. And if that liver is not functioning properly, then the antioxidant defense mechanisms is not working
Could
properly.
you mention? Could you mention that what is the detoxifying enzyme needed for the alcohol removal from the body? The name of the enzyme?
No, sir.
Okay, thank you.
Thank you. So, Swastika, Subha, are you there? Please respond.
Yes, ma'am. Am I audible? Hello.
Yes, you are audible now. Yes. So, impact of modern psychology in infertility. You may share your screen and now start your presentation.
A very good afternoon to one and all present out here. My name is Swastika Subba, and today I'll be presenting on the topic impact of modern psychology on infertility. WHO defines infertility as a disease of male and female reproductive, which is further defined as a failure to achieve pregnancy even after 12 months or more, despite of regular unprotected sexual intercourse. The left-hand side, we can see that in the chart that Asia has the largest recorded number of infertility, followed by countries like Africa, Europe, North America, and South America, and more. Infertility, as we know, is the major issues the world is currently witnessing, and it's likely to be more adverse in the coming years. Further, it has been noted that more of the studies has been carried out on the way infertility has impacted the psychological health of an individual, due to which it is often neglected the way our psychological well-being is leading to infertility. On accounting this, the aim of the study is to critically discuss the aspects of modern psychology and its significant impact on leading to infertility. In carrying out the study, I have carried out a primary qualitative research methodology where I have taken a sample size of 1,200 people consisting of both male and female. The demographic sample size were taken from people aging 18 to 40 years and above within West Bengal. Data collection has been conducted based on interview case study. While I have used a tool like Hamilton Anxiety Rating Scale, the Perceived Stress Scale, and Emotion Experience and Expressive Suppression Scale. So on the basis of this case study, we have found that in the first bar chart, we can see that the level of stress among group A is comparatively less, with a gradual rise in group B, C. On the basis of this, we can note that as the person ages in the late middle adulthood or the late adulthood, the level of stress eventually rises. Similarly, we can note that despite stress being less in group A, the level of frustration, anger, and irritability is much more higher as they reach the late adulthood or the category of group B. So considering this, we can say that the level of stress in the early group A is not minimized or less, but rather it's being getting more adverse form or being expressed in the form of frustration, anger, and irritability. On the left-hand side, considering the two pie charts, we can see that emotional suppression in case of female are would gradually rise, whereas in case of male, it would gradually descend with major rise in irritability. This shows that the suppression in case of male is being expressed in the form of irritability, while the emotional suppression in case of female is much the gradation of emotional suppression in case of female is much more higher as compared to males. So, considering the above charts and discussions, we can note three major patterns of modern psychology, that is suppression and emotional suppression, or emotional suppression leading to less outbursting, suppression of thoughts, and suppression of expectations, as well as ignorance and denial. Denial and ignorance in the current scenario is getting much more embraced due to hyper-individualistic mentality of individuals. For instance, when tobacco was first used, people were largely ignorant about its harmful side effects. And currently, despite the harmful effects being flashed on its packet itself, people just deny as well as ignore the fact, outlining various conditions as why they must consume or they are consuming tobacco. This very denial and ignorance among people is eventually leading to manipulating conflicting thoughts among them, which is based on the aspects such as the preconceived idea, social structures, and the orientation on the way they are thinking, analyzing, and the way the cognition is working. All these three patterns of modern psychology ultimately creates unresolved grief, unresolved anger, and unresolved desire, while leading to more stress. Accounting this, when people are on stress, it gets perceived through optic impulse, olfactory impulse, and hepatic impulse, which then reaches to brain in the optic lobe, occipital lobe, parietal lobe, and temporal lobe, respectively. All these three sensations, impulses, or informations is transmitted to thalamus, where it is then passed on to hypothalamus. Accordingly, hypothalamus gets programmed or encoded with impulses, which is then sent to pituitary. Pituitary here ensures to release the necessary releasing hormones. This eventually leads to release of various tropic hormones for a specific organ. Moreover, the organ responsible for infertility is ovary, due to which here the HPO excess is activated. And considering this, we can say that under stress, hypothalamus activates HPA excess when while releasing cortisol and mineralocorticoids, while stimulating GnRH. The GnRH impulse further release FHS, LHS, GTH, stimulations. When asked to conduct a serum androgen test, one can observe some irregularities in the menstrual cycle as well as infertility is evident. Considering this, it is evident that under stress, hypothalamus activates. Considering this, we can say that when the level of serum androgen is high in them, one must understand the particular person or individual is under stress. This stress is mediated by sex steroids and it's controlled by mineralocorticoid, which is secreted by adrenal cortex. The stimulation of adrenal cortex is then made. Cortex is made by the HPA excess under the stimulation of stress. So when the body is on the stress, neuroendocrine axes are activated. So when this under this activation of neuro often fails to give any productivity either physically or psychologically. This is the very impact of modern psychology on infertility. Coming down to the summary of the
Hello, ma'am, you are not audible.
There is considering this, there is a need for one to adopt effective management plans. So one must ensure to not disrupt their circadian rhythm, practice mindfulness and try to avoid negative thoughts as much as possible, and try to seek assistance in case of need. And lastly, avoid suppressing anger and grief and try to express those by diary writing, singing, or through productive works. These are the references I have used. Thank you.
Thank you, ma'am, for your presentation. I request session chair to ask questions, if any.
Swastika,
yes, sir.
Mentioned in your title impact of modern psychology on infertility.
Yes, sir.
Conclusion, you have mentioned that not disturb a circadian rhythm. What is the interrelationship between your modern psychological pattern and circadian rhythm?
Sir, there is a thing called cellular circadian clock, which is responsible for releasing LHS, FSH, and GTS, which is like necessary for like for fertilization.
My question is, what is the interrelationship between your pattern of psychology, that psychological pattern, and circadian rhythm? What is the outcome of circadian rhythm? We all know that, but what is the interrelationship between these two?
Sir, currently, like due to like modern lifestyle and all, people are like people are not sleeping, like their sleep cycle is completely distorted, due to which their sleep cycle is being disrupted, as a result of which more stress is being caused. And due to like incomplete stress, we can see more irritability due to the release of cortisol, higher level of cortisol level. So this is how it's like interrelated.
But do you have do you have performed any sort of biochemical investigations? Because you have mentioned in your slide about the Hamilton scales and other psychological scales, but in your resultant discussion you have mentioned about the pathway. But how this pathway you have established? Do you have performed any biochemical investigation?
No, sir, it is based on like theoretical literature review.
So it is just hypothetical, right?
Yes, sir.
Okay, thank you.
Okay, so thank you. We'll move to the next participants. Mukesh Methi, are you there? Please respond.
Yes, ma'am, I am here.
Okay, so differential study of varicocele.
Okay, ma'am.
You may share your screen and start the presentation.
Okay, ma'am.
Swastika Suba?
Yes, ma'am.
Please end your screen share. Okay, Mukesh Methi.
Yes, ma'am.
Yes, you can share your slide and start presenting.
Yes, ma'am.
Video. I'm the audience when I was telling you the time. Okay, please put your things there.
Hello, ma'am. Hello, sir. Today my topic is differential study of varicocele. Myself, Mukesh Maiti, and Dr. Sinchan Das helped me to make this. So yeah, varicocele is a abnormal dilatation of the pampiniform plexus. This pampiniform plexus is situated in the internal spermatic veins and spermatic cord. And this pampiniform plexus is the cause of varicocele, and this pampiniform plexus abnormal dilated pampiniform plexus is the cause of varicocele. My aims and objective is to evaluate different causes of varicocele and identify the probable pathological relations between etiological factors and varicocele. So, ma'am, my methodology. Sorry, sir.
तीन डॉट ये व्यू मोर है, ये वाला 3 डॉट वाला आया, मोर आया. हेलो
Sajjad
hello, sir.
Ahmed, please mute your mic. Sajjad Ahmed, I request you to mute your mic, please.
Okay, ma'am.
Mehdi, you can continue with your presentation.
Okay, ma'am. So my methodology is in my total case is 128, and this total case I also parted this three parted that one is heavy worker people, and second is secondary lifestyle people who are working with who are working in the secondary job professions like in office, or who are sitting or standing type of working in profession, and the others who are the people who are teenager or student. They are others. I also defined in three categories, and these three categories have I also this graph in methodology that 30% others and secondary in 30% and heavy worker in 40%. And I make a graph about the relationship between working profession and cause of varicocele. So heavy worker people, those are heavy worker people. Their varicocele, their varicocele is caused for the missing or insufficient of internal spermatic valves, and the secondary lifestyle people have elevated nitric oxide because they are in high stress. So this high stress for this high stress, the nitric oxide is synthesized, and nitric oxide is a local vasodilator, and this vasodilator also also cause for the vasodilating the internal spermatic vein, and this internal spermatic vein compressed the renal vein, and this for the compression of the renal vein the varicocele cause. And the others who have, they have some other causes like nutcracker phenomenon and spermatic cord disturbance. And after that, I also differentiate finding that the different age groups and the cause of varicocele, like 18 to 30 years age group who are basically from who are coming from teenager, or who are a student professional, like they have they have lowest number of elevated nitric oxide cases, but highest in the arterial blood flow. The arterial blood flow when increases, the pampiniform plexus is compressed, and this compression also cause for varicocele for the 18 to 30 years age group, and 30 to 35 there the internal spermatic vein valves, the insufficient valves, incomplete valves also cause for varicocele, and 35 to 48 age group have the highest number of internal spermatic vein valves absent of internal spermatic vein valves, and 48 to up had the elevated nitric oxide because of their stress level. And varicocele epidemiology and etiology and symptoms here. Epidemiology in 15% in adults occur and 8.2% in adolescents, and scrotal enlargement in adult males. And etiological factors like primary varicocele is cause for the venous reflux, and secondary varicocele is cause for the renal cell carcinoma and portal hypertension. Also the vein compression also, and symptoms the patients gives us that the dull edge of the scrotal region, and feeling heaviness and atrophy of the testis, and the infertility is the main symptoms of the varicocele. And this is the dissected testis and the pampiniform plexus review, and the pampiniform plexus and spermatic cord in this diagram. And the causes of varicocele, there are like missing or insufficient of the internal spermatic vein. And ontogenic differences mean ontogenic, the baby in the zygote formation, there are the baby in zygote formation, there are internal spermatic vein and the renal vein also compression, and if it is one type of ontogenic disorder. So in this ontogenic differences, the ontogenic disorder also here. And the nutcracker phenomena means the internal spermatic vein, renal vein, and the superior renal artery also form the nutcracker phenomenon. And the increase of blood flow in the arterial supply in the puberty, and the elevated nitric oxide for the 40 and 40 up age groups. And the spermatic cord differences, like the formation of the spermatic cord is abnormal, so the varicocele occurs. And there are the pathogenesis of the varicocele, the primary infertility and the secondary infertility. They are causes for the primary infertility, cause for the left spermatic vein drains into the left renal vein, and the nutcracker phenomena. And then the left renal vein increases the pressure in the spermatic vein. For this cause, the varicocele occurs, and the vein valve failure or retrograde blood flow. If the valves if the
Sorry for
valves are
disturbance, sir. You are just left with 2 minutes. Please conclude your study.
okay, ma'am.
Mukesh, you can conclude.
Okay, sir. And after the pathogenesis, it's the summary and the conclusion, and this is my special thanks to Dr. Sinchandas, and this is the sites where I get the help from these sites. So.
Okay, Mukesh, you have mentioned about the nutcracker phenomena. What is the nutcracker phenomena?
Sir, nutcracker phenomena, sir, this nutcracker phenomena means, sir, there are three veins there, the renal vein, and the internal spermatic vein, and superior renal vein. And these three renal veins compression forms the nutcracker phenomenon.
Is it superior mesenteric vein or superior renal vein?
Sorry, sir. This is superior mesenteric vein. Superior mesenteric vein and artery also.
And you have mentioned in your just go through your pathogenesis slide.
Yes, sir.
Here you have mentioned about the increased scrotal volume. What do you mean by increased scrotal volume?
Sir, in this increased scrotal volume means the increased scrotal type volume means the hydrocele or the increase of water in the scrotal.
Okay, thank you.
Okay, sir.
Thank you, sir, for your presentation. Next, we have Sahib Yusuf Daur. Are you there? Please respond.
Yes, ma'am, I'm here. Can you hear me?
Okay. Yes, you are audible. So, role of occupational therapy in management of seasonal affective disorder. You may share your screen and start your presentation.
Hello, everyone. My name is Sahib Yusufdar. I'm an occupational therapist student at Jamia Hamdard, Department of Occupational Therapy. Today, my title is my screen visible?
Yes, sir, it's visible.
So hello everyone, my name is Sahib Yusufdar. I'm an MOT pediatric student at the Department of Occupational Therapy in Jamia Hamdard. So the title for today's presentation is Role of Occupational Therapy in the Management of Seasonal Affective Disorder. The co-author for this presentation is Dr. Nazia Ali. She's an assistant professor at the Department of Occupational Therapy in Jamia Hamdard. Coming to the overview, as we all know, the sunlight decreases during the short days of winters. So many individuals struggle with seasonal affective disorder or SAD. Acronym illustrates that people have feelings of low energy and sadness, especially during the winter months, which includes the December, January, and February, which is the winter solstice when the days are shortest. It is not a unique diagnostic entity, rather, it is a type of recurring major depression with a seasonal pattern. According to the DSM-5 criteria, the criteria for depression with a seasonal pattern include depression that begins and ends during a specific season every year with full remittance during other seasons for at least 2 years and having more seasons of depression than seasons without depression over a lifetime. It is most frequently occurring in winter, although it can also occur in summer. Coming to the etiology and incidence of SAD, etiology increases the decreased serotonin level, which affects the mood and triggers depression. The melatonin is increased during winters, which all of us know that melatonin plays an important role in the sleep pattern and mood. The circadian rhythm is disrupted during winters. Coming to the incidence, the male is to female ratio is 4:1. That is, out of every 5 people, around 4 women are affected more and 1 man is affected. Age of onset, it is between 18 to 30 years. And those living farthest from the equator in northern latitudes are most susceptible to having seasonal affective disorder. Coming to the signs and symptoms, as the illustration itself describes that during the winter months, people sleeping more than usual, they have increased appetite, their cravings for carbohydrates increase, they gain weight, they have irritability, they have social issues, they withdraw from their social situations, have difficulty in concentrating, feel very tired and lethargic, and the most important sign being they feel sad, irritable, and they may cry very frequently. It is important to know that the seasonal pattern disorders vary in severity. Some individuals may experience a milder form of SAD that is known as subsyndromal SAD, SSAD, or most commonly known as winter blues. However, others may be severely incapacitated and unable to function. Even it is important to know that all the depressive disorders, there might be thoughts of suicide present in the patients or the clients of seasonal affective disorder. Coming to the assessment tool, there are clearly a number of significant people that live with the debilitating side effects of SAD and are not functional to their full potential. So screening for SAD and SSAD is very important. The seasonal pattern assessment questionnaire, which was first developed by Rosenthal and his colleagues in 1984, is the widely used tool. It is a freely available in public domain. It is a retrospective self-administered tool that screens for the existence of SAD as SAD. There is no training required to use this tool. This is a form of the SAD. Yeah. So this is the brief questionnaire where we have to fill the identification details and we have to fill about our education and all and the current weight. And then we have to find about we have to mark again accordingly the sleep length, social activity, mood, weight, appetite, and energy level. Then we have to fill accordingly which months we have felt the best or we have slept the most, we have slept the least, and other points such as how much was the weight fluctuation and others. Then coming to the treatment approach, the most commonly treatment approach used a combination of antidepressant medication, light therapy, vitamin D, and counseling. Antidepressant medications include the second generation antidepressants, such as the selective serotonin reuptake inhibitors. These are the most promising medications that have been prescribed for SAD. Light therapy, it has been well used across treating the patients with the SAD and SSAD. There is an illustration of the bright light therapy given on the right side of the screen. Vitamin D. There are often lower levels of vitamin D present which are associated with depression. Lower levels of vitamin D are usually due to insufficient dietary intake or lifestyle issues such as little outdoor exposure to sunshine. Counseling. CBT has been found a very effective method of treating SAD and SSAD. Coming to the occupational therapy intervention, which was the main focus of the topic. Occupational therapists have the primary responsibility of informing individuals with SAD about the etiology, prevalence, symptoms, and occupational performance issues caused by the disorder, as well as possibilities for positive intervention. The main symptom of SAD, which is the low energy level, is being remedied with fatigue management and energy conservation techniques. Occupational therapists have an important part in ensuring that the clients are aware of the typical usage guidelines provided to users of Lightbox and fulfill the need for clinical monitoring. In psychosocial rehabilitation, the therapist plays a role in identifying a client's psychosocial issues as well as his strengths and limitations, assessing a client's readiness, motivation, and belief in their abilities to make change in their life, identifying what is meaningful to the client, identifying social support systems in outdoor and indoor settings, mental health settings. Occupational therapists often lead therapy groups. The topics for the therapy groups might include the stress management, weight control and nutrition, smoking cessation, substance abuse, time management, social skills and networking, wintertime activities, self-esteem, sexual health, sleep, education, and etc. These group sessions are guided by a number of different theoretical and therapeutic frames of reference that are supported by research. Then coming to the common approach that the occupational therapists use for treating clients with SAD includes CBT, MBCT, behavioral activation, problem solving therapy, and outdoor therapy. Coming to cognitive behavioral therapy, occupational therapists use CBT to encourage clients with SAD to engage in enjoyable activities in the winter months as a method of activating change to
Sorry, sir,
behavior.
for interruption. You are just left with 2 minutes. Please conclude your study.
Yeah, I'll just conclude in 2 minutes. Yeah, coming to that helps to enforce cognitive restructuring. The skills that occupational therapists use are developing a repertoire, using diaries to record automatic negative thoughts, creating a balanced activity level, improving time management skills, problem solving about situations, setting goals and plans for maintaining gains and preventing relapse. So MBCT, basically this is used to train the clients that takes in a group setting over a number of weeks. It focuses on the concept of decentering. Decentering. Behavioral activation aims to increase the number of positively reinforcing experiences in an individual's life. Outdoor therapy uses walking, horticulture groups, outdoor walking, and other things such as which helps to maintain the healthy occupational performance in SAD. These are the references that I have used for the preparation of my PPT.
And in fact, not only that it is a human neural mechanism is said that your pattern processing in your brain is designed to
Thank you, sir, for your presentation. I request the session chair to ask any questions.
So you don't remember somebody's speech. You don't remember somebody's this one. In fact, we remember
Okay, I assume there are no questions. So
I'm
moving
really
to the
sorry,
next
but I cannot.
participant.
Thank you so much.
Thank you. Dr. Sonia Sharma, are you there? Please respond. Dr. Sonia Sharma, are you there? Okay, so next we have Urvashi Goel. The use of kinesiotaping in managing traumatic patellar dislocation, subluxation, a case report. Dr. Urvashi Goel, please respond.
Yes, ma'am, I'm here.
Share your screen and start with your presentation.
Okay, ma'am. Is my PPT visible?
Yes, ma'am, it's visible. You may start.
Okay. So myself, Urvashi Goel, and today I am presenting on topic the use of kinesiotaping in managing traumatic patellar dislocation or subluxation, a case report. Introduction is kinesiotape is used in a variety of settings for edema reduction, pain management, inhibition, and facilitation of motor activity. Kinesiotape can be worn continuously 3 to 4 days before a new application is required. The basic principle of therapeutic taping for weakened muscle contractions is to wrap the tape around the affected muscle from the origin to insertion. Athletes with patellar subluxation or dislocation usually describe a buckling from non-contact mechanisms of injury. The patella usually will reduce when the knee is extended. Now, aim and need of study. The use of kinesiotaping in managing traumatic patellar dislocation or subluxation. Methodology: a 38-year-old male sustained a traumatic left knee patella lateral dislocation while playing. The mechanism of injury was a slow medial rotational force in a closed chain flexed knee position. He reported immediate relocation by his medical team present there. Oral intake of 600 mg Advil and ice with compression wrapping. An examination was performed after the 3 days. The patient did not report a history of previous knee subluxation and was elected to physician consultation and did 4-week rehabilitation period. The patient continued to use a single point cane with weight bearing as tolerated. The primary impairments during this period were quadriceps inhibition with weight bearing, pain, and a feeling of left knee instability. Now treatment. The patient was given daily interferential current with ice, elevation, and 200 mg Advil twice a day for edema and pain management. kinesiotaping in a Y configuration to facilitate the quadriceps contraction and to decrease pain. In addition to taping and daily IFC with ice, the rehabilitation consisted of static and dynamic balance training, stationary cycling, self-massage, range of motion exercises, and core stabilization training. Now, result of my studies. This case report supports the use of kinesiotaping to promote beneficial effects on decreasing pain with pre-NPRS of 7 and post-2 and enhancing quadriceps activity and weight-bearing stability during functional activities. So the conclusion is this case study concludes that the use of kinesiotaping has beneficial effects on decreasing pain and enhancing quadriceps activity and weight-bearing stability during functional activity. Discussion. A major focus of rehabilitation is improvement in post-dislocation strength, pain, and swelling. Although re-evaluation revealed muscle atrophy and pain with eccentric loading activities, the patient felt her pain, stability, and quadriceps activation were subjectively improved with tape application. The functional neuropomp evaluation suggests kinesiotape application during rehabilitation may enhance strength, balance, coordination, mobility, and control necessary for participation in sports or occupational activities safely and with reduced risk of injury. Application of athletic tape demonstrated little or no difference in active range of motion or EMG measurements. The author suggested that further research efforts include randomized controlled studies to determine short and long-term efficacy and analysis of the success of the elastic taping. References. Thank you.
Thank you, ma'am, for your presentation. I request the session chair to ask questions, if any.
Urvashi, how much is the reliability of this tape? Like which type of tape that you have used?
reliability check करो इसमें HFMS
Sorry, ma'am.
The kinesio tape that you have used, what is the reliability of it?
Ma'am, I have used the means kinesiotape. The tape with ma'am, the tape which is used in sports or athletes, which can doesn't hamper the sports activity of athlete.
It's come with a different type of resistance,
Yes,
right? So
yes,
which
yes.
type, which resistance that you have selected to prevent the subluxation or dislocation? No idea?
No, ma'am.
Okay, thank you.
Thank you.
Well
So
done, Judy.
you may end
Hello.
your slide share now. Dr. Sonia Sharma, are you there? Please respond.
Yes, ma'am. Yes, ma'am. I'm here.
Okay, so addressing motor function deficits in spinal muscular atrophy, HFMSE analysis. You may share your screen and start your presentation.
Yes, ma'am. Yes, this is Dr. Sonia Sharma from Sir Gangaram Hospital. I'm pursuing my PhD from Jamia Hamdard University. I'm working in Sir Gangaram Hospital for past 10 years as an occupational therapist. So the title of my study is Addressing Motor Function Deficits in Spinal Muscular Atrophy through HFMSE. So spinal muscular atrophy is an autosomal recessive neuromuscular disease characterized by motor neuron degeneration. It is because of the SMN1 gene which is not there or in these patients. So SMA arises from a mutation or complete deletion of the SMN1 gene located on the fifth chromosome. SMN2 is a backup gene, so it decides the severity of the disease. The more is the more is the number of SMN2 gene, the less severe is the disease.
Ma'am,
So
your slide is not visible.
I hope it's visible now, ma'am. Ma'am, I hope it's visible now.
No, it's still not visible, ma'am.
Okay, ma'am, I'm trying.
Ma'am, you can share your screen.
Yes, ma'am, I'm sharing my screen, but I don't know how it is not visible. I'm still trying.
It's okay, ma'am. You can resolve your issue and come next. Is that fine?
No problem. Okay.
Okay. So, Saikat Hazra, are you there?
Yes, ma'am, I am here.
Okay. So, worm investigation and heart diseases. You may share your screen and start your presentation.
Okay, ma'am. Ma'am, my screen is visible.
Yes, sir. It's visible. You may start your presentation.
Good afternoon, ma'am. Good afternoon, sir. Myself is Soika Hajar. Today my topic is worm infestation and heart disease. Worm infestation. Parasite infection previously seen only in the developing countries are now diagnosed anywhere in the world due to the tourism and marketing.
Shrikant, you are not audible.
Sir, you are not audible. Saikat Hazra,
So you diverted all the questions.
can you respond if you can hear?
Transport and all was funded by.
So, are you there? So, next we have Dr. Priyanshi Pandya. Are you there? Priyanshi, please respond if you are there.
Yes, ma'am, I'm here.
Okay. So, level of physical activity among physiotherapy professional practicing in Vadodara. Please share your screen and start with your presentation.
ও কিন্তু ও তো বলেই যাচ্ছে
Question to identify the correlation between worm infestation and
Are you able to see the screen?
Yes, ma'am, your screen is visible. You can just do a slideshow and start.
Yeah. So my title is Level of Physical Activity Among Physiotherapy Professional Practicing in Baroda. The regular exercise can aid in preventing clinical illness and early mortality. As a physiotherapist, we promote physiotherapy exercise, but as a physio, because of the job and less time, we are getting less time, and that's why I prefer to go with this study. So due to the nature of their job, and physical therapists need to process high level of physical strength and endurance in order to carry out the exercise with that patient. And as we treat the patient, we require our fitness as well. So the need of the study is the physical activity is crucial for the physiotherapy professional who engage in both on-field and off-field patient treatment. Research assessing physical activity level among physiotherapists has been conducted globally and including participants from various academic and professional backgrounds. This study aims to assess physical activity among physiotherapy professionals in Baroda, which is present in Gujarat, India. The survey aimed to determine the extent of physical activity among physiotherapy professionals. So the null hypothesis is there is no significant prevalence and level of physical activity among physiotherapists. An alternative hypothesis is there will be significant prevalence for the physical activity. So aim was the objective of this research is to assess physical activity level, and two objectives are there: to identify level of physical activity and to compare the different domain of physical activity using the metabolic equivalent, that is MET. So on the basis of MET, I have assessed the physical activity of physiotherapists present in the Vadodara. So it is an observational study. The survey tool was IPEC long questionnaire. In this study, 40 physiotherapists were recruited, and I have taken IPEC long questionnaire. And for that, those who are qualified physiotherapists, those who are registered physiotherapists, I have taken them from the Baroda, and I have excluded those who are having mentally or physically challenged, temporary disability, deformity, psychological issue, visual impairment, any musculoskeletal or neurological disorder, major disorders. And I have not included the trainees, intern, undergraduate students, and those who are working more than 960 minutes. The response time should not be less than 10 minutes. That was my exclusion criteria. So basically, I've taken the IPEC questionnaire long form and I've converted it into a Google form, and I've sent this Google form link to different professionals who are working in the Vadodara through email. So I've sent that this participants included for the physiotherapy and postgraduate students, total 43 responses I've received from 65 questionnaires. So activity data were processed into MET minute. I've converted it into the MET minutes according to the formula I've received. That is simple formula it was, indicating energy expenditure and classified into low, moderate and high level of physical activity, so that I can identify key physiotherapists are having which kind of majority physiotherapists are having which kind of physical activity. So from the IPEC, I've taken it up, and it also includes different domains that walking, moderate and vigorous physical activity. There are 4 main domains. I've collected the data from the mail and phone according on the basis of inclusion exclusion criteria. And for the data analysis, I've used the Microsoft Excel for the mean and standard deviation. So IPEC is specifically for assessing activity frequency, duration, and intensity over the past week across 4 main domains that are work, transportation, leisure, and household activities. So MET values were calculated for each and every activity type based on the MET, that is energy expenditure per kilogram of the body weight. So total MET value per week were computed in the minutes. So IPEC long questionnaire showed reliability, specifically reliability of it is 0.8 and validity is 0.3. So I've sent the questionnaire to 65 physiotherapists. From them, 63 responded, and from the 43 responded, and from the 43, I've taken 41 participants. 2 were excluded from the study. That 2 participants, one was having physical challenge, and other did not make the response to the time. So that was the reason for the exclusion. So from the Google form, I've received a Google sheet, and from that, the mean age of the participants that is in the table, and I found the standard deviation of it. Another thing is from the IPEC guideline only I've received the formula that the hours and days I have to convert into the minutes, and from that apply it in the formula, and I've received the MET. So from all the participants, I have converted each and every participant's activity into the minute and then MET. So all our analyzed data were having total physical activity of more than 300 MET minutes per week, and hence we kept it as in the high physical activity. So more than 3000 is the parameter for the high physical activity level. So majority of the physiotherapists were having more than 3000 MET. That shows high physical activity. And again, this is the table for specific activity: total walking, total moderate physical activity, and vigorous physical activity. So this is the mean I have received from the simple Excel sheet. Other according to the domains. So job related physical activity, transportation physical activity, housework, house maintenance, caring, and recreational sports. According to this domains, I've found the individual MET of individual participants for individual domains. So as we can see, the recreation, sports, and household is the major transportation physical activities having major time. So from the result, about 66 participants responded to the questionnaire sent. Out of 43 were responded, and included is 41 because 2 were having another were included for according to the exclusion criteria. All the responses met the criteria for the high level of physical activity. So from the Excel sheet, I have found the mean. I've converted all the minutes into the MET, and according to the MET, we have found that the majority of the physical therapists present in the Vadodara are having high level of physical activity according to the response. I found this. So in the conclusion, the findings suggest that physical therapists in the Baroda city engage in the similar activity of physical activity across various domains such as transportation, housework, and recreational activity. These are the domains where the physiotherapists are more involved in Baroda. However, their job-related physical activity is notably higher, almost 3 times higher than the MET minutes per week compared to the other domains. So in the discussion, the recommendation include 30 minutes of session of moderate intensity physical activity for 5 days per week for the healthy individual. Using the MET method for the measurement, engaging in light, moderate, and vigorous activity reduce the cardiovascular risk factor for everyone. However, the self-reported physical activity tends to overestimate actual level, particularly in the detailed survey and low activity population. Work-related activity was the primary source of energy expenditure, while leisure and household activity were low and possibly due to therapy schedule. Moderate activity was most common, with over 4,000 MET per minute per week observed across across and domain. So from the IPEC questionnaire, it has some limitation. So we can conclude from this study that in the Baroda city, majority physiotherapists are having high level of physical activity, but it has some limitation as well because the sample size was very low. 41 participants were only there. So limitation is sample size is less. Study was restricted for the fact that IPEC questionnaire I used to ask about the physical activity over proceeding just 7 days. So there are chances of recall bias. And however, it is possible to conduct this type of research on large scale across the various region of the country. So in the Baroda only, the specific region I have not covered. So that is the limitation. And these are the references. Thank you.
Thank you for your presentation. I request the session chair to ask questions if any.
This is your observational study, fine,
Yes.
Priyanshi. And you have kept the hypothesis. So, is it that matching with your study design?
No, we are not finding exactly prevalence for the physical activity.
So, and your aims that you have mentioned that level of physical activity because of the involvement in the treatment aspect and all, fine. So that's why you need to measure the physical activity level. But in your result, it's showing that the highest MET they are using in the job. So it is like your aim, it is controversial to your result.
I have to check it once now.
Yeah. Okay, fine. And whatever the result you are getting, that is a high level of physical activity, might be due to the mean age, that is 30. So that you need to different category, and then you need to evaluate and then find out what is the barrier and how it's affected.
Yes, ma'am.
Yeah. Okay. Thank you.
Thank you.
Thank you. I request the next participant, Saikat Hazra. Are you ready?
Yes, ma'am.
Saikat Hazra, are you there?
Yes, ma'am.
Are you ready?
Yes, ma'am, I am ready.
Okay, so warm investigation and heart disease. You may share your screen and start with your presentation, sir.
Okay, ma'am. Hello, ma'am. Hello, sir. Good afternoon, everyone. Today my topic is worm infestation and heart disease. Myself, Soikat Hazra, and I helped by Dr. Sinchan Das. Worm infestation and heart disease. Parasite infestation previously seen only in developing country are now diagnosed anywhere in the world to better tourism, marketing, immigration, increasing the number of HIV immunodeficiency syndrome, organ transplantation, and blood transfusion. Therefore, clinicians anywhere around the must be aware to the potential cardiac manifestation of parasitic infection. My aims and object to predict the cases to cardiac irregular which could be like with the worm infestation and in the beginning to evaluate the complication and as well as the fate of the cases of worm infestation and to draw an interrelationship between the worm infestation and cardiac pathology to identify the suspectable class who are going to be affected by the pathology in a very frequent manner to rule out the associated factor of such pathology. we found the total case of taken 2,200. A detailed survey was conducted with the self-reported questionnaires to identify the correlationship between the worm infection and cardiac irregulation. We have taken 200 cases, subject from the low socio-economic condition 75, and subject from the moderate socio-economic condition 67, and subject from the upper socio-economic condition 58. The patient having a clinical manifestation, and they have chest pain, and same offer regarding radiating, and some offer non-radiating events in the chest, loss of appetite, and hepatidrosis, hyposis, occipital headache, and constipation, gritting of the teeth and salivation. And investigation of blood for cardiac, blood for CBC, blood of LFT. The patient with non-specific manifestation, hunger increased, excessive desire for sweet, irritability, and anger issue. And the subject without any manifestation, we have not found of any manifestation in this case. We make a graph chart, subject from the low socio-economic condition. The blue portion is worm infestation and cardiac equality both, and the green is the cardiac irregulates only. The blue color is worm infestation only, and the orange color worm infestation and hepatic pathology both. The cardiac manifestation of worm infection can be broadly classified into two major groups, depending upon the affected layers of the heart, that is table 1, and the class of parasites, that is table 2. Table 1 is a myocardium and pancreatitis. Tinea solium is the affect our myocardium or pancreatitis, and Echinococcus species is the effect on the pericardium, and Toxocara canis and Toxocara cati. They are types of round worm. They are effect in the miscellaneous. The ethophagy and parasitic disease of the heart. The pathophysiology of the structural damage to the heart by worms may be vary depending upon the etiology. Hence, the extra mechanism remains fully understood in the certain species. However, has been educated that generally worms affected various structure of the heart, such as the myocardium, pericardium, pulmonary vasculates directly or indirectly. The mechanism such by that the presence elsewhere in the human host, or the producing the reaction. Echinococcus and cytocercosis affect the pericardium and associates with pericarditis and pericardial effusion, and constrict the pericardial or cardium tamponins due to the rupture by cyst. Cystoma damage the heart by indirectly mechanism in from their presence elsewhere in the human host, such as pulmonary hypertension associated with hypersplenic cystomasis. And now the helminths. Helminths are they involve the human heart. And comparably, each varieties in species has a temperate the chesters and the nematodes. Their helminths affect the heart directly or indirectly in the various form, worms, larvae form, and eggs form. They are causing the different cardiac disease. Only a few helminths which commonly cause the cardiac disease will discuss below. And the cystotomyces, cystotom is the topical helminths infection caused by the nematodes flatworms. It is a flatworm of the genus Cystoma. The parasites that cause the cystomasis live in the certain types of fresh waters like snail, fishes, octopus, and Cystomos infection are classified into acute and cystonic phase. Worms, worms are three types of worms. This is the heart disease, the Echinococcus helminths and schistosomiasis. Echinococcus effect in the pericardium and associated with pericarditis and pericardium for pericardium effusion. And pericardium effusion is symptoms will found chest pain, chest fullness, light headedness. The helminths, the many types of helminths effect in our heart. The many and trematodes, castodes, and nematodes. The types of trematodes were hermaphroditic, interstitial flux, lungs, flukage, and other methods. Trematodes cause the consuming the contained food. It enter our body to consuming the content of the food, raw fish, vegetable, never unwashed fruit, etc. Its infection can lead a liver and lung disease. It can infection lung disease and schistosomiasis. Is caused by the fresh water. It is a fresh water parasites. It's found the sub-Saharan Africa, the Middle East, South Asia, and Caribbean. It caused by the fresh water from the fresh water condition from the infected animal of human urine, and it is enter the human skin, bloodstream, and migrated of the liver. It is effect in the intestine and liver. It makes the disease a cardiac complication, and its syndrome is Katayama syndrome.
Sorry for interruption, sir. There are only 2 minutes left. You may conclude your presentation.
Okay, ma'am. Katayama syndrome, and it make the heart failure. We found some syndromes, the shortness of breath, bilateral edema in the lower extremities, and trachycardia. The worms we make a chart. It's a worm disease and cardiac manifestation and treatment. Echinococcus granulose and Echinococcus he make the disease is echinococcosis. Cardiac manifestation and chest rupture leading to the pericarditis and anaphylactic reaction, and really chronic constrict the pericarditis. It eliminates albendazole and mebitazole or periquatal. Schistosoma mansoni make the disease schistosomiasis and cause pulmonary secondary to the pulmonary arterial hypertension and fasciculates. Tinasolium makes the disease cytocarcinosis after the osteopathomatic and usually discovered during the cardiac surgery or autopsy. The and condition abnormalities of the common cardiac role of antihypnotics and uracil. Summary conclusion. Worm infection are long-term diseases that produce the few symptoms in the early stages and something the serious effect we will develop the stage now or may be quite fatal at the time. Acknowledgement. I get this reference to these websites and especially thanks for my teacher Sinchan Das, Dr. Sinchan Das. Thank you, ma'am.
Thank you, sir, for your presentation. I request the session chair to ask questions, if any.
Because your pronunciation is very poor, and there are lots of wrong word you have used in your communication. So before, from the next time, try to prepare yourself before you're going to present anything.
Okay, sir.
Okay, thank you. Dr. Sonia Sharma, are you there?
Yes, ma'am. I'm there.
Okay. So, addressing motor function deficits in spinal muscular atrophy, HFM-SE analysis. You may start sharing your screen and start with your presentation now.
Yes, ma'am. Hope my screen is visible now, ma'am.
Yes, ma'am, it's visible, but it's the fonts are not clearly visible. Okay, yes, you may start with your presentation, ma'am. Your time starts now.
Yes. So I'm skipping the intro as I've already discussed. Good afternoon, jury members. So the title of my presentation is Addressing Motor Function Deficits in Spinal Muscular Atrophy. I'm using one scale, which is HFMSE, Hammersmith Functional Motor Scale Extended. So SMA is a autosomal recessive neuromuscular disease, which is characterized by motor neuron degeneration. So we have in our body SMN1 gene and SMN2 gene. So SMN1 gene is a gene which is responsible for SMA children. So when there is a deficit in SMN1 gene, then this problem occurs. So SMA arises from a mutation or complete deletion of the SMN1 gene located on the 5th chromosome. And SMN2 gene is basically the best backup gene. The more the number of SMN2 genes are there, the less severe will be the disease. So the types of SMA, there are 4 types of SMA, type 1, 2, 3, 4. So type 1 SMA is, the age of onset is from birth to 3 months. Like they can manifest at the birth also, or from birth to 3 months basically. So description is there, it is also known as Wernicke-Hoffmann disease. It's more severe, characterized by muscle weakness and hypotonia. Death may occur because of the respiratory failure. Then SMA type 2, which is manifested around 6 to 18 months of life, and children are sitters. They are able to sit, but they cannot stand, they cannot walk, often survive beyond 4 years. Then we have SMA type 3, which is manifested between infancy or youth, also known as Kugelberg-Wender syndrome. Milder in form, patients learn to walk unaided, prolonged survival is there. Then we have SMA type 4, which is onset is around adulthood, and some muscle weakness is there, twitches might be there, and tremors may also occur in this condition. Then if we look into the HFMSE scale, which I'm using, it is also known as Hammersmith Functional Motor Scale Expanded. So it has various components, like it has 33 components, and the scoring is from 0, 1, 2. 0 is where the child is not able to do anything. 1 is when the child is able to do the movement partially, and 2 when the child is able to. Yes, ma'am. Hello. Hello, am I audible? Hello.
Yes, you are audible. You may continue.
And two, when the child is able to fully do that movement. So the movements are 33 in segments, but here they have divided overall movements, like the movements which are related to sitting. So we have items from 1 to 4 which are related to sitting. Then we have items which are related to rolling from 5 to 9. Then we have items which are related to transitions and scrolling are from 10 to 17. Then standing and stepping items would be 18 to 20. And then these are the number of segments which I'm telling, that 18, 19, 20 would be covering standing and stepping. Then items 21 to 27 would be covering transitions, kneelings. Squatting and jumping would be covered in the item 28 to 29, and stairs in from 30 to 33. Now, I have taken 21 SMA patients were recruited in study in Sargangaram Hospital. 16 were type 2 SMA and 5 were type 3 SMA. Participants were aged between 2.5 to 34 years. Total score, HFMSC, total score is 66. I have already discussed 0, 1, 2 ordinal scale. I'm also, this is how the HFMSC looks like. 1, 2, 3 items are from 1 to 33, and 0, 1, 2 is a normal scaling, how it is. It is the score sheet of SMA, HFMSC. Then I have made the graph of 21 patients that, so it was concluded from this observational cross-sectional study that more the complexity of the movements, and more will be the challenging the movements, the less the less children would be doing those movements. So here we can see that from the graph that only few the items which are related to sittings and items which are related to rolling were the children were able to perform it fully. And the items which are more related to staircase climbing, standing and walking, children were not able to do it fully, or they were only very few, maybe 4 or 5 out of 21 were able to do it partially. And I have taken the mean of SMA, HFMSC for type 2 SMAs. It was 18.4 with a standard deviation of this 14.6, and type 3 448 plus minus 12.9. Then individual component wise, if I see that the children which are able to do these movements, like sitting movements, children were able to manage sitting movements or sitting items more than the crawling and transitions. And same goes for the rolling. Rolling were also possible with these children, be it SMA type 2 or SMA type 3. But the items which are related to transitions and crawlings, like kneeling, 4-point kneeling, crawling, lift head from supine, or prop on extended arms, these were really very difficult for these children to maintain and do. And same goes for the standing and steppings also. Most of the children were not able to stand or step 2 or 3 steps forward. And the same goes for the stairs and kneeling, jumping, squatting. Many out of 21, 18 were not able to do so. So discussion would be like patients may retain certain abilities such as sitting and rolling for an extended period, but their ability to perform more complex movement may decline as the diseases progresses. Muscle weakness and atrophy were primarily evident in the muscles surrounding the pelvic girdle. So proximal muscles are more involved in this case, leading to challenges in ascending or descending movements or doing more complex transitions. Weakness and wasting of the shoulder girdle and proximal upper limbs were manifested by difficulty raising the arms. These children were not able to raise their arms or do those tasks which requires raising the arms beyond 90 degree of shoulder flexion. Gene therapy combined with occupational therapy or physiotherapy can slow the progress of the disease and provide time for other treatments to be established, potentially changing the game altogether. So there are gene therapies which are coming from 2018. So we have 3 types of treatment, like Spinraza is treatment, and nusinersen is the drug, and Zolgensma which are given as a gene therapy for this SMA. So we are still checking that how these drugs are going, because these are the new drugs, FDA approved drugs. They have just come in 2018. So we are checking that what is the effect of these drugs on the overall progress of the disease. So if we give adjunct therapies like occupation therapy and physiotherapies to the children, so we can get some time for these therapies to change the game altogether. Continuous physiotherapy and occupation therapy are necessary to preserve remaining capabilities in daily life and can help decrease contracture progression or optimize residual range of motion. These are my references. Thank you.
Thank you, ma'am, for your presentation. I request the session chair to ask questions, if any. I request the session chair to ask questions, if any.
Nicely
Okay, so
presented. Yeah.
Thank you, ma'am.
So, moving to our next participant, Biplab Sasmal. Are you there?
Yes. Am I audible?
Okay, so yes, you are audible, sir. Differential study of rectal bleeding. You may share your screen and start with your presentation, sir.
Okay. Good afternoon, everyone. Myself, Biplab Sasman. Today, I will discuss about differential study of rectal bleeding. First of all, introduction. Rectal bleeding is a common symptom in general population. Rectal bleeding is a frequently encountered problem in the outpatient setting. It can have a pathology in the proximal lower GI tract, but it can also be from disease specific like hemorrhoid, fissures, anal cancer, anorectal malignancy, etc. Rectal bleeding present as frank red blood existing from the anus. The presentation may range from the mild to severe depending on the etiology of the bleeding. Mild cases may appear as red blood streaking the patient stool, and severe cases may present as a large volume. Aims and objective. We need the study for accurate diagnosis, treatment planning, and risk assessment of underlying health conditions. Studying of rectal bleeding is essential for both individual health outcome and public health, aimed at the preventing and managing related conditions. Aims of the rectal bleeding. The study aims to determine the causes of underlying causes, determine any associated symptom or risk factor, guide appropriate treatment and management strategy. Objectives of the rectal bleeding: diagnosis of the proper health condition, determine the causes of rectal bleeding, assessment of the severity of bleeding, evaluated the volume and frequency of bleeding to the urgency of intervention and management, prevention of complication, address the potential complication of rectal bleeding such as anemia, infection through appropriate monitoring, for promotion of health and well-being. Material method. It is following a mixed method where literature review has done a detailed survey has conducted with the self-report questionnaire to identify the different study of rectal bleeding. The total number of cases is 63. The male patients are affected 42, and percentage is 67%, and female patients are affected in 33%. Discussion: the sources of bleeding. Anytime the blood from the black passage, this indicated bleeding somewhere along gastrointestinal tract. First, the color of bleeding is the stool. The source of bleeding lower down GI tract. The blood will be bright red in color, and the source of bleeding higher up GI tract, the blood dark in color. Fresh red blood seen in the toilet indicated problem at the anus and GI tract. The most slight causes is hemorrhoid, anal fissure, fistula, etc. The dark red blood mixed the stool suggested bleeding from higher up GI tract. The potential causes is gastroenteritis, inflammatory bowel disease, polyps, etc. Next, I talk about the black stool, the bleeding upper GI tract, the blood digested. The result stool is black in color. This type of stool called is melena. Different types of rectal bleeding. Hemorrhoid, their sign symptoms are bright red blood during bowel movement, anal itching and discomfort, and their clinical features: visible swelling or lumps around the anus. Internal hemorrhoid may not be visible externally but can be felt during a rectal exam. Anal fissures, their sign symptoms are pain during and after bowel movement, cramming around the anus. Clinical features: a visible tear or crack in the skin around the anus, passing large and hard stool. Inflammatory bowel disease, their sign symptoms are abdominal pain, cramming, and diarrhea, sometimes weight loss and fatigue. Clinical features: the clinical features are joint pain, skin rashes, or eye inflammation. Rectal polyps, their sign symptom: rectal bleeding or stool in rectal bleeding or blood in the stool, changes in bowel habit. Clinical features may be detected during colonoscopy and biopsy and determine whether the polyp is benign and malignancy. Conclusion: the evolution of rectal bleeding typically involves through medical history, physical examination, and possible adjacent tests such as colonoscopy, sigmoidoscopy, or blood tests. The differential diagnosis include various conditions such as hemorrhoid, anal fissures, inflammatory bowel disease, and rectal polyps, among others. The early detection and appropriate management are crucial from the determining the underlying causes of rectal bleeding, and implementing timely intervention to address the condition effectively. Treatment approaches may be different depending on the specific diagnosis, but often include lifestyle modification, medication, dietary changes, and some cases surgical intervention. There are some reference, and special thanks to Dr. Sithu for giving me this opportunity. Thank you.
Thank you, sir, for your presentation. I request the session chair to ask questions if any.
Biplab, what is the interrelationship between hepatic pathology and rectal bleeding?
Sorry, sir.
Because you have mentioned here na rectal bleeding.
Yes.
Why the rectal bleeding is occurred? You have mentioned hemorrhoids, you have mentioned fistula, but why the hemorrhoids has occurred? What is the pathogenesis of hemorrhoids? It is not that it is only occurred in the rectum due to injury or etc. There are multiple internal causes also, multisystemic causes, etiological factors also.
Yes.
To specify. Okay, thank you.
Thank you.
Thank you, sir. Next up, we have Manan Patel, scapular motor control training with proprioceptive neuromuscular facilitation in chronic rotator cuff tendinitis, a case report. Are you there, Manan, sir?
Yes, ma'am, I'm here.
Please respond.
Hello.
You may share your screen and start with your presentation.
Yes, ma'am. Is this visible, ma'am?
Yes, sir, it's visible.
The title of my presentation is Scapular Motor Control Training with Proprioceptive Neuromuscular Facilitation in Chronic Rotator Cuff Tendinitis, a case report. Introduction. Shoulder complaints have high reoccurrence rates, and scapular control seems to be a major influencing factor in subacromial impingement syndromes. Scapular dyskinesia disrupts the scapulohumeral rhythm, altering biomechanical loads on the rotator cuff in shoulder movements. As a result, this disturbs the natural healing process. PNF seems to be a promising treatment approach because it has a focus on motor learning. This case report seeks to illustrate the clinical reasoning and feasibility of applying the comprehensive nature of PNF in a patient who was not responsive to standard physiotherapy. Need of study. PNF is effective in improving and maintaining range of motion, increasing muscular strength, power, and increasing athletic performance, especially after the exercise. The scapular patterns defined in PNF are activated within the upper extremity patterns and scapular motions together. Proper function of the upper extremity require both motion and stability of the scapula. Hence, this study will focus on combining PNF with scapular motor training program on chronic rotator cuff tendinitis. Aims and objectives: to assess the effect of scapular motor control training with PNF in chronic rotator cuff tendinitis. Methodology: a 24-year-old male, a professional volleyball player, was diagnosed with chronic rotator cuff tendinitis based upon a rotator cuff tendinopathy, scapular dyskinesia, and inflammation of the supraspinatus tendon. The patient presented complaints of right shoulder pain in overhead activities and in reaching behind the back. PNF-based motor control training was provided over a period of 4 weeks. This approach includes specific PNF patterns, exercises, specific PNF facilitation principles, and the results were improvements beyond the minimal clinical importance, difference, and or minimal detectable change for physical functioning, pain, range of motion, and functional disability of the shoulder. We use the different approaches for the scapular PNF like rhythmic initiation, hold and relax, rhythmic stabilization. The results were improvement beyond the minimal clinical importance, difference, and or minimal detectable change for physical functioning, pain, range of motion, and functional disability of the shoulder. PNF provided an opportunity for motor control training, restoring altered movement patterns in the patient daily life activities and thereby reducing pain. Visual analog skill before treatment, there was 7, and after the 4 week of session, the score is 3. And the other outcome measure we took the WORC, that is Western Ontario Rotator Cuff Index. Before the score is 798, and after 4 week of treatment, it's 654. It was significant level. Discussion. Chronic rotator cuff tendinitis instability has been defined as any functional deficit resulting in pathological motion. Since the patient of this report demonstrates scapular dyskinesia, it is likely that a secondary impingement had been present. Biomechanical imbalances of the scapula as the dynamic base for the most mobile joint in the human body might lead to an abnormal distribution of tension and result in an overload in soft tissues of the glenohumeral joint. Scapular exercise decreases dyskinesia, which might result in a more gradual distribution of tension and load on soft tissues throughout the active movements, thus facilitating the healing process. Conclusion. PNF provided an opportunity for motor control training, restored altered movement patterns in patient daily life activities. The approach addressed motor learning effects and structural impairments. PNF patterns have been described as mimicking functional activities from daily life and from sports. In cases where standard strengthening and mobilization exercise are not effective, a specified PNF
based therapy has shown to be a feasible alternative. Thank you, sir.
Thank you, sir, for your presentation. I request Secretary to ask questions, if any.
Which PNF pattern you have choose for the rehabilitation?
I use ma'am D1 and D2 diagonal patterns in sideline position. That is in D1 pattern, anterior superior starting position, ending position, posterior and inferior depression. And in D2 pattern, posterior superior starting position, ending position, anterior inferior in sideline position.
Okay, so whenever you are applying this pattern, what might be the baseline VAS score for applying this? If the VAS score is 8 or 9, then we can start with the pattern, or something else you are going to do with this?
Ma'am, PNF is it is a passive. So the VAS score which I took is that is in pain is in active movements, not in passive. And I do a PNF is passive.
Okay.
That are diagonal D1 and D2 patterns.
Yeah, okay. Thank you.
Thank you, ma'am.
Thank you, sir, ma'am. Next, we have Nurul Nisha and Kashish. Are you there? Please respond.
Yes, ma'am. We are here.
Okay. So, role of occupational therapy interventions in cognitive disengagement syndrome. You may share your screen and start with your presentation. Yes. You may share your screen.
Yes, ma'am, we are.
Okay.
Good afternoon, all. I am Kashi, student of MOT from Jamia Hamdard, and my topic is CDS. Let's start with the introduction first. Cognitive disengagement syndrome refers to cluster of behaviors that includes cognitive disengagement and motor hypoactivity. The former is reflected as apathy, slow processing, excessive daydreaming, mental fogginess, and the latter is reflected as hypoactivity, sluggishness, and sleepiness. Cognitive disengagement syndrome is also associated with marked impairment in social, emotional, academic functioning, and executive functioning. Now, coming on to the symptoms: low level of energy, lethargic, tiredness, sluggish movements, staring blankly, getting lost in their own thoughts, slow processing, excessive daydreaming, and suicidal thoughts. Causes: age and gender, brain structure and chemistry, alcohol poisoning, ADHD, acute lymphoblastic leukemia, and neuropsychological deficits. Prevalence. Prevalence rate of cognitive disengagement syndrome in autism ranging from 30% to 37%. In population-based study by Mass et al. In 2023, the prevalence rate of cognitive disengagement syndrome was found to be 32% in autism, 27% in ADHD in type, and 18% in ADHD combined type. The prevalence of cognitive disengagement syndrome was 22% during preschool, 29% during early childhood, 41% during late childhood, and 50% during adolescence, indicating the importance if studying cognitive disengagement syndrome during the adolescent phase. Now my co-author Nurul Nisha is going to present further role of autism, cognitive disengagement syndrome and intervention.
Good afternoon, everyone. Myself, Nurul Nisha. I am a student of Master of Occupational Therapy in Pediatrics from Jamia Hamdard. And today I am going to present role of occupational therapy in intervention in cognitive disengagement syndrome or sluggish cognitive tempo. As my co-author already explained about what is cognitive disengagement syndrome, so I am coming directly onto the role of occupational therapy in cognitive disengagement syndrome. CDS involves difficulty in maintaining attention and engagement in meaningful activity. And occupational therapy plays a crucial role in CDS. And as occupational therapists, we use activities which enhance cognitive functioning and improve attention span and develop strategies to manage distraction. OTs help individuals with CDS in adapting their environments to better support their cognitive needs and facilitate participation in ADL. Now, coming on to the impact. There are four major impacts on children which CDS can be seen, such as reduced productivity, performance at work, strained personal relationship, or general dissatisfaction with life. Now, reduced productivity leads to decreased ability to focus and task efficiently. Coming on to performance at work, this includes difficulty in maintaining attention, memory, and problem solving, which impact their performance overall. Now, strained personal relationship hinders communication skills and emotional regulation, which leads to misunderstandings, conflicts, and strained relationship with family, friends, and peer group. Now, a general dissatisfaction with life is associated with diminishing one's sense of accomplishment, joy, and fulfillment, contributing to overall dissatisfaction with life, overall reducing quality of life of a person. These impacts has a reference from Jonas A. 2024, Impact of Cognitive Disengagement Syndrome, a comprehensive review, Journal of Psychological Disorders. Now, coming on to the occupational therapy intervention, first, we concluded the task analysis and modification. Task analysis and modification. In this, an occupational therapist modifies tasks by breaking them down into smaller steps, simplifying instructions, and providing visual aids to enhance comprehension to reduce cognitive overload. And we can, as OT, we can give individual which are suffering from CDS, give activity scheduling which improve their ADL independence and promote and enhance their productivity overall. Next, energy conservation techniques. Energy conservation techniques may include spacing activities, which include rest and activity, which people have CDS have pain cycle, which has activity and overload, and which leads to that unproductivity. By pacing activity, we conclude that the patient is more productive and is more independent in their daily life. And then prioritize their tasks and implementing rest breaks to prevent cognitive overload and preserve cognitive resources throughout the day. Occupational therapists teach energy conservation techniques to individuals with CDS to help them manage cognitive fatigue and optimize task performance. Next is cognitive rehabilitation. Cognitive rehabilitation include memory training exercises, attention building activities, and problem solving strategies to enhance cognitive skills and promote independence in ADL, which has in this activities such as can be used as like flip puzzles, picture puzzles, number countings, sequence activities, riddles, and binning activities can be used to improve cognition. Next is environmental modification. Environmental modification. In this, occupational therapists assess environmental factors that contribute to cognitive fatigue and recommend modification to optimize task and performance. It basically involves organizing workspaces, in minimizing distraction, and implementing assistive technology solution to create supportive environment that facilitate cognitive engagement of the patient. Now, next is education and coping strategies. Occupational therapists provide education and support to individuals with CDS and their caregivers to help them understand the condition and develop effective coping strategies. This includes teaching stress management techniques, relaxation exercises, and mindfulness practice to regulate arousal levels and manage cognitive challenges. Now, coming on to the quality of life. As OT, how can we improve the quality of life of a patient who suffers from a CDS? As occupational therapists can improve quality of life by helping individual develop or regain the skills needed to participate in meaningful activities and roles. As OT, we assess person's abilities, goals, environment, and then tailor intervention to promote independence and well-being because every patient is different. Now, the strategies which improve quality of life can be self-care, productivity, leisure activities, and social participation. Occupational therapists, we provide education and support to clients and their family and empowering them to navigate challenges and maximize their potential. Thank you so much.
Thank you, ma'am, for your presentation. I request the session chair to ask questions if any. So I assume there are no questions. So moving to the next participant, Radhika Vashisht. Are you there? Please respond. Radhika ma'am, are you there? Please respond. Radhika ma'am. Okay, so moving on. Mary Gonzalez Delgado and Mary Fernandez Ovale Grenada. Are you there? Please respond.
Yes, okay.
Okay. Factors related to anxiety in health sectors workers in an institution of Etiquela, Colombia, year 2024. You may share your screen and start with your presentation.
One moment. Okay. Good afternoon and good morning from Colombia. At this moment, it is 3:50 a.m. in Bogota. We thank Alitcom for allowing us this space to present our work carried out with the student and teacher of the Minuto de Dios University Corporation of the Master Degree in Management in Occupational Safety and Health and the Master Degree in the Management of the Health Institution. The name of our study was a factor related to anxiety in health sectors workers in an institution of Antioquia, Colombia, year 2024. The authors are Eduardo Di Mate, Jesús Cortés, María Ovalle, Catherine Pérez, Luis Pineda, Carolina Villalba, and who is speaking to you, Mary González Delgado. The order of the presentation will be introduction, objectives, material and methods, results, conclusion, and reference. To introduce ourselves to the topic, it is important to define what anxiety is. This is understood as a condition in which a person has worry and feelings of excessive fear, terror. Other symptoms include sweating, irritable, fatigue, poor concentration, trouble sleeping, and others. In the sense, the COVID-19 pandemic established the health institution in two countries with fragmented health system and low coverage, lack of policies to protect human talent, generating chaos around the lack of insufficient personnel training in emergency situation and infrastructure deficiency for the volume of patients who require medium and high complicity servers of the health institution that had to assume the media burden of the pandemic, including the effects not only on their physical but mental health. For this reason, one of the greatest effects of the pandemic on the mental health of the health personnel was related to anxiety and depression, and demonstrated by multiple studies where nursing and medical professionals presented higher prevalence that varied between 50 to 69 for the anxiety, and depression varied from 9 to 68%, being among the most frequent related factors, being single, being a woman, not receiving incentives during the pandemic, presence of symptoms associated with COVID-19, and anywhere. For this reason, the objectives of this study were: one, to analyze the factor related to anxiety in the health workers, health sector workers in a hospital institution in Antioquia, Colombia, in the year 2024, and to describe the sociodemographic and work characteristics of health personnel in the health institution related and anxiety in a health institution in Antioquia, Colombia.
Okay, taking into account the objectives of the study described about, a methodology was proposed. A quantitative cross-sectional observational prevalence study was conducted, and self-report questionnaire and sociodemographic and work variables and the big insighted inventory by questionnaire to assess the presence of anxiety symptoms was sent to patient via email. The study population included 648 health professionals from a hospital institution in Antioquia, Colombia. A representative sample of 247 health sector workers following the application of the formula for sample estimated with a reliability of 95% and an admitted error of the 5% was performed. However, to minimize bias, selection and self-selection, 263 health workers were randomly selected. The study subjects were selected by contacting them directly on the workplace, and the instrument was sent to them by a Google form. The former was done with the intention of obtaining a positive response from the workers. Statistical analysis, risk and anxiety estimation with a chi-square test and a Poisson regression model, PRM, relative risk or RR, confidence intervals and p-value than less 0.05 were considered statistics significant. All statistical analyses were performed with SPSS software version 26. In the sample, 76% responded to the family gender with a mean age 31, with the greatest representativeness of section. 48 were single, with the greatest representatives at the technological and technical educational level, 64.4%. 58.6% have children, 64.6%, and the majority are head of the household. Almost a half of the sample belong to stratum 2, with greatest representation of human talent in nursing. Years of work experience of media, 19.34, seniority and the company of median 3.93. The prevalence of anxiety was 5.3% among Antioquia health professionals, mainly women, 64, united of married, 71, without children, 74, head and household, 78%, face-to-face work, 92%. On the other hand, in the bivariated analysis, no statistic significant associated was found, but however, in the multivariate risk estimate to presence and anxiety with high school educational level RR3, not having children
Sorry for
RR2,
interruption.
head of the
Only 2
family
minutes are left. You can conclude your study.
using a computer RR5 was evidence. So, conclusion and in conclusion, anxiety is an event present in the human health talent in Latin America countries, in which Colombia couldn't be the exception, mainly in women in free union or married, without children, among others. The work modality, which must be intervened by programs and strategies led by the commitment of the senior management of the health institution, all supervised by the control entities within the Colombian health system. Once again, thank you for much. Thank you very much for allowing us the space to present our work. We hope it has been interesting for you, and we remain attentive to your question. We copy your email for any communication. Mary Gonzalez Delgado, Minute of God University Corporation, Master and Management and Safety and Health to Work, email. And Eduardo Di Mate Garcia, Minute of the God University Corporation, Master Degree and Management of Health Institutional, email in this screen. So we invited to the register in the Ibero-American network of knowledge in patient safety and to link to the psychosocial risk line in patient safety. You can scan the link to register or write to us at the email you see on the screen.
Okay, thank you, sir and ma'am, for your presentation. I request session chair to ask questions, if any.
No questions from my side.
So I assume that there are no questions. So moving on to the next participant, we have Dr. Preeti K. A unique study of spontaneous non-traumatic gas gangrene caused by Clostridium perfringens. Are you there, Dr. Preeti, ma'am?
Yes, ma'am, I'm available. Am I audible?
Yes, ma'am, you are audible. You can share your screen and start with your presentation, ma'am.
Is it visible, ma'am?
No, ma'am, it's not visible yet.
Wait, ma'am. Ma'am, is it visible?
Yes, ma'am, it's visible. You can go on with the slideshow.
Yeah, 1 minute. Now it's visible, ma'am.
Yes, ma'am, it's visible. Your time starts now.
Yeah. Good afternoon, ma'am, everyone. I'm going to present a topic on unique case of non-traumatic gas gangrene caused by Clostridium perfringens. Coming to the background, Clostridium perfringens are the pathogens mostly known, the commonly associated with the life-threatening infection of gas gangrene. It's predominantly manifest in the skin and soft tissue infections. They are mostly categorized into under 3 categories: post-operative, post-traumatic, and spontaneous. In this, we are going to see like spontaneous non-traumatic gas gangrene, which is caused by Clostridium perfringens. Coming to the case report, it's a 54-year female presented to her OPD with main complaints of swelling over the right foot for the past 4 days. Patient was revealed that she had been in wellness until the 4 days ago. When she noticed that the gradual onset of swelling, she appeared to her OPD, and the patient was admitted for the further evaluation and the management. Coming to the present history of presenting illness, the swelling was sudden onset, progressive in nature, which was accompanied with pricking type of pain, was a past 4 days, and no history of trauma and no other negative histories. Her past history, she was a known case of diabetes mellitus, hypertension, and hypothyroidism for past 27 years. And she had a history of surgery 3 months prior to her current presentation. And she was undergone left below knee amputation due to the uncontrolled diabetes related complications and not a case of bronchial asthma and other long-standing infections. Her personal history, she is on vegetarian diet and normal bowel and bladder habits. And on examination, the patient was conscious, oriented, moderately nourished, and afebrile, no pallor, icteric, and no lymphadenopathy. And the systemic examination was normal. On local examination, swelling measures 5 into 5 centimeter was observed over the medial aspect of the right foot below the medial malleus. The affected area displayed discoloration, skin discoloration, thus indicating that some circulatory compromise or tissue damage, and no visible redness, ulcerations, or open sinus with active bleeding at the site. The affected site was like tender to touch, suggesting inflammation or localized inflammation. And on palpation, the peripheral pulses in the affected area was feeble, indicating the compromised blood flow to the area and raising a suspicion of some vascular insufficiency. There was no apparent warmth in the affected area. And the patient complex medical history and the presence of localized swelling, skin discoloration, tenderness, and compromised peripheral pulses. It is crucial to consider that a comprehensive diagnostic approach. So, suspecting necrosizing fasciitis or gas gangrene and suspected an emergency fasciotomy was performed, and superficial femoral artery endectomy was also done. The sample was sent for culture and sensitivity to our lab microbiological laboratory. The gram stain showed a short, stout gram-positive bacilli without a spores morphologically resembling Clostridium perfringens. And antibiotic therapy has been started, such as clindamycin and meropenem on patients, which has significantly improved. Like injection meropenem is 500 mg per intravenous 12th hourly given for 3 days, and injection clindamycin 300 IV 12th hourly given for 5 days. The relevant investigation results, total count, HP, and fasting, postprandial, RBS, blood urea, creatinine, RFT, CRP, HbA1c, procalcitonin, chest X-ray, and ECG. And was USG Doppler study shows some monophasic flow with forward diastolic component, which is noted in the anterior tibial artery. These are the images, the patient food, the gram stain, and Robertson Cook made anaerobic culture, and this is diagonal plot and reverse camps or strip camp test. Coming to the discussion, the gas gangrene represents a grave medical emergency posing substantial risk to the both life and the limb. And although spontaneous non-traumatic clostridial necrosis, which caused by Clostridium perfringens, remains exceedingly rare because causative agent spontaneous means simply Clostridium myonecrosis mostly caused due to Clostridium septicum. In the review of the literatures, the 49% of the gas gangrene was found to be occurring in the patients after injury or after surgery and spontaneous, as I said earlier. And this is like spontaneous non-traumatic case of gas gangrene. Despite of rapid and usual fatal clinical course and leading to a death within 12 to 24 hours, the case has been reported following a prompt admission or administration of high-dose antibiotics and surgical debridement. As a result, the patient with suspected gas gangrene who are in a severe pain should be given urgent treatment to maximize the chances of survival. It reduces the morbidity rate. Conclusion, the gas gangrene remains a formidable and undoubtedly fatal conditions that demands evoke the recognition and the intervention. Here we discuss the case of non-traumatic gas gangrene, which is caused by Clostridium perfringens. A multidisciplinary approach to the patient care and should diagnose and timely surgical intervention was pivotal to achieving a positive outcome. And additionally, the rarity of non-traumatic gas gangrene caused by Clostridium perfringens emphasizes the need for ongoing research into the mechanism underlying this unusual presentation. These are my references. Thank you.
Thank you, ma'am, for your presentation. I request session chair to ask questions if any. Okay, so I assume that there are no questions.
Thank you, ma'am.
So, thank you. So, moving on with the next participant, Tajal Ahmed Khwaja. Are you there?
Yes, ma'am. I'm here, ma'am. Hello, am I
Documenting
audible?
Yes, you are audible, sir.
Thank you.
Optimizing respiratory muscle assessment in mechanically ventilated patients of physiotherapy perspective.
Yes, ma'am.
Let's start your screen and start presenting.
Thank you. Yes, ma'am. Hello, ma'am. Am I visible now? My PPT is visible?
Yes, sir, it's visible.
Okay, thank you. Just a moment. So as for my title, thank you. Good evening to everybody. As per my title, optimizing respiratory muscle assessment in mechanical ventilated patients at physiotherapy perspective. My name is Sajad Ahmed. I'm a PhD scholar in Jamia Hamdard University. So first, let me go to introduction. Respiratory muscle weakness is commonly present in mechanical ventilated critical ill patients for several reasons. First of all, mechanical ventilator itself makes the muscles weak. Mechanical ventilator is a life support therapy for managing respiratory failure. However, it inherently promotes the diaphragm to rest. Consequently, mechanical ventilator induce time-dependent diaphragm weakness in critical ill patients, referred as ventilator-induced diaphragm dysfunction. This so ventilator itself makes puts the diaphragm at rest and induce the diaphragm in ventilator-induced diaphragm dysfunction. It weakens the diaphragm basically. So this ventilator-induced diaphragm dysfunction is exacerbated by the factors such as ICU acute weakness, neuromuscular blocks, steroids, disease like sepsis, and COPD disease. So as these patients, ventilator patients, they are being routinely treated with steroids, neuromuscular blocks. So which it increases the weakness of these muscles to this ventilator-induced diaphragm dysfunction. Next slide. Now, what are the consequences of this weakness? Consequences of the weakness are it promotes weaning failure, prolonged duration of mechanical ventilation, worsen patient's prognosis. It has been seen a high proportion of patients requiring prolonged mechanical ventilation more than 48 hours, maybe 5 days, 6 days, 7 days, as much it has been prolonged, do not survive for 1 year, and who survive have significantly reduced functional states and quality of life. Thus, measurement of respiratory muscle strength is useful to detect a respiratory muscle weakness and to quantify its severity to determine optimal long-term management. In the light of this early rehabilitation, like mobilization and respiratory muscle training, have been seen. I'm also working on this. Have been seen are safe and effective, and have potential, like it increase muscle strength, enhances cognitive awareness, improves overall quality of life, reduction in ICU stay and duration of mechanical ventilation. However, assessing respiratory muscle strength to initiate a rehabilitation program in mechanical ventilated patients is challenging. Thus, combining multiple tests can improve diagnosis accuracy, such as these are tests like PI max, PI maximum inspiratory pressure, we can measure, which can be measured like it can be directly measured from the software, which is present in some ventilators. Features within the ventilator softwares are utilized. Coaching patient to inhale forcefully against a closed gate during end expiratory occlusion for 20 seconds. So we had to occult the end expiratory value for 20 seconds, and patient is asked to inhale deeply, forcefully, and the reading will come on the screen. PI max, what is NAB, negative pressure, how much is the muscle strength of the patient. And the alternative technique is using a handheld pressure monitor gauge, which is available in the market. The patient is directed to exhale first. First, patient has to exhale for 20 seconds, through a unidirectional value. reaching true residual volume before the maximum inhalation. So before inhalation, patient should be it should be ensured that patient is doing this test from the residual volume. So he has to exhale for 20 seconds. 3 maneuvers are conducted and highest recorded value is selected for the analysis. These are the pictures. This is the with the end expiratory where we can be pressed button and occlusion can be done. Expiratory occlusion will be done and reading will come. This is the handle held which has been directly with the insert connected to the AET tube, and patient asked to first exhale for 20 seconds, then inhale maximum, and the readings will come in this gauge. Second, now interpretation of this test. PI max approximately minus 80 centimeters of water, H2O, typically rules out clinical significance of inspiratory mix. That means patient's muscles are normal if it comes about approximately minus 80. However, if it is above minus 30 of centimeters H2O, it ensures that successful weaning can happen for this patient. So before developing a rehabilitation program or before going for weaning, we should go for these tests because physiotherapists are now vital for weaning patients from mechanical ventilator. Mostly it has been used in most of ICUs. Second is rapid shallow breathing index test. It is a physiological parameter for predicting successful weaning from mechanical ventilation. It's calculated as the ratio of respiratory rate per minute divided by the tidal volume (VT). Rapid shallow now method, it's same like above. It is we can use handle held spirometer connected to ET tube, and the patient is breathes at the room independently for 1 minute without ventilator. Ventilator should be disconnected by that time. Directly it should be connected to the ET tube, or we can take a direct RBS value from the ventilator setting. It's available in some ventilators. Mechanical ventilator, many ventilators include RBSI as a part of their algorithm, displayed in it as one of its ventilator parameters. Now, interpretation of this RBS value below, if it comes below 105, is widely recognized as a reliable indicator for successful extubation of the patient. If it's below 100, if it's above, then it means the patient will not be weaned. So as much it is below, more chances of extubation of the patient. Now the latest is ultrasound. Nowadays, ultrasound rehabilitation professionals are being taught ultrasound, how to do ultrasound, diaphragm ultrasound for the ventilator patients. It is a safe method and it utilizes 2 parameters, diaphragmatic excursion and diaphragmatic thickness fraction. Basically, it's a non-invasive and it's very easy to do. It can be done on the bedside of the patients. And there are 2 parameters we are using, diaphragm excursion and diaphragm thickness fraction. Now, first diaphragm excursion. It is measured by 3 to 5 megahertz probe in B or M mode, it's affected by the ventilator PEEP and the ventilator support. So definitely, if we will measure the diaphragm excursion, patient should be on TPs. He should not be on the mechanical ventilator because the mechanical ventilator force will also be measured with this one. So it should be on the TPs patient. It's limits during the mechanical ventilation. For this reason, we go for diaphragm thickness friction if patient is on mechanical ventilator. Provides a direct contactability during the mechanical ventilator.
Sorry for interruption.
Yes, ma'am.
You are just left with 2 minutes. You can conclude your study.
Yeah, I'm just going. It's last slide. Okay. It provides direct index of the contactability during the mechanical ventilator. It's measured by the 10 megahertz probe, calculated muscle thickness in the zone of openness, especially between the 8th and 9th intercostal space. Its interpretation is by the formula. So we have to measure end expiratory pressure and during the inspiration and during the expiration, and then divided by the thickness and expiration multiplied by 100. It gives the diaphragm thickness fraction. So if this now interpretation, decreased expression if diaphragm expression is less than 10 millimeters is associated weaning. That means weaning failure. Diaphragm thickness, if it is more than 30 to 36%, it's associated with the extubation success. Thank you for very much. Any questions?
Thank you, sir, for your presentation. I request the session chair to ask questions if any.
So, as a therapist, which method you will choose for like assessment?
Yeah, as I mentioned in my PPT. We should choose 2-3 methods. We should not rely on the one method because these are volatile tests where we need the patient's effort. Sometimes patient is weak, he cannot cooperate with you. So definitely we should go for 2-3 methods to confirm our diagnosis of weakness of respiratory muscles.
Okay, fine.
Any more questions?
No, thank you.
Thank you, ma'am. Thank you very much for listening to me. Thank you very much.
Thank you, sir and ma'am. Next up, we have Snehasis Adhikari. Differential diagnosis of hemorrhoids. Are you there, ma'am? Please respond.
Yes, ma'am. I am here.
Sorry. You may share your screen and start with the presentation, sir.
Yes, ma'am. Is it visible, ma'am?
Yes, sir. It is visible. You may proceed.
Okay. So, hello, ma'am. Hello, sir. Good afternoon to all. I am Snehasis Adhikari. Today I will discuss about differential diagnosis of hemorrhoids. This project was helped by Dr. Sincharan Das. Hemorrhoids, also known as piles, are swollen veins in the lower part of the anus and rectum. When the walls of these vessels stretch, they can become irritated. Older age, pregnancy, and constipation can cause piles. 1/3 people in India suffer in hemorrhoids or piles. Around 1 people in 20 in India found hemorrhoids patient. There is my needs and aims. Hemorrhoids have been affecting around 50% of Indian population in different sets. Hence, there has been a need for gross examination and understanding of hemorrhoids in patient. My objective is to exclude the major etiology of hemorrhoids, to identify the type of properties of hemorrhoids, and to evaluate the differential study of hemorrhoids. Here is the methods. Etiology of hemorrhoids. Number 1, pregnancy. During pregnancy, the increasing weight of developing fetus and uterus put pressure on the pelvis. Hemorrhoids may occur in up to 35% of pregnant people. Aging. Hemorrhoids are most common among adults age 45 to 65 years. Hemorrhoids causes mainly constipation. Straining to move a stool puts additional pressure on the wall of the blood vessels, which may result in hemorrhoids. Anal intercourse is another cause of the hemorrhoids. Diarrhea can occur after cause chronic diarrhea. Spending a long time in a seated position, especially on the toilet, can cause hemorrhoids. Eating low fiber food may contribute to hemorrhoids. Repeatedly lifting heavy objects can lead to hemorrhoids. overweight to a higher risk of hemorrhoids. Here is the basic symptoms of hemorrhoids. Number one is bleeding, itching or irritation in the anal area, discomfort, pain or soreness about the anus, lymph and swelling in the anal region, dilation of or bulging of a vein which may or may not be painful depending on where it occurs. Symptoms can be uncomfortable and alarming, but they often improve on their own after a few days. Here is the some preventing process of hemorrhoids, like eating plenty of high fibers food, avoiding straining, going to bathroom when necessary, getting regular physical activity, maintaining moderate body weight. Some complication of hemorrhoids are bleeding, anemia, infection, urinary retention, fistula, and strangulated hemorrhoids when muscles around the anus blocked to blood supply to a prolapsed hemorrhoids. Differential diagnosis of hemorrhoids are like skin tags, anal fissure, anal abscesses, anal fistula, inflammatory bowel disease, genital rats, tumors, etc. Here is the pathogenesis of hemorrhoids. Mainly, it causes the constipation, chronic constipation. So it causes hemorrhoids. Hemorrhoids are mainly two types, external and internal. So internal hemorrhoids are mainly sign and symptoms are swelling, pain, itching, and perianal irritation. And the internal hemorrhoids are have some sign and symptoms like painless rectal bleeding. Internal hemorrhoids are mainly four types: first degree, second degree, third degree, and fourth degree. Internal hemorrhoids have special four types of sign and symptoms like bleeding without prolapse, prolapse with spontaneous reduction, prolapse requiring manual reduction, irreducible, and acute severe pain. Here is the some picture of different types of hemorrhoids. This is my source of this presentation, and I thank our teacher and our guide, Dr. Sinchan Das. Thank you.
Thank you, sir, for your presentation. I request session chair to ask questions if any.
Snehashish,
yes, sir.
Kindly mention what is the basic cause of hemorrhoids, not those factors. What are the pathophysiological cause?
The pathophysiological cause are
You have mentioned
behavioral.
here increased intra-abdominal pressure, where cirrhosis of liver has mentioned, constipation has mentioned, but how these factors are playing the important role in the hemorrhoids?
There are inflammatory reaction or occur, sir.
Then
it causes thrombosis.
No.
Mainly, sir, swelling of veins cause hemorrhoids.
Fine, but what is the other systemic association you can find in the case of hemorrhoids?
The muscle layer of internal anus and rectal area are damaged by the pressure of the stool, and it causes bleeding.
That is fissure. That is your fissure. Okay, thank you.
Okay, thank you, sir. Next up, we have Darpan Manvi to assess the effect of physical therapy on pain and tenderness in T10 syndrome, a case study. Are you there, Darpan, sir? Please respond.
Yes, ma'am. Yes, ma'am.
You must share your screen and start presenting.
Okay. Good afternoon, all. Study of my title is to assess the effect of physical therapy on pain and tenderness in T10 syndrome, a case study. Introduction. There is a limited information about T10 syndrome involving lower thoracic spine related dysfunction, producing lower extremity symptom due to the possible sympathetic nervous system dysfunction and lower thoracic hypomobility. However, we all the radiological findings like X-ray, MRI, and CT scan are absolutely normal, yet the patient complain of asymmetrical radiating pain. It may be diagnosed as T10 syndrome. Physiotherapy has a major role in the play such in condition. Need of the study. Study has shown the effect of medication on symptomatic relief in among patients with T10 syndrome, but there has been a scarcity of evidence which prove the effect of physiotherapy on T10 syndrome. This may be due to the lack of knowledge in diagnosis of T10 syndrome. Hence, this study will focus on diagnosing the condition and establish the effect of physiotherapy on T10 syndrome. M and objectives. The first one is to assess the effect of physical therapy on pain, tenderness in T10 syndrome. Second is to assess the effect of physical therapy on pain among participants with T10 syndrome. And third is to assess the effect of physical therapy on tenderness among the participants with T10 syndrome. Methodology. 32-year-old female presented to the physiotherapy OPD with pain and tenderness over the lower thoracic region, radiating to the bilateral limb, sometimes associated with the paresthesia and heaviness. The radiological investigation like X-ray of spine and MRI revealed no significant pathology. Patient had no other secondary complaint associated with spine. Hence, with the clinical examination, the patient was diagnosed with T10 syndrome and physiotherapy in form of thoracic spinal mobilization, thoracic mobility exercises, local ultrasound over T10 level was administered for 4 days a week for 4 consecutive weeks. Treatment. Each of the exercise was practically demonstrated to the patient. The first one is the ultrasound dosage 1 megahertz, 1.3 watt per centimeter square, 10 minutes. Method of application, water bag method, and area of application is around T9, T10, T11. Second is the facetal joint mobilization. Patient was made to lie in prone position and therapist hand placed over T9, T10, T11 thoracic vertebra, and grade third and fourth of Maitland technique was delivered. 3 sets of 5 repetitions over each vertebra was applied with rest period of 1 minute between each set. Most pack was applied after mobilization to prevent post-mobilization soreness. Third one is the thoracic mobility exercises, in which the first one is a foam roller extension. Foam roller was placed under the thoracic region, and the patient was asked to roll over it from upper thoracic to lower thoracic spine with flexion of bilateral shoulder during upward movement and bring back to the shoulder in neutral downward movement. This was repeated for 15 times, 3 sets with 1 minute rest between each sets. Second is the side lying position, side lying rotation. Patient was asked to lying in supine lying position with above leg resting on in 19 hip flexion and 90 knee flexion. Both the upper limb was kept in horizontal abduction and then asked to perform rotation of the upper body. First on right and repeat on the left side. This was repeated for 15 times. On each side, 3 sets with 1 minute of rest between each sets. Third one is a half kneeling rotation. Patient was asked to take up the half kneeling position, first right and then left, with both the upper limb abducted to the 90 degrees, and then instruct to the rotate upper body toward the right and left side. Results. 4 weeks of physiotherapy, like 16 days of physiotherapy in form of facetal joint mobilization at T9, T10, and T10, T11. Thoracic mobility exercise in which include foam roller extension, sideline rotation, half kneeling rotation, and local ultrasound therapy over T9, T10, and T10, T11 level help reducing the local tenderness. grade 2 and 0. Pain was pre-6 and post-4, relating to the bilateral limb asymmetry pattern that may be also sometimes associated with paresthesia or heaviness and localized tenderness among participants and T10 syndrome. Physiotherapy in form of spinal mobilization, spinal mobility exercise, local ultrasound over T10 level help reducing pain relating to the bilateral limb, sometimes associated with paresthesia or heaviness, localized tenderness, T10 syndrome. Conclusion, there is a limited information about T10 syndrome involving lower thoracic spine related dysfunction, producing lower extremity symptom due to the possible sympathetic nervous system dysfunction and lower thoracic hypomobility. However, clinical assessment and detailed examination of patient help identify T10 syndrome. Also, physiotherapy in form of facetal joint mobilization at T9, T10, and T10, T11, thoracic mobility exercises, and local ultrasound therapy over T9, T10, and T10, T11 level can help reduce patient symptom in just 2 weeks. Hence, physiotherapy should be considered as mainstay of management of T10 syndrome. Thank you.
Thank you, sir, for your presentation. I request session chair to ask questions if any.
So, what might be the cause of T10 syndrome in your case?
Sorry, ma'am.
Why the T10 syndrome is occur in your case? Like, what is the reason that person has developed the T10? What might be the cause?
Decreased mobility. More on
Decreased mobility.
yes. Sitting posture.
Sitting posture and decreased mobility that develop the T10 syndrome
Yes.
in your case.
Yes, ma'am.
So, what might be the other causes of T10 syndrome? Because you have mentioned the facetal joint mobilization. So, not in every T10 syndrome facetal mobilization that is applicable.
Yes, facet joint arthropathy.
Might be there is a malalignment or the disalignment of yes.
Yes.
So, based on evaluation and assessment, like
Rearrangement.
what are the causes? So you need to choose. Yeah. Okay. Thank you.
Thank you, Soren ma'am. Next up, we have Dr. Payal S. Effective tibial nerve neurodynamic sliding technique on pain and flexibility in subject with calcaneus spur. Are you there, Dr. Payal ma'am?
Yes, I'm there. I'm
Okay,
here.
you can share your screen and start with your presentation now.
Okay. Is my screen is visible?
Yes, ma'am, it is visible.
Okay. Good afternoon, respected judges and each and everyone who is present here, right now. Myself, Dr. Payal Bharadwa. My title is Effect of Tibial Nerve Neurodynamic Sliding on Pain and Flexibility in Subject with Calcaneal Spur. Calcaneal spur is a most common musculoskeletal condition of lower extremities. In the studies of published on the 16th August 2016, reported 59% of general population are affected once in their life, that is elder to middle aged. Plantar fascia provides dynamic shock absorption and static support of longitudinal arch. Inflammatory condition is now thought to be a degenerative condition due to repetitive microtrauma occur into the plantar fascia. Recently, Lemont and colleague reported that in non-inflammatory conditions like atrophy and fibrosis have no any evidence found in the plantar fascia. In the plantar fascia, is development of heel pain is thought to be a multifactorial. symptoms of calcaneal spur represent a talocrural dorsiflexion is reduced, pronated foot posture is present, and work-related prolonged weight bearing and high body mass index is independent risk factors in the plantar fascia in calcaneal spur. In advanced age, it shows reduced compressibility and shock absorption capacity in the advanced age, like elder to middle age. Now, most widely clinical feature in calcaneal spur is pain. It can be dull or sharp or stabbing pain. It can be started at first step or after prolonged weight bearing and triggered by prolonged weight bearing in performing most essential functions of daily activities. It also further restricted job related performances. There are many therapeutic uh, modalities, and there are many treatment is available for calcaneal spurs, like ultrasound, laser, joint mobilization, stretching, strengthening, etc. What is my purpose of study is now nervous system is able to adapt mechanical load, and it must undergo distinct mechanical event like elongation, sliding, cross sectional changes, compression, etc. So if the protective mechanism fail, it may cause neural edema, ischemia, fibrosis, and hypoxia, which may alter neurodynamic. In calcaneal spur, altered foot biomechanism, Wendler's mechanism, and weight bearing may affect a neural structure that passing through the foot. It may have a persistent pain in heel. And patient having calcaneal spur reported tightness of calf and plantar fascia. It lead to hypomobility of the joint. And it also altered a mechanosensitivity of the neural structures inflexibility. Neural mobilization technique is used to restore the dynamic balance and relative tissue and surrounding mechanical interference, thereby allowing reduced intrinsic pressure on neural tissues and promoting physiological optimum function. This is my need of this study. Hence, the purpose of the study is to assess the efficacy of neural sliding technique of neural mobilization as a part of conservative treatment strategies for calcaneal spur. Aim of the study to the effect of neural sliding technique over conventional therapy technique on pain and flexibility in patients with calcaneal spur. Objective to find out the effect of neurodynamic sliding on pain and flexibility in calcaneal spur, to find out the effect of conventional treatment on pain and flexibility in calcaneal spur, and compare both the effect in pain and flexibility in calcaneal spur. Hypothesis null, there is no significant found in both group, and alternative hypothesis is there is significant difference found in both the group. This is my review of literature. Materials and methodology. I have taken the all the data from the GMRS Hospital, Yogini, Davalba, Life Care, and Sri Hospital. This is an interventional comparatively study, and I have taken 10 to 12 months for after the approval from the ethics committee. Inclusion criteria: subject those who are willing to participate in giving consent, complaint of unilateral or bilateral heel pain greater than 9 months, patient who is having tenderness on plantar aspect of the foot, age between 30 to 60 years, heel pain which restrict functional activities related to lower extremity. Exclusion criteria: I haven't taken those participants who have a musculoskeletal conditions, neurological conditions, and having a presence of any wound, infection, or skin disease in the foot. This is my proposed sample size. Materials I have used: this plinth, pillow, assessment sheet, and etc. etc. Methodology: 36 participants I have recruited based on the inclusion and exclusion criteria. I have taken a verbal and written consent form. In this, I have randomized participant into the two group by ratio of 1:1. I have taken demographic data, NPRS scale, and ankle range of motion, a pre-intervention and after the day of 3 and day of 6. In first A group, I have given neurodynamic sliding and conventional protocol, and second conventional protocol. In neurodynamic sliding, I have given a two nerve neurodynamic sliding, that is first distal nerve and proximal nerve. Second conventional protocol, in this I have given calf stretching, plantar fascia stretching, ultrasound, intrinsic foot muscle strengthening, standing heel raise, and resisted TheraBand exercises. Outcome measure, I have taken NPRS scale, and for flexibility, I have taken ankle range of motion, that is dorsiflexion and plantar flexion. In statistical analysis, I have taken a PET t-test. Result has shown a significant difference found in the improvement found in the group A compared to group B. This is my paired t-test and unpaired t-test. First group A, range of NPRS and range of motion dorsiflexion. There is a significant found shown t value, and there is significant difference found in NPRS and range of motion in group A. The p value is 0.001 in NPRS, 0.1 in dorsiflexion. Similarly, in plantar flexion. Same in group B, p value is found in NPRS and dorsiflexion is 0.04, and plantar flexion and dorsiflexion p value is 0.01. In within group comparison A and B, the significant improvement found in all the outcome measures. Discussion in the main purpose of the study was to evaluate the effect of neurodynamic sliding technique on pain as a measured by the NPRS scale and ankle range of motion in
Sorry for
kilonewtons per
interruption,
patient.
ma'am. You are just left with 2 minutes. Please conclude your study.
Okay. Conclusion: by implicating neurodynamic sliding technique and conventional treatment in clinical practice as per this study, results both are significantly effective for reduction in pain and flexibility in kilocalories per patient. But neurodynamic sliding can better improve pain and flexibility within short duration compared to conventional treatment. This is the summary that this neurodynamic sliding technique is improves more than group B, that is conventional treatment. This is the reference. Thank you.
Thank you for your presentation, ma'am. I request the session chair to ask questions if any.
Is that you have assessed the type of calcaneal spur in your study?
Ma'am, I have taken according to the inclusion criteria that is greater than 9 months. I have.
Yeah, that is fine, but you have mentioned the now tibial nerve sliding, fine. So
Yes.
is there a dorsal heel spur or the plantar heel spur which has the
Dorsal.
association with the
Plantar heel
that,
spur, ma'am. Plantar heel spur.
that you have included?
Okay, okay, ma'am.
Okay, fine.
Thank you, ma'am.
Thank you. Thank you everyone for being there. Special thanks to Honorable Session Chair for being there and giving valuable time and opinion. The session ends here.
Sorry to interrupt. Ma'am, Gopika has texted you regarding like we have 2 more presentations which are video presentations. Could we continue with the video presentations, ma'am? Does that works?
Yes, you can continue.
Yes, sir. Thank you.
Good morning, everyone. My topic is improving strength of dysphasic muscle with taping therapy, an experimental study. So as all we know, the stroke is a condition in which patients suffer from the motor weakness. That is not only about the movement and cognition in the stroke patient, it is all about the dysphasic muscle. So basically, the silent flight of dysphasia often goes unnoticed, its impact underestimated, leaving patients vulnerable to hidden dangers and prolonged suffering. The hyolaryngeal complex may move less entirely during swelling because of the atrophy and weakness of the suprahyoid muscle, which could lead to dysphasia symptoms such as aspiration and pharyngeal leftovers. Now, clinically, it is important to train or strengthen the suprahyoid muscle during swallowing to improve the mobility of the hyolaryngeal complex. So, for that, we can use the resistant training has shown promise in addressing these issues coupled with kinesiology taping. It offers a novel approach to enhance the muscle activation and improve swallowing function. As kinesiotaping may easily attach to skeletal muscles or either stimulate or inhibit the muscle movement and promote the stability of structures such as ligament, muscles, and joints by applying an external physical force while stretching it and utilizing properties like adhesiveness and elasticity. So this study investigates the combined effect of resistance training and kinesiotaping applications on suprahyoid muscle stimulation, aiming to offer a target therapeutic strategy to enhancing swallowing function in stroke patients. Now, need of the study is dysphasia can have serious consequences if not addressed properly by the physiotherapist and other medical professionals. So it is important that it is treated properly. Now, null hypothesis is there is no significant improvement in strength of dysphasic muscle by application of tapping therapy with resistance training. Alternate hypothesis is there is significant improvement in the strength of dysphasic muscle by application of tapping therapy with resistance training. Now my aims and objectives are: the study aimed to assess the impact of resistance training combined with kinesiotaping on suprahyoid muscle activation in stroke patient. An objective is kinesiotaping combined with resistance training activate the suprahyoid muscle, enhancing the muscular activity during swallowing. Now, material methodology. So basically, study design is an experimental study. Research location: multiple hospitals and clinics of Vadodara, Gujarat. Study durations 2 weeks. Sample size is 20 subjects. Sample method is random convenient sampling. Blinding is double blinding, and there is a single group only. Now, what material I used is consent form, pen, pencil, diary, paper, kinesiology tape, Caesar's laptop, numerical pain rating scale, and dysphagic severity scale as an outcome measure. Now, inclusion criteria is individual of the age of 20 to 40 years, acute stroke patient with dysphasia, both male and female is involved, individual who are willing to participate in the study. Now, exclusion criteria is individual diagnosed other than stroke, individual with psychosomatic disorder who are not able to understand the commands, any structural abnormality of the respiratory system, uncorrected left and palate or cleft lip, taking treatment to control drooling, and general contraindications include malignancy, infection, cellulitis, open wound, deep vein thrombosis, and a previous allergic reaction to kinesiotaping. Now, procedure. So basically, individual screen 53, total patient is screened. Now, after 53 is participant selected based on the selection criteria. So out of 53, only 20 participant is selected. The procedure of the study was explained and written consent was obtained from all the participants. Baseline assessment was done with all the outcome measures. Patient received treatment for total duration was 2 weeks. Post-intervention assessment was done after 2 weeks and data was collected and statistically analysis was done using SPSS version 20 with the help of a statistician. Now, application of kinesiotaping. So basically in this, we take one I tape and one Y tape cutting, and before we first we apply the I tape over the neck region with available cervical range of motion, and kinesiotaping was pulled downward with 10 to 80% from hyoid bone and joined to anterior cervical. Additionally, a reverse Y-shaped tape was applied from the hyoid to the sternocleidomastoid and placed the horizontal I-shaped tape to stabilize the taping. Now result. So baseline data is There is a 14 male and 6 females, and the mean age is 34, and you can see the pre and post NPRS, and we can see here the significant improvement in the both NPRS also and dysphasic severity scale also. So here the mean NPRS was 3.05, standard deviation is 2.235, and p value is 0.1. And for the dysphasic severity scale, the mean value is 4.25, standard deviation is 1.618, and p-value is 0.001. So interpretation is both in NPRS and SDS's score shows significant improvement in post-intervention as indicated by the low p-value. On average, participants experience a decreased pain in levels and an improvement in the dysphasic severity after the intervention. The DSS score had a higher mean and a lower standard deviation compared to NPRS score, suggesting that the dysphasic severity measurements were more consistent among participants compared to pain ratings. The study suggests that the taping treatment intervention may have contributed to improvement in both pain level also and the dysphasic severity among the participants also. The discussion. The study goal was to ascertain how well KT works in dysphasic patients who had a stroke. The evidence was to support its usefulness and with possible benefits like enhanced swelling performance and decreased aspiration risk, and the statistical test yield a positive significance value, indicating that the data shows a substantial improvement in the suprahyoid muscle strength. The research indicates that applying KT to the front of the neck at a tension of 10 to 80% along with resistant training and swelling exercise is more beneficial. The study shows more reliability as the test was conducted with one certified kinesiotherapist and who applied KT and one other therapist who worked as an assessor, which measured the outcome, which made the study more significant to the or it less probability of bias. In the study, we faced challenges while applying the kinesiotape due to unsuitable texture and difficulty in sticking of the hyoid muscle group. Along with that, it was cost causing. Now, in few cases, the patient unwillingness to give consent did not allow us to conduct the study, which leads to small number of sample size. The tape applied to muscle group was to remove and reapply on every third day of treatment. But in some cases, due to perspiration and during bathing, the tape used to come out. This study need increased duration and the time intervals along with the increase in sample size or small sample size with only 20 patients. The study sample size is relatively small. Small sample size can limit the generability of the finding and increase the risk of sampling bias. A more extensive and varied sampling would provide more robust evidence regarding the effectiveness of the therapy. Lack of comparison group. Without a comparison group or control condition, it's challenging to determine whether the observed improvement are solely attributable to kinesiotaping therapy or if other factors may have influenced the outcomes. In conclusion, this study shows the effectiveness of kinesiotaping therapy with resistance in dysphasic stroke patient. The study shows significant improvement while using kinesiotaping with resistance training in dysphasic stroke patient and also improve the strength swallowing performance with decreased aspiration risk through induced muscle activation. So this is about my topic. These are my references.
So this presentation is by Dr. Varga Sharma, and which was on a topic of improving strength of diaphragm muscle with taping therapy. And the next presentation is by Dr. Joel on a topic of exploring the impact of accelerated muscle activation through step training. Just give us a moment, sir.
Good morning all. I'm Joel Tejpal. My topic is exploring the impact of accelerated muscle activation through strap training on cadence on patients having stroke, a randomized control trial. As stroke is a leading cause of the long-term disability worldwide, and often resulting in the impaired motor function as well as in the gait disturbances. Rehabilitation intervention plays a crucial role in enhancing functional outcomes for the stroke survivors. Among these interventions, step training has gained attention for its potential to improve gait parameters such as cadence, which is closely linked to the mobility as well as independence in the daily activities of the patients. However, the specific impact of step training on muscle activation and its subsequent influence on cadence in patients having stroke remains relatively unexplored. So this experimental study aims to investigate the effect of accelerated activation through step training on cadence individual recovering from the stroke. The need of this study is step training has emerged as a promising rehabilitation strategy for improving gait parameters in stroke survivor. By focusing on repetitive step exercise, this approach will aims to stimulate the muscle action, enhance motor control and retrain gait patterns. So, therefore, there is a critical need for empirical research to investigate this effect of the step training of the cadence in stroke patients. Hypothesis, null hypothesis is there is no significant difference in cadence between stroke patients undergoing step training and those receiving the alternative care. An alternative hypothesis is stroke patient undergoing step training will demonstrate a significant increase in the cadence compared to those receiving a standard protocol. So the aim of the study is to assess the effectiveness of structured step training intervention in improving cadence, a key gait parameter crucial for the mobility as well as independent in the patients having stroke. Objective is, first of all, assess the changes in the cadence following a structured step training program, investigate the relationship between accelerated muscle activation and improvement in the cadence, and to explore the feasibility and acceptability of the step training as a rehabilitation intervention for the patients having stroke. The materials and methodology. Inclusion criteria: subject must having a confirmed diagnosis for the subacute as well as the chronic stroke. All the territories of the stroke has been included. Age group 45 to 65 years has been mentioned. Male and females will be both included in the study. Participants should have the ability to ambulate independently or with minimal assistance. Subject willing to participate. Exclusion criteria: subject having severe motor and cognitive impairment, those who is not able to understand the commands, subjects who is having other neurological conditions like Parkinson's or any other, those who are having other medical conditions like uncontrolled hypertension or other, and subjects involved into the other treatment protocol. The study design is an experimental study. Random convenient sampling has been done. The 40 subjects with the subacute and chronic stroke has been added. Among that, 6 were dropped out due to the illness and due to the uncomfort reasons. The total were males would be 18 and females would be 16. The study has been done around 6 months. The material which has been used in that is a consent form, assessment for Bozo ball, the step pitch, measure steps as well as the stopwatch. The procedure is, there are three different protocols has been given to the patients. The first of all, exercise protocol which will be given as in fast muscle activation with a stepping training, that is given in the experimental group. Exercise, first of all, exercise which has been given as in squats. 30° of the hip and knee flexion as fast as possible will be performed by the patients. 5 sets of repetitions, 5 seconds of rest between each repetitions, and 30 seconds between each set will be done. Another second exercise protocol for the stepping training is simple block practice, that is stepping leading with each leg with the alternative leg. 2 sets of 60 repetitions and 10 repetitions per set has been done. The second is semi-random practice, that is stepping leading with each leg in each directions. 5 sets of 5 repetitions in that. Then random practice will be given. That is also given in the Bozo wall. Stepping leading with the dominant leg into all these 3 directions. In that also 5 sets of 5 repetitions will be done. So total 75 repetitions with each leg would be performed. Random nomination, the therapist randomly nominates the lead leg. Like patient can choose, therapist will be telling and patient will be choosing that, and they will be performing the exercise. In that 20 steps with each leg in all the 3 directions. Concurrent task planning, that is simple concurrent cognitive task. Repeat all previously mentioned stepping exercise. And this oil exercise needs to be performed till the 4 weeks of protocol. So here the result concludes. We'll be seeing, you can see the graph of the male and female ratio. Then the pre and post data of the cadence. The sample size was 16 for that. The minimum and maximum range. So in an experimental group, the mean difference was around 5.875 and the standard deviation difference is 3.283. The test statistically T was significant with a p-value less than 0.01, which is less than 0.05. So it is a highly significant value. So we can conclude the post measure we have a good significant treatment approval and the effectiveness of the treatment is there in improving a cadence. So here we go with the discussion, and the same thing has been done with the control group. In control group we had gone with the normal treatment along with the stepping training, balance training, grip training, stretching and strengthening exercise protocol has been given to the patient. So in control group also the patient is having a good improvement with the cadence as well. So the discussion will be including, so this study will be aimed to evaluate the impact of fast muscle activation through stepping training on reactive postural control in individuals with diabetic neuropathy. This is a 4-week intervention program which was designed to measure the various outcome parameters. The analysis of this result revealed a significant improvement in both the groups, in control group as well as in the experimental group, highlighting enhanced reactive postural control and even increasing the cadence. Consequently, this study concludes that the implemented intervention effectively contribute to positive changes in these key aspects. A pivotal factor in diminish the occurrence of the falls and averting fall-related injuries in the incorporation of the balance training exercise, as the cadence and stepping will be more important for the patient for having stroke. So Ahmed and Verma stated that balance training activate the mechanoreceptors which is present into the Golgi tendon as well as in the muscle spindle as well as in the responsive joint capsule. This will be increasing the sensory feedback from the foot, ankle as well as from the trunk. Furthermore, in supporting with this article, the Hidayati et al. Noted that improving the balance to strength exercise will be linked to the activation of large and fast muscle twitch activation, and that will be stimulating the muscle spindles as well as the Golgi tendon. This increases will be helping into the better coordination of the muscles, tendons, and those will be stimulating a more contraction activities. This is how the flexor and extensors will be having a good co-contraction, and this is how it will be helping to improve the cadence into the patients. So the result demonstrate that participation in a structured step training program lead to significant improvement in cadence among stroke patient compared to the standard care. Limitation is small sample size has been done. Conclusion, as it has a good significant effect is there. And with the future research, we can go with all this limitation. We can go for the larger population. We can add on other parameters like the postural balance, trunk balance, stability, even the dynamic and static component of the gait can be also checked by this. These all are the references for this article. Thank you.
Thank you, sir. That was the last presentation of our day. On behalf of BioLeaks, I would like to express my gratitude and give the vote of thanks. Thank you is such a prayer that cannot be seen or touched. It must be felt by heart. I feel honored and privileged to get the opportunity to propose a vote of thanks on this special occasion. I would like to thank all the honorable dignitaries, committee members, and invited speakers, session chairs who blessed us with their presence. I am also thankful to all the attendees of both the days of the conference. If time is money, then today you have spent million for us. Thanks to all of you for making this event successful today. Thank you. All the participants and all the attendees will be getting the certificates in 2 to 3 working days to your registered mails. Thank you. Have a nice evening. Thank you, sir.